Good morning, everybody. Our National E-Conference on Labor and Birth, which was planned and worked upon in a month's span to be executed today, has received a registration of over 600 delegates from all over India and also abroad. We have a lineup of stellar speakers who took out their valuable time from their busy schedules to enlighten us with their talks. This National E-Conference has been awarded 2 KMC points and 10 ICOG points. We also have free scientific papers and posters that are being judged since 2 days, and we have had around 64 paper presentations and 142 poster presentations so far. Because of the high number of registrations, we had to extend it by another day for exclusively judging these residents. Today's talks will be starting from 9 a.m. The first talk is by Dr. Shaijush Nair, who will be talking on how to choose between VBAC versus repeat cesarean section. The second talk is by Sarita Agarwal on the topic overview of various birthing positions. The third talk is by Dr. Chandrasekhar Murthy. He will be speaking about OSS, the third and fourth degree tears. The next talk will be by Dr. Anisha Gala on the topic of role of instrumental deliveries in modern obstetrics. These talks will be in the first session. The second session will start at around 11:30. We have 3 speakers for the second session. Dr. Rekha Ratnani, who will be talking on PPH and obstetrician's nightmare. The second talk by Dr. Purnima Jaidev on conduct of labor in COVID-19 pandemic. Third talk by Dr. Virendra Kumar, breech delivery, how confident are we? After a lunch break, we will be having the interesting panel discussion where we have various panelists who will be discussing on case scenarios. The e-poster and paper judging competition will start at around 3:15 sharp for until 4:45, and then we will have the valedictory function starting at 4:45. The winners of the e-poster and paper competition will be announced before the valedictory function. So please stay tuned. Good morning, everybody. With a new day comes new strength, new possibilities, new hopes, and new opportunities. After a very energetic and successful day 1 of the conference yesterday, we have come to day 2 of the conference. For joining us anew today, you have logged in to the National E-Conference on Labor and Birth organized by the Department of Obstetrics and Gynecology, KVG Medical College and Hospital, Sulya. I, Dr. Akshata Rao, final year postgraduate, Department of Obstetrics, would like to welcome our President AOLE and Medical Director, KVG Medical College and Hospital, Dr. KV Chidananda, all the members of our management, our Dean, Dr. Neelambikai, our HOD and Organizing Chairperson, Dr. Geeta Doppa, our Organizing Secretaries, other committee members, respected department HODs, delegates in the conference, and my fellow PGs for joining us on board this journey of learning. We have a lineup of awe-inspiring speakers today who have taken out their time from their busy schedule to enlighten us with their talks. Without much ado, let's get into the talks. The first session for today will have 4 talks. First talk is by Dr. Shaijush Nair. The chairpersons for this session are Dr. Vidya Thobbi, Professor and HOD, Department of Obstetrics and Gynecology, Al-Amin Medical College, Bijapur. She is the chairperson of Food and Medico-Surgical Equipment Committee, FOXY, and honorary treasurer of Kasoga. Our second chairperson is Dr. Kasturi Donimat, Professor and HOD, Department of Obstetrics and Gynecology, KIMS Hubli. She is the Secretary General of Kasoga. This session will be chaired by Dr. Geeta J. Duppa, Organizing Chairperson, Professor and HOD Department of Obstetrics, KVG Medical College and Hospital, Sulia. I request the chairpersons to introduce the speakers and take over the session. Over to you, ma'am.
Yeah,
Vidya ma'am and
good
Dr.
morning.
Kasturi ma'am.
Yeah, good morning, everyone. I welcome you all, and I thank Dr. Geeta for inviting us, myself and Kasturi Dodimat. I'm very glad to introduce Dr. Shaizes, who is very close to me and close to my heart, and he's a very good academician. He's a chairperson elect of Midlife Management Committee, FOXY, and chairperson research committee of Kerala Federation of Obstetrics and Gynecology, KFOG, and he has got to his credit many awards. So if we go on reading the awards, I think it will take another 15-20 minutes. And he's very good speaker, and he has got many other qualities also. So Shaizes will be talking today on, I think, vaginal birth after cesarean and the previous cesarean. So over to Dr. Shaizes, and after your talk, let us have some comments from other co-chairpersons. So Dr. Shaizes here. Okay.
Thank you so much, Vidya madam. Such a pleasure to be introduced by you. Such a privilege to be here today. Is my screen visible?
Yes, sir.
Yeah. Lovely to be the opening batsman for the day 2 of this wonderful national e-conference on labor that is being conducted by KVG Medical College. Thank you so much, Geeta madam, for this invite and making me a part of this lovely 2-day program which attempts to unravel the mystery behind problems related to labor. And big thanks to the head of the institution, Dr. Neelambige, as well as the organizing secretaries, Dr. Ravikant and Dr. Bhavya, and to the entire team.
He's more bothered about that Veena Shankar, no?
Which I can see on the brochure. So big thanks for making me a part of this lovely, lovely program. So let me just get on with my lecture. Now, this is the topic for the day. TOLAC versus planned repeat cesarean delivery. For people who are not used to this terminology, TOLAC is trial of labor after a cesarean section. And obviously planned repeat cesarean is something which you all know. Now, this is a debate which has been going on for long. And I would say that it's a never-ending debate. And it is good to debate because every year when we talk about this, we come out with something new. We come out with some better evidences, which actually helps the clinician in you makes a better decision. So let the debate be never-ending. Let this be a very hotly debated topic ever. And hopefully we can make some good decisions on the mode of delivery for such a patient with good scientific discussions. Now, I've always felt that in a conference or a webinar, when people talk about this topic of how to choose the mode of delivery in a post-cesarean pregnancy, there are primarily two schools of thought. The first school of thought comes from the minority, but they are the speakers at conferences, people including me, who are relatively experienced. They are generally very skillful, some evidence-based individuals, but many of these senior people who actually talk about the evidence, most of them have the luxury of a big team in a tertiary care center. The other voice comes from the majority, which is the logically thinking obstetricians working in single consultant hospitals in the big or small towns of the country. Okay, now, which one do I belong to? I would say I neither belong to either of them because there is a cliche. I would undeniably say that the most important thing, irrespective of how much ever we talk about evidence and science, the most undeniable thing is the logic of the obstetrician working in the periphery. And the best decision is the one taken by him or her based upon the available resources that he or she has got in the work setting which he is a part of. So let's get on. We're talking about a scenario where there is a post-cesarean pregnancy and we want to choose and give her options about mode of delivery. We have two options primarily. One is about going into labor and attempting for a vaginal birth, which is what we call as trial of labor after cesarean or TOLAC, or she could have a planned repeat cesarean delivery. Whenever we are recruiting a patient for a planned TOLAC, it could either result in labor and end up in a vaginal birth, which is what we call as VBAC, or she could end up in an unplanned intrapartum emergency cesarean section. So remember that TOLAC is not the same as VBAC, and a VBAC is one of the outcomes of a planned TOLAC. I would say a successful outcome of a planned TOLAC, the other outcome being an unplanned emergency cesarean delivery. So we have a planned TOLAC group, a repeat cesarean group. Planned TOLAC could end up in two of the outcomes, either a successful vaginal birth where we call it a VBAC or an unplanned intrapartum cesarean delivery. When it comes to the decision making, there are a few factors which obviously you need to consider. In these days of increasing medico-legal problems, patients' personal preferences are given a very, very important value. Number two is the obstetric history of the patient, which are the factors related to the previous cesarean, as well as her comorbid factors now in this pregnancy, which helps you to choose your patient for VBAC well or choose your patient for TOLAC well. You should be talking about the data of the risks and benefits of TOLAC versus a planned repeat cesarean, and most importantly, whether the availability of TOLAC in the selected birth setting wherever you're working, including the anesthetic facilities and the ability to take up for a cesarean section immediately as you have made a decision. Fine. For the patient, it's primarily two major concerns. There are two questions which she would ask you whenever you give these options. One is, what are my chances of a successful VBAC? And your answer should be anywhere between 60 and 80%. Second question is, what are my chances of a scar rupture? You should tell her that on an average, it is between 0.4 to 0.7%. So 60 to 80%, 0.4 to 0.7%, the two answers which the patient would seek, and you should be able to tell it very clearly. Now, medicine these days is a game between benefit versus risk, isn't it? And the medical and the obstetrical benefits of TOLAC are primarily the avoidance of the risks of a repeat cesarean. And you know that these risks are primarily related to the number of cesareans that she has undergone. More number of cesareans, more is the risk. Yes, I am talking about additions, which could involve the bladder, the bowel, with a definite inherent risk of ending up in a visceral injury, difficulties even to enter the peritoneal cavity, difficulties to deliver the baby, and a whole lot of problems. Sometimes it is so very difficult and a nightmare to even enter these abdomens. So the risks of multiple cesareans are significant. Now, coming on to the other aspect, which is the medical and the obstetrical benefits of a planned repeat cesarean, are primarily about avoiding the potential adverse outcomes of a trial of labor, isn't it? You know that there is an increased risk of post-operative wound infection related to an unplanned intrapartum cesarean due to a failed TOLAC, possibility of postpartum endometritis, a small but a definite risk of scar rupture. As you go on, remember that benefits of TOLAC, that is trial of labor after cesarean, are very closely related to having a successful vaginal birth. That means you need to choose your patients well. Why am I saying that? I'm saying that because the morbidity levels for the mother are least when the patient ends up with a successful VBAC. The morbidity levels are moderate in a planned repeat cesarean group. And most importantly, the morbidity levels for the mother are maximum when she plans for a TOLAC and ends up in an unplanned intrapartum emergency cesarean section. So this is why I say that you need to choose your patients well so that you almost always end up almost 60 to 80% chances of ending up in a successful VBAC is there. That is how well you need to choose your patients. Where does the evidence come from? 2010 guidelines on National Institute of Child Health and Human Development. They sat together and looked at all the available evidence related to TOLAC. Their primarily aim was to make recommendations for practitioners so that they can decide on the right mode of delivery. Before we actually get on with what the evidence said, you should always understand the limitations of these evidences. Number one, no large randomized trials are available to compare a TOLAC data versus a planned repeat cesarean group. Very important. Number two, there was a systematic review, which actually identified 2 randomized trials, but involved only a total of around 320 women with very minimal data on maternal and infant clinical outcomes. So whatever 2 randomized trial we had very less number of patients as well as very minimal data on maternal and infant outcomes. There were many case control and cohort studies which have reported good amount of maternal and neonatal outcome data. But the problem was they were based on the actual route of delivery rather than the intended route of delivery. You know what I mean? A patient was kept for TOLAC. That means a trial of labor, okay? And she delivers by a cesarean section. So her data was calculated along with the planned repeat cesarean group. A patient was kept for planned repeat cesarean. She ends up in a vaginal birth. She goes into labor and ends up in a vaginal birth. Her data was tabulated along with the vaginal birth group, and that creates a lot of bias. And number 4, very important, women actually did not want to go through the randomization process to choose their mode of delivery. So they did not want to be a part of the trial. So that's why randomized trials were very less. And because of the lack of intent and the inability for many women to go through the randomization process, they had to step in with another strategy called propensity analysis. Propensity analysis is a statistical method in an attempt to replace randomization. Though I say it can replace randomization, it does not replace it very well, but it is the best available alternative that we have. So most of the evidence that talks about TOLAC versus planned repeat cesarean is based on propensity analysis rather than on randomized trials. So what does the data say? For the mother, the rates of endometritis and operative injury are lower for the planned repeat cesarean group. For the baby, the incidence of respiratory distress syndrome and newborn infection rates were lower in the planned repeat cesarean group. The rates of hysterectomy and wound complication rates were obviously higher in the planned repeat cesarean group. If you want it in very, very simple numbers, I would say that the authors estimated that almost 62 women would have to go through a planned repeat cesarean to prevent 1 maternal adverse outcome of TOLAC. And 43 women will have to go through a planned repeat cesarean to avoid 1 neonatal adverse outcome of TOLAC. So these are numbers which can help you in counseling. 62 cesareans to avoid 1 abnormal maternal adverse outcome. 43 cesareans to avoid 1 adverse neonatal outcome. If you look at scar rupture and look at a hypothetical group of almost 1 lakh women of any gestational age who goes through TOLAC, there would be around 468 uterine ruptures. Simple words, 1 in 200 TOLACs may end up in a uterine or a scar rupture. On the other hand, people who are kept for a planned repeat cesarean, 1 lakh women, there were incidentally some 26 uterine ruptures. That means 1 in 4,000 planned repeat cesareans may encounter a uterine rupture. So that numbers can tell you the comparison. 1 in 200, 1 in 4,000. Okay. 62 cesareans to avoid a bad maternal outcome. 43 cesareans to avoid 1 neonatal adverse outcome. These numbers can really help you in counseling. Now, the other outcomes of a uterine rupture is the possibility of ending up in a hysterectomy, possibility of ending up in a perinatal birth. But thankfully, there are no maternal deaths reported. That means, in simple terms, scar rupture may lead to the death of the baby and morbidity for the mother. But mortality for the mother generally does not happen because an intervention generally happens before that. If you look at the infection rates, the overall rates of infection are similar for both TOLAC as well as PRCD. But remember that VBAC, the successful outcome of a planned TOLAC, has the lowest frequency of postpartum infection when compared to a planned repeat cesarean. And at the other hand, The unplanned intrapartum cesarean delivery has the highest frequency of postpartum infection. Again, telling you that you have to choose your patients well. Peripartum hysterectomies are primarily done for uterine rupture in cases of TOLAC and for adherent placenta for patients who were posted for a planned repeat cesarean. People talk about pelvic floor disorders, especially in days of women empowerment. People are worried about their pelvic floor, and they feel that if they undergo a cesarean section, they can avoid all the potential risk and sequelae of pelvic trauma and pelvic relaxation disorders related to labor and childbirth. But remember to tell them that the absolute benefit of planned repeat cesarean versus vaginal to prevent pelvic floor dysfunction is still unclear, and add on to the fact that pregnancy itself is a risk factor for future pelvic relaxation disorders. So just by doing a cesarean, that does not keep your pelvis intact and prevent pelvic relaxation. You getting pregnant itself can be a risk factor for future pelvic relaxation disorders. Now, many a times there are so many reasons why women choose for a repeat cesarean or a vaginal delivery. But convenience becomes a very, very important factor these days. And as you all would agree, the benefit of a planned repeat cesarean is that of a scheduled delivery. It allows her and her family the ability to make very specific work-life plans for delivery and postpartum period, which you would all agree, and we need to respect that, because most of the present generation mothers definitely require help from someone else to bring up their baby. Especially if they're working, there's no need to further underline that fact. Now remember, you might argue that even in TOLAC, you can plan your induction and make it predictable. But remember the golden rule that the best success for a planned TOLAC comes when the labor is spontaneous and not when we induce. So you should take it that PRCD is going to be more predictable and TOLAC is going to be a little bit unpredictable. Now, personal benefits which people say about VBAC would be a shorter hospital stay and quicker return to normal activities. But I'm sure many obstetricians would oppose to that and would say that they can discharge their patient on second day or third day after a cesarean section also, and hence can actually help them achieve and get back to normal return even after a planned cesarean if it is indicated. Now, postpartum sterilization is a very, very minor point in support of cesarean delivery, and you should not actually entertain it because there are good contraceptive methods and there is a very easy way of doing a lab sterilization, even as a daycare procedure. Even for patients who have delivered vaginally, you can do it later on at the end of 6 weeks or so. Coming on to perinatal morbidity and mortality, these rates obviously are higher for TOLAC when compared to a VRCD. These are the numbers of perinatal mortality rate and neonatal mortality rate. But remember, though we talk about these numbers, the absolute risk of the baby ending up in a problem is actually very low, even with TOLAC. Now comes the use of bag and mask ventilation and TTN. Very important aspects. As you would expect, the use of neonatal bag and mask ventilation was more in babies delivered by vaginal route, that is TOLAC, than by babies delivered by cesarean. But remember this point called transient tachypnea of newborn. Okay, that was found to be more for babies who were delivered by cesarean section. Now, why does transient tachypnea happen? Transient tachypnea happens because of retained lung fluid. Okay, because of retained lung fluid. Whenever the baby delivers vaginally, prior to vaginal delivery, there is a cortisol surge in the body. And that cortisol surge helps in reabsorption of all the retained lung fluid from the baby's lungs. Okay, so the baby comes out of a vaginal delivery with the least amount of retained lung fluid, and that is why the baby delivered vaginally ends up with very less amount of TTN. But for the baby planned for a repeat cesarean, you take out the baby so very fast, baby has lot of retained lung fluid and ends up in ICU, probably just for this entity called TTN. So incidence of TTN is significantly higher for babies delivered by a cesarean section. Now, is there a way to modify your cesareans to reduce the incidence of TTN? Then I would honestly advise you to have a look at this technique. Now, this is named after me. It's called the Scheid's technique of cesarean section. And fortunately, we could make it appear in the British Journal of Obstetrics and Gynecology in the year 2011 with our case series. Now, a very, very simple technique. The basic difference is I use uterine contractions to deliver the baby rather than me pulling out or pushing out the baby. Okay. So immediately after giving spinal and the patient is kept in the dorsal position, I start an oxytocin infusion. 5 international units at 32 drops per minute, equates to around 18 to 20 milli international units per minute. 5 units oxytocin, 32 drops per minute. Make the uterus contract. By the time you open your abdomen, reach the uterine cavity or the uterus would be very actively contracting. You make the incision and the baby would actually come out just with the help of the uterine contraction. So this is a technique where the uterus would push out the baby for you rather than the anesthetist or you yourself giving very bad fundal pressure. Okay, now just look at this. Fine. So after giving the uterine incision, just lift the baby's head and allow the baby a surface to slide on. Palmar surface of your index and middle fingers provides the area to slide. Very clearly note that there is no fundal pressure. Anesthetist is also admiring your way of delivering the baby from the leg end. And the uterus is contracting and pushing out the baby for you. Okay, that's how easily the head can come out. This was a previous 4th cesarean after previous 3 cesareans. Okay, 4th post-cesarean pregnancy after previous 3 cesareans. Okay, now the advantage of this particular technique is that the uterus hugs upon the baby's chest, squeezes out the lung fluid much better. So incidence of TTN can significantly be reduced, and that is one significant benefit. Okay, now if I can pause it here, as I told, we found that in our case series, the incidence of TTN was almost nil because here was a contracting uterus hugging upon the baby's chest and squeezing out the lung fluid through the oral and the nasal cavity. So the retained lung fluid obviously was less. That was the benefit for the baby. Benefit for the obstetrician obviously is no fundal pressure and very easy delivery. No more non-engaged heads. All heads are engaged because you have already made the uterus to contract and push out the baby. And number 3, for the mother, it is almost 50 to 60% reduction in the blood loss at a cesarean section because you're working on a uterus which is already contracted. Okay, fine. So just continue looking at it. After delivering the head, you just have to lift up the baby, allow the uterus to contract and expel out the baby by itself. Now just see how beautifully the uterus can help you deliver the baby rather than you pulling out the baby. That is what you see generally. See that there is no action at the anesthetist end. Okay, no fundal pressure. Nobody sitting across the patient's chest and pushing out the baby for you. This is otherwise known as the baby's walkout technique. Baby would kick the uterus back and come out of the uterus comfortably and so actively. And at this point, also note that the placenta is here, almost very clearly seen, almost separated by now. And by the time you finish your cord clamping and get back to the site, you will see the placenta would also come out by itself. Okay, so that's how it is. Now, these are some of the data which I've already mentioned. And before I finish, let us look at why women choose for one mode of delivery over the other. Okay, now most common reasons for women to choose a TOLAC are: one are for those women who have future pregnancy plans. They know that multiple cesareans would increase their risk of adherent placenta and also placenta previa. So they don't want to go through that. Many have family obligations, want to get back to a normal routine very fast, and they feel vaginal route is actually the best possible way for that to happen. Number 3 is the desire to have a vaginal birth. And trust me, even women of this present generation want to experience a vaginal birth. She was robbed of her opportunity for some reasons in the first pregnancy, and she doesn't want that to happen again. So she wants to go through a TOLAC. Number 4 is the desire to get her partner involved in labor and childbirth. Okay, because that cannot happen probably with a cesarean. And in vaginal delivery nowadays, partners are allowed in most labor rooms, I believe, and that's the way to get her partner in. Now, why women choose for PRCD? Most important is scheduling convenience. It's a predictable mode of delivery. You can fix up the time and date and ensure that you get enough amount of help whenever you require. Women didn't want to go. Women had fear of a trial of labor, and they told the obstetricians that I may have to suffer the pains of labor. And then if I end up in a cesarean section, I have to bear the pain of a cesarean section also, as well as the post-operative discomfort. So they didn't want to go through those twin pains. Some women were so afraid of labor pain, so they wanted to totally avoid it. So went for PRCD. And women also claim that sterilization can be done together. So that's why I prefer a planned repeat cesarean. Now the take-home messages are very simple. One is for the mother, the rates of endometritis and operative injury are least with a planned repeat cesarean. For the baby, incidence of respiratory distress syndrome and newborn infections were lower with a PRCD when compared to a TOLAC. VBAC obviously has a lower frequency of postpartum infection than PRCD, but remember that an unplanned intrapartum cesarean section has the highest frequency of infection, so choose your patients well. Rates of hysterectomy and wound complication rates were higher with PRCD. Remember the numbers. Chance of scar rupture after TOLAC in is 0.4 to 0.7%. 1 in 200 TOLACs can end up in a scar rupture. 60 to 80% of well-chosen patients can end up in a successful vaginal birth. But finally, knowing all the signs, make the logical decision with scientific knowledge based upon the availability of resources at your particular setting and what comes out after the discussion with the patient and the bystanders. So the logic of the obstetrician working in the peripheral center is undeniable. He is the boss, and his discussion with the patient and the bystanders with sound scientific knowledge of all this data that I've mentioned should be the best way to decide the mode of delivery after a cesarean section. I hope I've been able to convey my message. Thank you so much for a very, very patient listening and for tuning in on this good Sunday morning to listen to this talk on mode of delivery after a cesarean section. Thank you so much.
Thank you, Dr. Shaizas. It was a wonderful talk, and your Shaizas technique is very popular amongst many of the obstetricians. And I think I remember long ago you had sent me that video, and I have tried on 1 or 2 patients, but many times what happens in fetal distress, we cannot use your technique. That's it. But otherwise, it is very good technique, and it prevents. It acts as an active management of 3rd stage of labor, like that also. So it prevents lot of bleeding as well. So it was a wonderful talk, and as you told that it is always the obstetrician's dilemmas and it is always the patient's decision. And cesarean deliveries on maternal request and the urban areas, they are very common. We always find that we cannot have that WHO standards and we cannot keep up at 15% rates. But as an obstetrician, we always try to counsel the patients, and many times it may not be possible. We have to have a Caesar audit in every institution so that we look into what is going wrong and where we are going wrong. So in COVID areas, of course, the cesarean rates are skyrocket high. But even then, I feel that we should judge it very carefully. I want any comments from my co-chairperson, Dr. Kasturi, who has also joined in. And there are no questions in chat box because I think it was the first session. But if you stay back, Shaizas, if you're free.
Yeah, there are questions, ma'am.
There are some questions.
Yeah, there are questions. Yeah.
Okay.
Yeah.
I
Kasturi,
did not
ma'am.
see, but you can, Geeta, you can take over.
Yeah. Kasturi, ma'am. Yeah.
Excellent talk, Shajish, as usual. Or every time he comes out with a very, I feel he's a very innovative person. Not only in academics, in all other things. I am a good friend of him, and I know he's a very talented, multi-talented and multifaceted person.
Thank you so much.
Excellent. Regarding just one point, so that people follow that, regarding your technique of Shaji's technique, that 5 units of interstellar, we have done a good number of cases, and we have presented paper also on that. This was after I heard your talk in, I think, one conference in Bijapur. And excellent. We have done a number of cases. I'll tell you, TTN is very less, as you told. And then extraction is so easy, it's like playing. You need not worry. You're not dependent on the anesthetist and all to push all that. I think everybody should follow his technique. It's except for those some contraindications, you can rule out that, and all other cases you can do. As you told, all are engaged only. And as all of us know that when a patient in labor and in a elective, the difference in the baby outcome and also the extraction, all those benefits you'll get when you employ your technique in a plan. One more thing, just I wanted, regarding hysterectomy, when we give them TOLAC, do you all routinely take consent that they may end up in hysterectomy?
Basically speaking, there are 2 ways of looking at it. One is these are high-risk patients who might actually end up in a hysterectomy as a life-saving procedure. So rather than leaving it all to a situation where there is panic and then somebody has to in an emergent way run out of the OT, meet the bystanders, tell that the situation is very panicky, and now you give a consent. It is always much better to inform them prior about the possibility and tell them very clearly that the risks of ending up in a hysterectomy are actually very less. But for the sake of the procedure, for the risks involved, you need to make it a part of the consent making whenever you take up a patient for a TOLAC or probably a planned repeat cesarean also, because incidence of adherence is increasing, because it's not just about uterine rupture. I think adherent placenta is becoming really, really significant now. And unfortunately, even today, many are getting missed in the ultrasound scans that are done during pregnancy, and many are being found out for the first time at the on table. So I think put together all these risks, it is much safer for us to take that consent for a hysterectomy as part of the consent for a cesarean section.
Yes, even I totally agree with this, because we have faced a situation. Once I remember some few years back, the patient was allergic to TOLAC, and then because of certain rupture, she was shifted to OT, and on table she ruptured, and it was very bad rupture, and patient attenders gathered outside and they told, we are not going to give consent for hysterectomy. At any cost, we want the uterus. And our assistant in the middle of the night, she called me, madam, they're telling at any cost they want the uterus, they're not going to give consent for hysterectomy. So I rushed to the OT, somehow retained the uterus with great difficulty, though she had some broad ligament hemorrhage. So much, with great difficulty, we retained the uterus because the patient attenders never, because they told, you never told us, So
The only point, madam, is that for a life-saving purpose, even if you actually do a hysterectomy without a consent, also it can still be argued upon in the court of law. But this situation where patient with a post-cesarean pregnancy is being taken up for a TOLAC or a PRCD, a consent for hysterectomy is a must prior to that.
Thank you. It was really very excellent, and I request everyone to adopt his technique. At least you start adopting. Excellent, because it's my experience, own experience.
Okay, we have a question here from Dr. Megha. Any specification in consent for repeat planned C-section? Any important points in consent for TOLAC?
Basically, I think we probably should be consent should be, what do you say, two important components. One, if you're planning for a TOLAC, obviously it should include the consent. I mean, the facts about scar rupture, which you already mentioned, and the associated comorbidity, the consequences of a scar rupture, of ending up in a hysterectomy, and even problems related to the baby. The other aspect is for a planned repeat cesarean, we obviously need to talk about adherence. And all adherence may not be picked up in an ultrasound, so you might actually have to anticipate the surprise finding of an adherent placenta on table, the possibilities of adhesions involving the bladder and the bowel, the possibility of visceral injuries that can happen during a planned repeat cesarean. So all those components need to be included.
I'm listening.
Thank you, sir, for the excellent presentation.
Thank you so much.
You're welcome.
We move on to the next speaker. Now the next speaker for the day is Dr. Sarita Agarwal. She'll be talking on overviewing of various birthing positions. Dr. Sarita Agarwal will be introduced by our chairpersons.
Okay,
Welcome, Sarita. Welcome.
Hi, good morning.
Good morning.
okay, I'll introduce. Okay.
You introduce. Kasturi.
Dr. Sarita Agarwal is a very well-known personality. I don't think so she needs much introduction. She has worked a lot in FOXI and ICOG. Presently, she is a professor and head of the Department of OBG at AIIMS Raipur. And she has served as Vice President FOXI 2015, ICOG Governing Council member and chairperson of HIV committee. And she has done so much of work when she was a chairperson of HIV committee and she has brought out many guidelines during her period. And she has organized more than 30 sensitization workshops on HIV and AIDS all over the country, and 15 basic laparoscopy workshops as Vice President Foxy. And she is involved in many research activities with ICMR and many others. And she has achieved so much, but I'll not take much time. Now I request Dr. Sarita Agarwal to talk on birthing positions, the various, the overview. Actually, this is a little neglected topic. So we are looking forward to hear to this birthing position, because in India we don't give much importance to that. Over to you, Dr. Sarita.
ಕಳಿಸಿದೀನಿ ಅವಳಿಗೆ ಡ್ಯೂಟಿಗೆ ಹೋಗಿದ್ದಾಳೆ ಆದ್ರೂ.
Okay, mute.
Yeah. Very good morning to one and all. And thank you for this kind word. And I thank Dr. Geeta for giving this opportunity to me. And I don't know how she came to know about me. And the topic allotted to me is like a very good topic and very practical topic. So I love to share this topic. That is alternate birthing position overview. And when we talk about the alternate birthing position, why we talk about? Because the labor is considered as the most dangerous journey of a woman ever undertaken. And it is the worst journey in the world as defined by Apsley Cherry et al. In 1922. And everyone deemed the obstetrician and the mother both that at the end of the delivery, the mother should be healthy and the baby should be healthy. And further, now the concept of respectful maternity care, which is especially stressed out upon the 7 rights of the women, which every postgraduate must know. These are the 7 rights of the women. And one of such rights is choices and preferences, that we should respect the women's choice, what she wants. And among these choices, the one choice is the right to have a liberty to move during labor. She has a right to choose to have a companion, either can be the husband or can be the birth companion. And the one most important is the right to choose the position for the childbirth. And providing due care for the emotional needs and the comfort is the responsibility of every midwife or the obstetrician taking care of a woman during the labor. So when you talk about the right to choose the position of the birth position, you can just have a case in the medical legal also in 2016. The Caroline Malestita won a landmark court case in Alabama when she has sued the hospital that the hospital nurse forcibly turned her onto her back during her delivery, and the hospital was awarded a penalty of $16 million. Because the forcing of the women into care providers' preferred position is being described as the obstetric violence. We are lucky that in our country we don't have such cases till now, but with this is one which is the women's right. Therefore, the concept of alternate birthing position needs to be understood by each and every postgraduate, and the maternity leave maternity ward should be implemented. The most traditional position used by almost 80% of the hospital in India now is the lying on the back, maybe dorsal position, maybe recumbent position, semi-recumbent, or the lithotomy position, which is the most popular position. Why actually we prefer this position? I think the PGs are not allowed to speak. Otherwise, I would have asked how many have heard about the alternate birthing position and how many have they practiced it. It comes to be very few. In the US also, this was discussed in the medical school, and none of the students were aware about the alternate birthing position. And this is the most important reason that why the traditional birthing position is being enough. In the other alternate position, there have been the part of the curriculum is the standard traditional position of lying on the back or the lithotomy position. And of course, it is the most comfortable and most convenient to the care provider. It is easier for the caretaker to look at the abdomen, look for the fetal heart rate when the mother is lying on the back. If you want to give an epidural, again, the epidural procedures, after the epidural position, patient lies on the back and finds her comfortable. But when you go for the upright position, patient will not be able to stand up and the hospital may have limitation for the caregivers and the less number of caregivers can be there. Further, if you want to carry out the instrumental delivery or the vaginal birth, it is much easier in the back on back position. And of course, if you want to inspect the perineum, it is easier to do it in the traditional back position. But just look at, if you want to take out the catcher from this bottle, would you like to keep the bottle like this, lying? Of course, no, because the gravity doesn't work. And the same happens when you're delivering the patient on the back position. You miss the gravity of the push, gravity effects on the pushing, and because of that, the labor may be prolonged. Further, on back position, the gravid uterus presses on the aorta and the inferior vena cava, and thereby decreases the fetal circulation and increases the risk of fetal hypoxia. Further, the alignment of the uterine axis and the pelvic axis is not as efficient as in the upright position. Therefore, the efficacy of contraction is less. Further, the researchers have also found that the back position or the supine position of delivery increases the risk for postpartum urinary incontinence, specifically the stress urinary incontinence. So, considering all these facts, the alternative birthing position definitely has certain advantages, and how? There are the several physiological reasons which I described were not available when the woman is delivering the supine position. That is the upright position, gravity is there which helps in the bringing of the baby, and therefore it can shorten the duration of labor. There's less risk of compressing the mother's aorta, and therefore the better oxygen supply to the baby, and the heart rate variation may be less when the patient is delivering in the upright position. Similarly, the uterus contracts more strongly or more efficiently and help the baby to get in the better position to pass through the pelvis. Apart from that, the MRI has shown the dimensions of the pelvic outlet becomes much wider in squatting and the kneeling position, all four position, which is very well studied by the Gupta et al. In 2017. And further, if you look at the maternal satisfaction score in the various studies, it leads to be more positive birth experience for the women who deliver in the alternate birthing position. There are the Cochrane reviews also, which shows that the shorter duration of labor by 29%, and there's a risk of emergency cesarean section is reduced, 21% reduction in the episiotomy rate. There's a reduced need for the epidural and also the analgesics during the labor. And based upon this, most of the maternal position other than the supine position have shown to have the potential benefits in promoting the optimal maternal and the fetal outcome. So what are these positions? The positions are typically classified in two ways. One is the upright position or in the non-upright position. I will be taking all these positions one by one in detail. The other way of classification is the flexible sacrum position that takes the weight off the tailbone, and second is the non-flexible sacrum position where the mother's weight lies on the tailbone. Now you can just understand, we very well know that the patient goes in the second stage of the labor. When the sacrum goes back, the outlet diameter increases by 2 centimeter, and the sacrum forward, the diameter is 11 centimeter. When the sacrum goes back, the anteroposterior diameter is 13 centimeter. So now you can think which position can be better, either the backline position or the upright position. So the position that takes the weight of the sacrum allows the pelvis to expand and ease the delivery of the patient. So coming to the first position, that is the upright position. In the upright position, the woman is standing. She may be walking. She may be swaying. Simply, she should be in vertical position. While she is swaying, she can take the baby on her hand. And that gives the most comfort to the patient during the woman during the labor. Therefore, the advantage of all the upright position is there, that it can encourage the baby to move deeper into the birth canal with the effect of the gravity, the contractions are more efficient and the back pain is less. The partner can massage her back when she is standing. There is all methods have some disadvantage like that. The upright position, the disadvantage, the women with a high blood pressure cannot be allowed in the upright position, and a telemetry unit may be needed for the continuous monitoring if you need a high risk pregnancy. And the another most dangerous is the women remain unattended, then the risk of baby falling down is there. Therefore, this position demands for a continuous presence of one healthcare provider or the nursing or the partner to be there when patient is laboring. The second position is a squatting position. When the mother, I think this is a position used in the rural areas long back. The patient just sits on the toilet seat and then she delivers the baby. And the easier deliveries, easier births are there. The pain is less, and therefore most of the time the women use this position when she's late in the labor or during the labor, maybe the early stage. She can intermittently sit down in the squatting position, and this can be the partner sitting on a chair can give the support, or she can be just hanging on a birthing bar and then she can give the squatting position, or she can take the support of a chair and sit in the squatting position. So the squatting position has several advantages. It definitely helps in widening the pelvis and then give more room for the delivery of the baby. But the disadvantage, sitting in the squatting position may be a difficult on the mother's part, and it can become tiring if she sits for the longer time. So the intermittently this position is being used by many mothers during the labor. Then the sitting on a cushion birthing chair with a U-cut. This is quite commonly practiced in many of the centers. And here this is, you can see that ordinary chair can be cut like that in the U-cut, and the patient can sit. It should be well cushioned. So the patient should not have a pressure effect when she is sitting on this chair. When she is sitting on the chair, she can rock backward and forward, and that helps in relieving the pain. And similarly, the husband sitting on the back can give a back massage, or the birth companion give her the back massage. So this is one good position. The squatting position advantage is there because in the sitting position also, the pelvis is being opened up. The advantage of upright position, that the gravity works over here, and the patient is sitting, the fetal monitor can be very well applied. So the problem is not there in this patient, and it is much comfortable for the women to deliver in a U-cut chair with the delivery. Now look at this birthing ball, which is a common gym ball available anywhere. This chair balls can be kept in the labor room, and the mother can lean forward like this and rest in between. And when she is about to deliver, she can just sit on this ball, and the obstetrician sitting over here can deliver the baby with the wide end of the leg. So the birthing ball position again is very comfortable for the women, but of course one support system is needed. So she should be able to make the balance. Then there's a special type of stools are being designed, which is called the birthing stool position. Again, these birthing stools have the U-cut, and this U-cut can help the delivery. The woman can sit on the widened leg, and the obstetrician sit here like this, and the patient can be delivering. And when she is not in the active pushing effect of the second stage of the labor, she can just relax herself by leaning on the table, this birthing stool, or just putting one leg supported over this stool, and then she can deliver very well. And this table can be kept used for the water birth also, and water birth time this can be put on the water tub, and this can be again used. So it has an advantage of both sitting and the squatting position. So it has an advantage of sitting and a squatting position both. Now this is the lunging position, the most commonly taught thing on the gym. Just one leg is forward with the knee bent and the lying flat. So here it is not a classical gym position. Here what the woman does, she just put her leg over a stool or the chair with the knee bent and the flat. And then when there is a contraction, she just leans forward and then goes back. Leans forward and goes back. And this way she can have a relaxation, and the pain during the labor may be much less perceived with the women in this lunging position. And all the advantages of upright position is also there. Here again, you need a partner or the birth companion to help us during the labor. Now coming to the sideline position, this is like modification of the standard supine position where the woman lies on her side, and when she is not actually laboring, she can just put a pillow between these two legs. But when she labors, she has to widen the leg, and the obstetrician sitting by the side can deliver the patient. The advantage of this position is that the mother is lying on not on the back, so the pressure of the aorta and IVC is not there, so better fetal circulation is there, and therefore the heart rate variation may be less, and the indication for cesarean section is less when the patient is lying comfortably on the back line, on the lateral lying position. And again, the back massage can be given, and it is easier method to relax during the contraction. I'll suggest all the PGs when they are delivering the patient, when the patient is not on the active second stage of the labor, till she comes to this stage, she should be made comfortable on lying either on the left lateral position or on the right lateral position, which gives a maximum comfort to the women. So this is the sideline position. Now this is the all four position. We are all are taught in the shoulder dystocia management. The women lies on the knees and the arms, and that helps the women to deliver the patient because it widens the pelvis, and it helps provided more space in the pelvis during the delivery. And this has been taught when you're delivering the shoulder dystocia. So in this position, again, you have the advantage of the upright position as well as the advantage of a sitting position. The only problem with this position is that when you're there for when the woman is there for the longer time on her arms, she may be feeling tired. So intermittent hand and knees position may be there, or at the time actually when she is delivering, in the second stage, this all four position is quite useful. Reclining position, again, very commonly used. The head of the woman is raised, but it has got the disadvantage of all the supine position, because you are just now aortic pressure is there, but the patient is quite comfortable in this position as well. Now the most awaited topic for all the postgraduate, what is the water birth? I think water birth or the hydro birth, it is now quite old, and even in the India, in the few centers, this facility is available where the women gives the birth on the tub of the lukewarm water. Why it is useful? It is said when the baby is delivering, it comes out from the water tub. It is just like, and the baby feels the environment is exactly same as the amniotic sac, and the baby is quite comfortable. Then when your patient is on the water tub, the delivering method can be two. One is the hands-off technique and the hands-on technique. In the hands-off technique, the obstetrician or the midwife sitting doesn't do anything, just the baby comes out at its natural method, as Dr. Saizes was talking about during the this VBAC also. You don't have to put much effort. The baby comes out, takes its own speed of delivery. Even the mother herself can help the delivering of the baby. So the obstetrician's hands are off. In the hands-on technique, the obstetrician help the delivery of the baby by to stop the spontaneous rapid birth of the baby. Now this can be a choice which method to be used, which method to be practiced, the hands-off technique or the hands-on technique. Now comes how you're going to monitor the patient when she's in the bathtub. So the specially designed waterproof continuous monitors are also available in some of the hospitals, and this can be used. Otherwise, intermittent auscultation is sufficient, and I think it is a low risk women. The intermittent auscultation had lots of advantage, and the continuous electrical fetal monitoring itself poses the increased risk of cesarean section. We all are aware about that thing. The water bath has definitely a certain benefits. It increases the woman's energy. The buoyancy effect lessens the mother's body weight and allowing movement and the new positioning. The buoyancy effect further promotes the efficient uterine contraction, and it also improves the fetal blood circulation. Therefore, the more oxygen to the baby. It reduces the stress, how the pain is being relieved in the water bath. It reduces the stress-related hormone and therefore allows the release of the endorphin, and which actually works as a pain inhibitor. Perineum also becomes more elastic and relaxed, reducing the incidence and severity of tearing So there are so many advantages which has been very well elaborated in many trials, including the Cochrane review, and they found that the women who are in the water birth, the need for the analgesia, the need for the epidural is much less. The duration of first stage is less than average by 32 minutes. Even there is some study would describe the duration of second stage is also significantly reduced when the woman is laboring in the water birth. But of course, there are certain risks with the water birth. That is, the theoretical risk of water embolism is there, but it has been rarely noticed. The British Medical Journal says there can be a risk of aspiration of the water by the baby, but if you look at the logically, the baby doesn't breathe till it acquires the air. So when the baby is delivering in the water tub, till it is being exposed to air, it is not going to get the aspiration of the fluid. So another concern is that the umbilical cord could snap if the baby floats in the water and come onto the surface, but this is again a very rare evidence. There are certain contraindications for the water birth, the maternal infection like genital herpes, breast presentation, and there's excessive bleeding, the multifetal pregnancy, the preterm labor, and the preeclampsia patient, the water birth is usually not indicated. Now you may be asking, after so many positions, which labor position is the best? My dear postgraduate student, there is little evidence that any one position is the best position. No one position needs to be mandated or prescribed as per the ACOG. The overall observational study says the women spontaneously assume many different positions during the course of the labor, and the many of the observational study has shown the women in the first stage and the early second stage of the labor, they resume some other position, and then at the time of the birth, many obstetricians prefer that the patient should be in the back lying position only, so that gives them comfortable, because this has been taught in the literature and they are not very well prepared about how to deliver when the patient is standing, sitting, or in the squatting position. So the frequent position change enhances maternal comfort, and optimal positioning can be supported with the appropriate maternal care. I just came across to learn about the 3 stages in the second stage of the labor when I just looking the literature says that the second stage is further divided into the passive phase, the active phase, and the actual birth phase. So during the passive phase, actually the head is descending and it is rotating and there's no bearing down effort. In the active phase, actually the patient starts perceiving the bearing down effort, and it is also known as the reflex phase. And then the third stage is an actual birth. So if one can understand this concept, the patient can still be resting when she is in the passive stage, and only during the active stage, when there's a desire for the pushing, the patient should be allowed to push, and that is going to provide the maximum relaxation to the women during the birth process. So I think this all concept has been very well supported by many of the evidences, the Cochrane trial, the meta-analysis. I'm just not reading all this trial. If anybody wants to read, then they can just go through the evidence-based birth, and you can get this data of the alternate birthing positions very well supported, the comparison of the non-upright position and the upright position. The comparison is also available for the squatting position versus lying backline position, and there are the n number of literature for the water birth is also available. So just to end up my talk, the certain take-home message is that the alternate birthing position gives the women positive birth experience and has got lots of physiological benefit. Each method has its own advantages and disadvantages. Therefore, one has to look for this, and one has to be very much trained about this and understand which women should be allowed in which, but the patient's comfort is most important, and a prior counseling of the women definitely help us which position she is going to opt, and if she's aware of the various position during the labor, she can choose which position makes her more comfortable. And given the evidence and the ethical guidelines, it is being shown by, it has been dictated by WHO in 1996, the Royal College of Midwives, the Royal College of ACNM, that is American College of Nursing and the Midwife. They have given the clear guideline that the medical schools and the residency program should begin training medical students and resident physicians that how to support women in various birthing positions. So they should not have an apprehension at the end, as they have not been trained about the alternate birthing position, which are much better than the standard backline position. So this is very important. The curriculum should include the alternate birthing position. And my lecture is over. I just want to get an excuse to start with my one video. Can I just take one video? How to go for the sharing of the video? I want to minimize. How to minimize this presentation?
On your laptop only, Sarita.
Mm,
Minimize it.
I'm not getting to minimize. I just want to, I'll just stop
Ma'am,
sharing.
double click on the screen. Double click on the screen, ma'am.
Okay, but if still no.
Video is not playing, I think, no? After double
I
click.
just, no. I'm just stopping my sharing and then coming back to share my screen with the video open.
Yes, ma'am, that will do.
My screen, can you see my video?
No, ma'am.
Yeah, I got it.
Ma'am, you may have to go back to Zoom. Yeah, it's coming.
It's coming, no?
Yeah.
So I have to yeah. So I just want to show a video on the alternate birthing position. What happened? This everything is.
Y'all don't mute me. I will control my own muting, unmuting. Ma'am, we are not able to see the video.
Yeah. We are not able to see the video. In the meanwhile, she uploads the video. Dr. Geeta, can we take some of the questions? Can you read from the chat box? I think Dr. Ravi.
I think she is logged out, ma'am. She must be able to hear us. I think she is logged off and she's playing the video.
Okay.
My mobile. Take this. Just try.
Yes, madam. Yeah. Hello, madam. Okay. Okay. You want to log in later, madam?
Few questions are there.
हो गया उससे ज्यादा अच्छा होता है, ज्यादा अच्छा होता है.
Questions are there.
Okay. Thank you.
What happened? Dr. Sarita has logged out. Huh?
Network issue is there. She has asked to start with the next speaker, and after that she'll take our questions.
Okay, no problem.
With the next speaker.
So can we have the next speaker, please?
Yes, Dr. Chandrasekhar Murthy, our next speaker. I request our chairpersons to introduce our next speaker.
Yeah. Can I have his CV, please? Yeah. So, yeah. So welcome Dr. Chandrasekhar Murthy, who is a consultant urogynecologist and head of the department of OBGYNs Hospital Pinia. He is presently chairman of Scientific Committee of Urogynecology Kasoga, Karnataka State of Obstetrics and Gynecological Association, and he has conducted many live operative workshops at state as well as national level as a faculty. He has got many publications in fourth and national one and international journals, and he has presented many national and state conferences. So Dr. Chandrasekhar Murthy is very well-known urogynecologist, we all know. And now today he will be speaking on OASIS, that is and third and fourth perineal tears, what are the implications and how to manage them. So over to Dr. Chandrasekhar Murthy. Welcome, sir.
Hello.
Hello.
Yeah. You can start, Chandra.
Thank you for your kind.
You have to unmute, Chandru.
Madam. Share वो करना है.
So we have Dr. Chandrasekhar Murthy, sir, who will be talking on OASIS, third and fourth degree tests. After this session, we'll take the questions from Dr. Geeta ma'am.
Thank you for your kind words, madam. At the outset, I would like to thank Dr. Geeta madam for giving me this opportunity. And I want to congratulate them for conducting this e-conference on labor and birth. So my topic for today's presentation is third and fourth degree perineal tears management. Madam, is it coming?
Your screen is not shared.
It is shared, madam.
We are not able to see your slides, sir.
Yeah, we are not able to see your slides.
Okay, 1 second, madam. So, share. Zoom over. One second, madam. Share. Desktop ಹೋಗ್ತದೆ ನಮ್ದು. ನಮ್ಮ ಡೆಸ್ಕ್ಟಾಪ್ ಹೋಗೋದು. Desktop presentation.
So our speaker is sharing his screen. Yeah, we are able to see your slides.
Banta?
Now we are able to see, Chandru.
Okay. Yeah.
Yes, we are able to see now. Slides, so you have to make. Okay.
Yeah, the rate of anal sphincter injuries has tripled from 2000 to 2012. In England, it was 1.8 in 2000, whereas it is 5.9 in 2012. So the overall incidence in UK is 2.29. Compared to multipare, the incidence is high in primipare. The reason for increased incidence from 2000 to 2012 is not mainly because of increase in the rate of injuries. It is increased because of recognition. The rate of recognition has been increased from 2000 to 2012. So then what are the risk factors for this anal sphincter injuries? Asian ethnicity, nulliparity, birth weight more than 4 kg, shoulder dystocia, occipito-posterior position, prolonged second stage of labor. They are the actual risk factors. And with respect to the instrumental delivery, Ventouse without episiotomy has got more risk in comparison to Ventouse with episiotomy. Likewise, even for forceps with episiotomy has got less incidence of anal sphincter injury in comparison to forceps without episiotomy. So these are few images of identification of injury to the sphincters. So this is the internal anal sphincter. this is the external anal sphincter. We are holding it. So this is complete. This is 4th degree perineal tear. Can you make out this tear in the rectal mucosa? Yeah. Okay. Then what is the classification? Classification of this perineal tear. So 1st degree tear is injury to the perineal skin or to the vagina. 2nd degree tear is injury to perineum involving the perineal muscles but not involving any sphincter. 3rd degree, in that it is included the sphincteric damage. 3rd A is for less than 50% of the external anal sphincter thickness is torn. In 3rd B, more than 50% of the external anal sphincter is torn. 3rd C is both external anal sphincter and internal anal sphincters have been torn. 4th degree is injury to the anorectal mucosa along with these damages. So this is the photo showing the degree: 1st degree, 2nd degree, 3rd degree, and 4th degree. Okay, can this obstetric anal sphincter injury be prevented? Okay, so yes, it can be prevented up to certain, we can minimize this. So how to avoid this? Mediolateral episiotomy should be considered wherever it is necessary. When episiotomy is indicated, the mediolateral technique is recommended with careful attention to ensure the angle of 60 degree. What happens when we give when the head is fully crowned? So when we give episiotomy at 60 degree inclination, after the delivery, the degree will be 40 degree. Like that, when in full crowning, if we give episiotomy in 40 degree, so after the delivery, if we properly assess, the episiotomy angle will be 22 degree. So that is why, while we should not take the consideration of angle at the time of incision, okay, we should take the angle of episiotomy, this thing, post delivery. After the delivery, we should assess. So it should be as per NICE guideline. The episiotomy angle is very, very important to prevent this sphincter injury. It should be between 45 degree to 60 degree. So 45 to 60 degree episiotomy angle should be assessed after delivery, not at the time of giving episiotomy incision. Okay. Then perineal protection. So perineal protection, is it really gives protection for anal sphincter injury? Yes. Hello. Perineal protection at crowning is protective, and warm compression during the 2nd stage of labor, continuous warm compression to the perineum at the in 2nd stage, it prevents the risk of obstetric anal sphincter injury. With respect to the perineal protection, there are two concepts. As per NICE guideline, hands on and hands off, there is not much difference. As per Greenprop recommendations, so always it is better to put right hand in the perineum, left hand to support the head, and ask the mother not to push while the head is in crowning stage. These are the precautions to be taken to prevent obstetric anal sphincter injury at the time of delivery. So repair of obstetric anal sphincter injuries. What are the what are this thing? So precautions we are supposed to take. All women having vaginal deliveries should be examined systematically, including digital rectal examination to assess severity of damage, particularly prior to the suturing. So that means for all vaginal delivery, rectal examination is must to rule out the sphincteric damages and buttonhole injuries to the rectum. Sometimes what happens, sphincters may be intact after the delivery, but if we properly do rectal examination, we can able to feel some buttonhole injury in the rectum. So if it is identified, it has to be sutured to prevent rectovaginal fistula afterwards and to prevent anal incontinence in the futures. After all vaginal deliveries, rectal examination is must. Okay, next, repair obstetric anal sphincter injuries should be conducted by an appropriate trained clinician or by a trainee under supervision. So it has to be repaired by a trained surgeon. So where the repair should take place? Ideally, it should be done in an operation theater under GA with good lighting and using appropriate instrument. If there is excessive bleeding, then pack the vagina and then take the woman to the theater. So repair of obstetric anal injuries in delivery room, because sometimes it is very difficult to shift all the delivered patients to the OT. We may not get. Sometimes after discussion with the senior obstetrician, we can repair this obstetric anal sphincter injury in delivery room in special circumstances. Okay, what are the techniques of repair? Now we have this anorectal mucosa in this obstetric anal sphincter injuries. This obstetric anal sphincter injuries includes only 3rd degree and 4th degree perineal tear. 1st degree, 2nd degree perineal tears are excluded with this nomenclature. Okay, this torn anorectal mucosa should be repaired, and internal sphincter, external sphincter. These are the things. Okay, how we are supposed to close this anorectal mucosa? It has to be closed. It has to be sutured either with continuous stitch or with interrupted stitch. Okay, wherever internal anal sphincters can be identified, it is advisable to repair this separately. Okay, in all the cases, it is very difficult to identify internal anal sphincter. Agreed. But in case if we can able to see this, it's better to repair it separately from the external anal sphincter. So how to close it? Whether with interrupted or mattress? Yes, we can do interrupted stitch or mattress. In both these two, we are not supposed to use figure of 8 stitch. So either in the anorectal mucosa or in the internal anal sphincter. So figure of 8 stitch is to be avoided because it is going to hamper the hemostasis. Okay, then what about the external anal sphincter? In external anal sphincter, we may get partial tear or complete thickness tear. So whereas if it is partial thickness, then end-to-end anastomosis is used. Okay, if it is full thickness, 2 options are available: overlapping and end-to-end. In both, there is no problem with the efficacy. Both are equivalent in outcome. So if it is a full thickness external anal sphincter damage, either overlapping technique can be used or end-to-end technique can be used. Whereas for this internal anal sphincter, we are not supposed to use this overlapping technique. Only we are supposed to use end-to-end technique. Okay, for this partial tear, we can use only end-to-end techniques. Okay, so choice of the suture materials. Here we have anorectal mucosa, internal anal sphincter, external anal sphincters. So these are to be repaired. So what are the choice of suture materials? So for closing this anorectal mucosa, we are supposed to use 3,0 Vicryl polyglactin. Okay, so we are not supposed to use PDS for this anorectal mucosa. For anorectal mucosa, 3,0 Vicryl is ideal. When we are repairing external anal sphincter or internal anal sphincter muscles, so preferably PDS, 3,0 PDS or 20 Vicryl. Both have got equivalent outcome. So there is no preference. Either we can use 20. When we are using Vicryl, it should be 20. When we are using PDS, it should be 30. So this is with respect to the repair of external anal sphincter and internal anal sphincter. When obstetric anal sphincter repairs are to be done, the knots should be buried beneath the superficial perineal muscles. That is superficial and deep transverse perineal muscle. So between these two muscles, the knot should be buried. Otherwise, there will be a problem of a suture migration. So it will end up with chronic pain and irritation over the anal region. So these are things to be considered. So this is the schematic diagram showing the end-to-end repair of sphincter, external anal sphincter, external anal sphincter. So this is the diagram showing the overlapping technique. So sutures are passed like this. So after this, tie the knots like this. This is the overlapping technique. Once again, I will show. This is the end-to-end closure. So this is how we are supposed to take the stitch. After that, in overlapping, so the technique of external anal sphincter, we are supposed to tie the knots like this. Okay. What are the post-operative important things that we are supposed to be considered? Okay. The use of broad spectrum antibiotics are recommended following repair of sphincter injury to reduce the post-operative infection and dehiscence. The use of post-operative laxatives is recommended to reduce the risk of wound dehiscence. So bulking agents, Ipsagula, that should not be given routinely after laxatives, okay? Because once we start laxatives along with the this bulking agents, then what happens? The lady will be having diarrhea, incontinence, immediate anal incontinence. That affects the healing procedure. That's why bulking agents should not be used routinely with laxatives. Post-operatively, laxatives and antibiotics. These are the two things to be given. So, and local protocols are different for different areas. Okay, antibiotics, the best sensitive antibiotic in that area should be selected. This is as per Green Top guidelines. Okay, even laxatives, the recommended laxatives which are available in that country, in that area should be used. Examination and follow-up. For this, whoever is the best, whoever is the senior most surgeon in that institute, should do the follow-up and he should take care of the patient. Women should be advised that physiotherapy following the repair is beneficial. So this we should convey the lady. If you want to undergo physiotherapy, yes, it is beneficial, you can go ahead. And when women who have undergone obstetric anal sphincter repair should be reviewed at a convenient time, usually after 12 weeks postpartum. Where possible, review should be done by a clinician who has got special interest with this. Okay, what are the recommended practice? Rectal examination after delivery, adopt the new classification, obstetric anal sphincter injury repair by experienced doctor in theater under regional or general anesthesia, external anal sphincter end-to-end or overlap repair of torn anal sphincter with 20 PDS or Picral 20, lactulose 15 ml BD for 2 weeks, antibiotics, ensure bowels opened, follow up at hospital by a senior obstetricians. What is the postnatal review? All women should be offered physiotherapy of pelvic exercise at 6 to 12 weeks. All women who had obstetric anal sphincter repair should be reviewed 6 to 12 weeks postpartum. So when to refer? A lady of obstetric anal sphincter injury, when to refer that case? If a woman is experiencing any incontinence, either for the flatus or for the fecal material, or pain following the surgery, referral should be done to a specialist, gynecologist, or to a colorectal surgeon. But the problem with colorectal surgeons, they are not fully aware of these acute injuries. So we should keep it in mind. Okay, a small number of women may require referral to a colorectal surgeon. That's why where secondary sphincter repair are required. So post-delivery counseling. So how to counsel the patient? Women should be advised that after the surgery, 60 to 80% of the patients will be asymptomatic at 12 months. Most women who remain symptomatic describe incontinence to flatus or fecal urgency. Okay, regarding post-delivery for the next pregnancy, how we should counsel the patient who has undergone sphincter repair in this pregnancy. So as per Green Top guidelines, all women who sustained an obstetric anal sphincter injury in a previous pregnancy should be counseled about the risk of developing anal incontinence worsening symptoms with subsequent vaginal delivery. So subsequent vaginal delivery, there is a possibility of worsening of this anal incontinence symptoms. And all women who sustained an obstetric anal sphincter injury in a previous pregnancy should be advised that there is no evidence to support the role of prophylactic episiotomy in subsequent pregnancy. Okay, this time the lady had developed this thing, obstetric anal injury. So there is no guarantee that in subsequent pregnancy, by just giving prophylactic episiotomy, it can be avoided. So even in future also, the lady, even with episiotomy, the lady can develop obstetric anal sphincter injury. That we should, in the counseling, we should tell this. And all women who have sustained an obstetric anal sphincter injury in a previous pregnancy and who are symptomatic and or have abnormal endoanal ultrasonography findings or manometry should be told that the option of elective cesarean section should be given. That means if the lady is having symptomatic anal incontinence or abnormal findings in endoanal ultrasonography or manometry, they are the people whom the elective cesarean section option should be given. Okay, documentation and information. When a third and fourth degree pairs are performed, it is essential to ensure that anatomical structures involved, method of repair, suture materials used are clearly documented, and instruments, sharps, and swabs are counted. Everything should be recorded in the document. And woman should be fully informed about the nature of her injury and benefit of her follow-up. And she should be told she should not be there at the home. Frequently, if she comes for the follow-up, it is better for her health. So these are all these things should be clearly documented and given to a lady while discharging. So unfortunately, as we all know, this obstetric anal sphincter injuries are acute. I do not have, apart from these pictures, I do not have any video of this, but I have a video of chronic pelvic complete perineal tear repair. If you want to watch the video, it is 5 minutes video I will put. Hello?
You can play the video.
Yeah, this is the video of chronic perineal tear. Now I am separating the vaginal mucosa from the underlying structure. Okay, this is actually 1 to 1.5 hour surgery. I have reduced it to 5 to 6 minutes. So that is how we are supposed to separate the vaginal mucosa from the underlying tissue. So see, the sphincters are torn and they are retracted. That's why we should put the incision vertically on both the side, like butterfly. So to catch the external anal sphincters, they are okay. We are supposed to cut the tissue. So still I have not got the external anal sphincter. So I'm trying to catch the, see. So if when we catch hold of the external anal sphincter, when we remove, it should elevate the posterior aspect of the anus. So then only it is sure the dissection is done on the right side of the patient. So see the thickness of anal mucosa. No perineum is left. Okay, this is how we catch hold of the external anal sphincter. In this, it is impossible to differentiate between external anal sphincter and internal anal sphincter. So this is the separation of external anal sphincter. So now after this dissection, what we need to do is we should look for the anal mucosa, even in complete perineal tear. So anal mucosa is torn above. It has to be sutured for convenient length. Okay, and then now I'm taking a bite through the external anal sphincter. So ideally, 2 or 3 stitches are taken. So usually, if it is very thick external anal sphincter, I take 3. Otherwise, I take 2. So for this, preferably I use 30 PDS. Okay, or we can use 3020 Vicryl for this external sphincter. So we should use either 30 PDS or 20 Vicryl. Okay, after closing the external anal sphincter, we are supposed to close the superficial and deep transverse perineal muscles. Can you able to make out that? So we will have after this, even this superficial and deep transverse perineal muscle, they will be apart. Only we will be having vaginal mucosa and anorectal mucosa. In between, we won't be having anything in this case, in this chronic perineal tear. So we have to dissect all the things. After closing the external anal sphincter, we are supposed to close the superficial and deep transverse perineal muscles. So after that, so the perineum will become 4 to 5 centimeter thick between the vaginal mucosa and the anal mucosa. So see, now I have already closed both external anal sphincter and including external and internal anal sphincter, and even the superficial and deep transverse perineum. See, this is one more thing. So I am closing the skin. This is not the perineum, the skin in the perineum. This closing is through the whatever the dissection that we have done laterally. We have to cut on the lateral aspect of the anal canal. Okay, that has come down. So to get the external anal sphincter on either side, that is the rectal mucosa. On either side, still we have that skin gap. So that we are supposed to close. See, that is not the perineum. That is the incision that we have put to get the external anal sphincter. So that area is also be closed separately. Why that is important? This 3rd degree and 4th degree perineal tears, this complete perineal tears, they are known for wound gap. So they are horrible cases. So if we don't repair them properly, they will end up with gap. That is the dreaded complication of this thing. Okay, and one more thing, it is not there in any of the textbook. What I preferably do is, so this PDS, usually what happens when we close both the external anal sphincter end to end, there is a possibility of slipping. So anal mucosa, what happens, the sphincters will be remained at its normal level, but anal mucosa will recede upwards sometimes. I have noticed in few of the cases like that. That's why what modification I am doing in my case is, so go above 1 or 2 centimeter above the anal orifice, you take a bite through the rectal this thing, rectum will be there, that mucosa. So take a bite through the serosal part of it and attach to the sphincters. So if we do this with the same suture material, when we are using PDS or Vicryl, so with the same suture material, if we attach this, the possibility of slipping of this this thing, sphincters, or migration of the outer margin of the anorectal mucosa will be very less. So this I have adopted off late. By this, this complication can be prevented. So these are few important technical aspects with respect to the repair of this complete perineal tear. So if we identify the sphincters properly, and one more thing is, we can't get 100% of the external anal sphincter tissue while operating. So that is a fact. But we should not miss, at least we should take, we should search and take 80 to 90% of the tissue. So we can't, it is not like something which is easily graspable. It is embedded inside the tissue. So it is preferably, even if we if we get 80 to 90% of the tissue, it gives 100% this thing, but success rate. So we may get initially. So once we hold it, hardly we will get 30 to 40% of the tissue. So we should catch it, dissect it, and we will get soft lateral to this thing. We will get some soft tissue, okay, fat tissue. So we need to dissect it out, and the complete external anal sphincter we should grasp it. So if we follow these few tricks, we can able to give 100% success rate. Till date, yeah. Kirana, the next slide. Yeah, that is third degree complete perineal tear. So thank you. I thank all the organizers for giving me this opportunity. I thank Kasturi Madam also. Thank you, one and all.
Okay, thank you, Chandru. Excellent presentation as usual. He is a faculty. He is our old student. He has done a postgraduate in our institute. But for our every PG program, PG teaching program, he is a faculty. He and Kiran. So we are very fond of him. They both are. Chandru has done excellent work in urogynecology. He is a pioneer. Now I think you should call Dr. Chandru to hold live workshops, so that because these cases are rare and people, PGs are not much exposed to this. So live workshops he can actually show, so that the benefit is passed on to the patients, So Chandru, you should think of that, doing more and more live workshops with this.
Yes, madam. Surely I will consider and I will do it.
So, any questions?
Yes, ma'am. Questions are there. Dr. Ravikant.
Thank you, Dr. Murthy. It was excellent. Yes.
Thank you, Vidya madam.
Yes.
Yeah.
Yeah, and the videos were excellent. So we would like to have some live workshop. Because of this corona, we are not able to do that. But I remember you coming to Bijapur and conducting a nice session. Yeah.
Yeah. So shall I take the questions, sir? Dr. Chandrasekhar, sir?
Yes, madam. Yes,
yeah.
madam.
So the first question, sir, does OSS suturing cause constipation? What are the chances of fecal incontinence and flatus incontinence after successfully treated OSS? How do you treat or rehabilitate those patients?
Yes, as per the data, the fecal incontinence rate is 5.9%. After the repair, there is a possibility of fecal incontinence of 5.9%. So if it is fecal incontinence, we are supposed to advise her for rehabilitation. So pelvic floor exercise and physiotherapy. Even after that, if it is not subsiding, then we need to opt for the surgery once again. Yes,
okay, sir. Yes. So next question we have from Dr. Vidya K. In undiagnosed 4th degree tear and reported 40 hours or later, what are the management options?
I didn't get the question, madam.
If there is a 4th degree tear, sir,
okay, madam.
The patient reports to you later, or she is delivered somewhere in the periphery.
Yes. Yeah, this happens. Yeah, even then, we are supposed to do the surgery. Even she comes off late. So with broad spectrum antibiotic, we need to do the repair. When compared to the acute injury, the success rate is bit less because already the tissues will be edematous and infection might have been progressed. So in spite of that, we should go ahead with the repair work. There is no need to delay.
Okay, sir. We have Dr. Aruna Nigam, our speaker, who was there for our conference yesterday. So ma'am is telling the post-operative protocol. When will you allow orally? So I'll ask one question, sir.
Yes, madam. Yes, madam.
When will you allow orally, sir?
Yeah, usually preferably after, as per this international norm, there is nothing. Once the bowels are open, you can start. Ideally, what I will do in my practice, 3 days over 2 days, I will give oral fluids. From third day, I will start liquids for another 2 days. So by then, for the bubble to come, it takes 4 days. It is more than enough for tissue healing.
Okay, sir. Then to start perennial exercises, as 6 to 8 weeks is very late.
Madam, in this, I will advise the patient once. That's what I told in my this thing. The most one of the most common complication with respect to the repair of this third degree perineal tear is wound dehiscence. Okay, early immobilization we advise, preferably doing pelvic exercise. A pelvic floor exercise should be started once the tissues are healed. Preferably, it is advisable after 12 weeks. So because we need to give the time for tissues to heal. So once the tissues are healed, then we can strengthen them. So before the tissues are getting healed, if we put more stress on them, there is a possibility of dehiscence of the sutures that we have applied to the sphincters. So early exercises should not be advised, madam.
Okay. When to resume sexual activity?
After 3 months, madam.
Okay. Use of anal ultrasound during follow-up?
Yes, madam, sure. Usually we used to do in our hospital. So it usually ring-like structure, it appears if it is a complete this thing. But with respect to the endoanal ultrasound, the reproducibility and the expertise is very less in most of the countries. Hardly very few people are there to do very good sonology and give interpretation. So that's why still this anorectal, anal sonography and manometry, they are only research this thing, importance. As per green top guidelines, they should not be taken into consideration for the management purpose. Digital examination and thorough examination and visual inspection, they are the better tools rather than sonography.
Okay, sir. So last question. So what is the protocol for follow-up visit? When to call the patient and how long she should come to us for follow-up?
Yes, madam. Ideally, she is supposed to come at 6 weeks and 12 weeks. If not between 6 to 12 weeks, she is supposed to come. Once she comes, we are supposed to assess. By then, we will come to know about her this thing, whether the repair is successful or not. If it is successful, then advise her to go ahead with pelvic floor exercises, and we should advise her the following next pregnancy. What are the things she is supposed to be followed? Okay, if it is if she has got anal incontinence, advise her for pelvic floor exercises. After 6 weeks, if it is not improved, tell her the option of repeat surgery.
Thank you, sir.
Thank you, madam. Thank
Thank you for the excellent talk, sir. We are getting many congratulatory messages on this chat box that sir's talk is very excellent.
Thank you, madam. Thank you.
Thank you, sir.
Thank you.
So shall we move to Sarita ma'am? Because we have to take few questions. Madam has to answer few questions for us. Sarita ma'am?
Yes, I am ready, madam.
Yes,
yeah,
madam.
Before answering the question, can I just show my video?
Yes, ma'am.
Because
Surely,
it is
ma'am.
very important that I can will be able to understand. So I'm just playing my video and the full screen. I just want to mention that this video is prepared by Dr.
ಪ್ಲಾಸ್ಟಿಕ್ ಚೀಲ ತೆಗೆದು ಒಗಿ ಆಮೇಲೆ ಇವು ಟ್ರಾನ್ಸ್ಫರ್ ಕೈ ವಾಶ್ ಮಾಡ್ಕೊ ಅದು ತಗೊಂಡಿಲ್ಲ ಅವ್ನ ಕೈಯಾಗಿಂದ.
Yeah, I'm sharing this video which is being prepared by Dr. Poonam from Vardha MGIMS, and she is doing the excellent job there with the PG also doing the thesis on under her. She will just show how they have set up the alternative birthing position room and how they can deliver the baby, and our PGs can understand.
We can't hear the voice, ma'am.
Oh, why? But
But video is very clear, ma'am. Video
can
is very
somebody,
clear.
can
Yeah.
the organizer help me how to make the voice, because I can listen the voice over here. I'm
Ma'am,
not
if you
able
can
to-
increase the volume of your
volume is maximum.
And you
on my
can
side.
put your earphones there somewhere. Here.
Can you listen now?
Remove the earphone. No,
but
no.
video is very clear, madam. We can see the video, only it's not audible.
But I think the observation may be enough for them, because I'm not able to translate. This is available in YouTube. Once you just put alternate birthing position MGIMS, one can read.
And this ball is taken out. So this ball is taken out. This is a very simple ball which is available in the gyms, so everyone can get it. Now with this rope, she can hold it. She can just reduce her pain whichever way she wants. Now and once she is delivering, she just pushes it here, sits on this, and like that, she can deliver. Now, how do you sit for delivery? Can you please tell me? How do you sit for the CVT baby? So you can see both of them will sit down, like they will kneel and they will sit, and there are also stools there. These are stools which are, can you show them these stools which are available on the chair? So they can be kept here and she can very easily pass the baby here. That's one way we are doing. How do you set up a bar delivery? So this is a bar, very simple bar which anybody can take. And here she sits, so she's just like this and she passes the baby. And if you sit, and we are sitting here and she passes the baby. You can very quickly know where the baby is as well as your back and then the body. And here is tray for this baby. So this is another use by which women can be delivered. Another method what we are doing is birthing chair. This is what you should at that. She can spread her leg on the side and we sit here like this. And the baby comes out from here. On the lower part, you see there is a tray. This tray is covered by a lot of gauze and sterile sheets. And then the baby comes and passes down. She herself can pick up her baby and then put the baby on the breast. So that is what we do. But by making these small stools, we can very easily see, watch, support, and then deliver. So this is also another way of delivery. Lateral position, there is a bed. In this room, if she wants to sit laterally, and then we support the baby from this side. So this can also be done. The most interesting is hydraulic labor. When you see, this was a simple armchair which we have converted into a chair, birthing chair. And if you see, any armchair can be used, but all what you have to do is you have to make it so soft that when the woman sits there, she should not get hurt. And the area which you have to cut should be such that the baby can easily pass out. And the below the tray which is there has to be broad enough so that the whole baby goes in that. And once you cover it with the cotton pieces and the sterile sheet, then it becomes completely sterile. This is what we have done. So it is a simple bath.
If the voice is not audible, I can dictate. This is a simple bathtub which is being used for the, which can be simply used for the bathing. The woman lies over in the bathing tub and there's a cushion is there and the armrests are here on this side, and this is the tap for the water to come, which is connected to the geyser, and the temperature usually capped is 32 to 38 degrees centigrade or 100 degree Fahrenheit, and the flow of the water can be controlled by the patient herself. And the bathtub is filling up, this tap can be taken out and the water can be drained. Similarly, if you get more amount of the blood, then also this can be drained and the water can be changed very easily. And for this, when woman has to enter into the bathtub, usually the women require a training to be in the bathtub, those who are used to be in the bathtub, or they can be just asked for an initial stage of the labor to be around 1 hour or 2 hours sitting on the bathtub. Sometimes the women doesn't like to take out their clothes when they are the bathtub, so they can just simply use the raincoat sort of the thing, and they can be sitting comfortably. They can have the reading, they can have whatever they want to do, and they can listen the music also if you can give the earphones to them. And the patient sits in this position, and when the patient is delivering, the obstetrician sits on the other edge of the bathtub, and then when the baby is delivering, they are the hands-off technique. When the obstetrician doesn't have to do anything, they just watch the progress of the labor, and the baby is just coming out, they are watching. And once the baby delivers out, the head of the baby should be brought out of the water birth. So the baby should not inhale the water. So look how the obstetrician is sitting over there. The most important, the foot hygiene of the obstetrician needs to be maintained. So she can use a sterile foot covers on the legs like this, and then they can just dip their legs, so there should not be any problem. And this is how you can just help the baby is delivering out, sitting and then observing. And the other way, you can just assist the delivery by giving the support to the perineum, and that you can decide that is a hands-on technique. And the prior counseling is very well important in all these patients. So with this, I end up my video, and I can just proceed further. You can just proceed for the questions.
Yeah, thank you, ma'am. Do our chairpersons have to say anything? I'll take the questions after that. Kasturi ma'am, Vidya ma'am, do you want to add to this something?
How they are protect? Just I wanted to know, Sarita, if hello.
Yes, ma'am, you're audible. Yeah.
In water birth, I feel the obstetrician is exposed to some kind of infections if the mother is carrying, because she's into the water can act as a carrier medium.
I described that if the woman is having the infection like a herpes infection, and the obvious infection, she may not be allowed for the water birth. But there are other studies where the studies for the streptococcal incidence of streptococcal pneumonia in the babies, the risk is not being different from the normal population. And similarly, the other infection risk is also similar as compared to those who delivered on a non-water birth positions. So the studies has very well reflected there's no increased risk of infection when the patient is delivering the water birth. Of course, the patient with the HIV infection, the herpes infection, they are the contraindication for the water birth.
What about if the woman needs episiotomy?
Episiotomy can be usually in the water birth because of the increased perineal elasticity, and the patient is more comfortable. The effect of the contraction is not there. Episiotomy is not required. If at all required, it can be very well given when she's in the water birth, because she's in the sitting position. At that time, you can give the episiotomies also.
How the sterility of the water is maintained?
That is in the clean water, the simple water can be used, and the lukewarm water is good enough. And the sterility, I just told that women should take a bath and then she should enter into the water bath. And the obstetrician who is dealing with should also be wearing the sterile foot covers, so the water infection will not be there. And of course, the water bath water is allowed to be changed maybe around every 4 hours with the tap which is connected over there in the water bath, which woman herself can regulate.
Okay, yeah.
Ma'am, we have few questions here. Does any using alternate birthing position affect intrapartum monitoring or emergency intervention?
Yes, about the intrapartum monitoring, that is one of the problem. The patient is ambulatory here, so when you put an electronic fetal monitor, they can get displaced, and the risk of non-monitored labor can be there. But in such cases, it is being very well described. The low-risk women, intermittent auscultation is the best method. And if you're doing the electronic fetal continuous monitoring, it already increases the risk of the cesarean section. So we don't stress much upon the continuous electronic fetal monitoring, but those women who are then high risk and those who actually need the continuous electronic fetal monitoring, the wireless digital applications are available, which can be put on the abdomen of the mother. Mother can be ambulatory, and any displacement the mother herself can control. And in the central monitoring system at the nursing station, the fetal heart rate can be very well monitored. And I describe when the woman is in the water birth also, the this waterproof monitors are also available that can be applied on the mother's abdomen. Otherwise, the intermittent monitoring is good enough, and I already described in all these positions, the chances of getting the fetal heart rate variability is much less because the baby gets more oxygen supply due to more less compression in the aorta and the IVC, which improves the fetal circulation.
Okay. Thank you, ma'am.
And about the
Does-
instrumental delivery, yes, there are certain issues with the instrumental delivery in upright positions. Therefore, if you feel that the patient needs an instrumental delivery, it is always available. The patient can be put on the backline position and where the instruments can be applied very well. But the water birth instrumental delivery can still be carried out.
And do these alternate birthing positions reduce posterior positions?
Yeah, this is all four positions and the left, the line, lateral line position. They have been shown to decrease the risk. They have been shown to correct the occipito-posterior positions. So these are the many of the practice being done. And I think in my own practice, I always ask the women to lie on her opposite side of the back, and then improves the occipito-posterior position and corrects and facilitate the rotation of the baby's hand and the chances of vaginal delivery rather than the face to pube delivery.
Sir, next speaker, she is messaging. Yes, ma'am, then can we use these positions in breech delivery also?
Yeah, about the breech delivery, actually, most of the breech delivery, they need lots of assistance and care during the second stage of the labor. For the breech delivery, it has been said, the women in the first stage of the labor and the early second stage of the labor, what I talked about, the passive stage, and till the bearing down effort start, the patient can still be in the comfortable position, whatever she feels, and when she is in the actual active phase of the second stage or about to give the birth, that time the patient can be put on the lithotomy position because that is the most acceptable position for any of the assisted vaginal deliveries.
Okay. Then Dr. Lohit Kumar is asking, how do we assess the requirement of episiotomy to prevent tears in these positions other than lithotomy? And will these alternate positions reduce the requirement of episiotomy?
Yeah, that is very well described. I have shown the figures also as per the Cochrane review. The women delivering in the upright position, the squatting position, or the kneeling position, the perineum gets widened, and the mothers are more relaxed. The perineum is more stressed, so the chances there's around 20 to 40% reduced incidence of requiring the episiotomies. And another thing is that if you don't give the episiotomy, the risk of tears are always there. So these tears can be first degree and second degree in the most of the position. And the overall, if you look at the intact perineum rate is much less in this alternate birthing position as compared to the standard backline position. And regarding the assessment, when you need the episiotomy, it is exactly the same what you're doing in your backline position, because anyhow you have to monitor the progress of the labor as per the partographic principle on these women. And that time you can assess in the second stage of the labor whether the woman needs episiotomy. So it has been shown that some cases of the upright position, especially in the standing position and the lunging position, the risk of perineal tear of the third and fourth degrees are there. So some of the cases has been shown, but the risk is so less. So if the benefits overweighs the disadvantages, then the benefits, it has to be taken into consideration, and then they can be repaired, because once you identify, as Dr. just now described, you identify immediately, repair, the results are wonderful. So if you're leaving behind an intact perineum in more of the women, still this alternate birthing position can be the choice.
Then last question, ma'am. What are the minimum requirements we should have to use these alternate birthing positions?
Yeah, for this minimum requirement, I think you could not listen the voice in this video which I showed. The first most important thing, you should have a setup, that you should have all these like gym balls and the U-cut chairs and the stools and the bathing tub, whatever you need to avoid. And the second thing, and counseling the women during the late third trimester itself, they should be shown all the options that these are the birthing positions available. And you could have seen one protocol book on that, within the every page, each position's advantage and the disadvantage has been very well described. So this can be in the late third trimester, and once again when the patient enters into the labor room, the patient herself and the partner or whoever the accompanying person, they should be talked about this, discussed, counseling should be done, and the patient preferred position should be taken and then noted down. And after that, once the patient is in the already in the labor, at that time throughout an assistant should be there who is going to assist her and guide her what to do and how to do and when to do which procedures. So these are the important requirement when you're doing an alternate birthing position. And as I told that the SCOG says there's no mandatory one prescribed position. So during the labor, throughout the labor, patient women can opt different position. Whichever position gives her the best comfort, they should be promoted, and then she can opt a different position. But of course, at the end, when she's actually delivering, that should be fixed by the women. So there should not be a litigator on, that should be taken on the consent paper.
Okay. Thank you, ma'am. Thank you. Thanks a lot.
I hope I justified the chapter.
Yes,
Thank you
ma'am.
so much. I thoroughly enjoyed being with you.
Thank you, ma'am.
Hello, Dr. Deathubi, madam, it's nice to see you. Thank you so much.
Yeah.
Dr. Geeta, madam, very wonderful being with all.
Thank you, Sarita ma'am. We move on to the next speaker, Dr. Anisha Gala, who will be talking on role of instrumental deliveries in modern obstetrics. I request the chairpersons to introduce our next speaker.
Yeah, Dr. Anisha Gala, she's done a fellowship in obstetric medicine. She's a consultant at Fernandez Hospital, and actually her special interests are medical disorders complicating pregnancy. Very, very important these days because we have lots of cases, pregnant patients with medical disorders. But today she'll be talking on the role of instrumental deliveries in the modern obstetrics. Over to you, Dr. Anisha.
Good morning, everyone. Good morning, everyone. It's a nice conference arranged with nice topics. I would like to thank and also congratulate the KVG Medical College, Dr. Kasturi, Dr. Geeta, Dr. Vidya, and their team who have arranged such an excellent conference. Thank you all for giving me the opportunity to share what we do in daily obstetric practice here in Fernandez Hospital. So let us look at the role of instrumental delivery in modern obstetrics. We all know that as in our daily practice, we can see and it is very evident that the skill to do a forceps delivery, artful forceps delivery or ventouse delivery is dwindling slowly. As the residents, they come to us, they are, more, at the end of their 3-year period, there are residents who may learn how to do a cesarean section, the most complex laparoscopic surgeries, but at the end of their 3-year teaching period, it is unlikely that they would learn a beautiful forceps delivery or a ventouse delivery. I do remember my professors doing a forceps delivery, which was like, it is described in the books, it is like an art of forceps, or it is a treat to eyes to watch people doing forceps delivery. So is it worth learning at all? We all know that Cochrane meta-analysis has shown that the women who experienced vaginal birth were less anxious about their babies. They were more positive about their approach towards their motherhood, about their, and they had a very satisfied experience about their childbirth itself. And women who had cesarean section were sort of unsatisfied with their experience or never felt more complete, as if we call it. So the implication also is that for the future mode of delivery, one of the central point is that what was the woman's first delivery. We all know, and we have seen in our practice, daily practice, that the chance of a normal delivery increases when the cesarean section, when the woman has a vaginal birth, prior vaginal birth, whereas the chance of cesarean section is higher when a woman has had previous cesarean birth. So as we know that we can look at the world, the chance of cesarean section, the incidence of cesarean section is slowly rising in this world, and the incidence of instrumental vaginal births is slowly dwindling, as is the and these two graphs are continuously going apart. So if we have to reduce the number of cesarean section rates, our primary objective should be to increase the incidence of vaginal birth and to decrease the primary cesarean itself, and that is how we will achieve more and more vaginal births. And one of the instrumental things in decreasing cesarean section rate is a timely application of instrumental vaginal delivery. We will see how and what we should do it. So if we look at our Fernandez Hospital statistics, in all RCOG and ACOG, they have said that ideal instrument delivery rate should be anywhere between 10 to 12%. We also hover around 10% in our daily, in our statistics, yearly statistics we can see. So first and foremost, we should look at when is the instrumental delivery required? Is it required at all? So how do you classify these instrumental delivery? And if we know the classification, and if we know that when a certain instrument can be applied, then we can apply this theoretical knowledge into our daily practice and then achieve more and more of instrumental vaginal birth. So we all know that outlet delivery is when the head is at the outlet, that is, it is distending the perineum and it is not rotating more than 45 degrees from the midline, whereas for a low instrumental delivery, it is at +2 or more, but not on to the perineum. And if it is more than 45-degree rotation from the midline, it is called as rotational delivery. And if it is less than 45 degrees away from the midline, non-rotational. And mid, when the head is at +1 station. So if we have this basic classification in our mind, when we are doing vaginal examination, we will not resort to a cesarean section, or we will not wait for a vaginal delivery, which whenever it is we will not resort to a wait for a spontaneous vaginal delivery when an instrument is actually indicated. So when should we do an assisted vaginal delivery? Look at this lady. She is primigravida, 34+ weeks with spontaneous labor, uneventful antenatal checkup so far, spontaneous preterm labor, and good progress in first stage. And this is her CTG in second stage. She's fully dilated, +2 station, and clear like her. Isn't it not evident from the CTG that there is loss of variability? The baseline is around 150, there is loss of variability, and there are repetitive type 2 deceleration. You can see that after every contraction there is a type 2 deceleration. So there are repetitive type 2 decelerations. So certainly this baby needs to come out very fast. So is it good that I resort to a cesarean section at +2 station? What is the kind of morbidity that she is going to have, the mother is going to have? And another thing is that doing a cesarean section or preparing a cesarean section so early when the baby is having so many decelerations is not correct, because that will only take up some more time. For institutes where anesthetist is available 24/7 is also difficult, because to give her a spinal, to paint her, drape her, and then to take the baby out after dissecting so many layers is certainly going to take at least 15 minutes from the time I decide to deliver her. Isn't it not? So what is the safest way of delivering her? Obviously, we all agree that the delivery needs to be hastened, but what will be our choice of instrument, or what will be our choice of route of delivery? Certainly, we cannot wait for spontaneous vaginal delivery, because from +2 for the baby to come out, it is going to take time, and baby may be compromised by the time we deliver her vaginally. At the same time, the morbidity and the time taken for a cesarean section is going to be tremendous. So when we look at presumed fetal compromise or fetal distress in AVD or assisted vaginal delivery, it is the most common indication after prolonged second stage. It contributes to almost 1/5 of the all assisted vaginal delivery, but because of the anxiety to deliver her faster because of fetal distress, it is more likely to fail as compared to a prolonged second stage. Suppose there is a woman who is like 3 hours fully dilated, and you want to deliver her because her second stage is prolonged, and you want to put a forceps. You will obviously do a thorough vaginal examination. If you want second opinion, you will call your colleague and do take a second opinion regarding that. But in a situation where a CTG is continuously showing type 2 decelerations, we are more likely to expedite the birth by sometimes by going wrong in our assessment. And the only way to improve ourselves is go on doing these deliveries, practice on the mannequins, and do not let our clinical and surgical skill decline. So the fetal indications, where do you need instrumental delivery? In fully dilated patient when the station is +2 or more, non-reassuring fetal heart pattern, or cord prolapse, or malposition with relative dystocia for the people who can deliver the women with rotational forceps or rotational Veltius, it is oblique position, or in occipito-posterior position where the second stage is more likely to be prolonged. Maternal indications, wherever there is maternal exhaustion or maternal medical disease which may compromise the mother's well-being because of the Valsalva maneuver. Whenever there is Valsalva maneuver, there is tremendous cardiovascular demand which may deteriorate the mother, and to cut short second stage of labor, we may have to resort to instrumental delivery rather than going in for a planned cesarean section and increasing her morbidity with a planned cesarean section. It is better that we allow her for a vaginal birth, and if she can escape with a instrumental vaginal delivery, that is the best thing to happen for maternal and fetal outcome both. So what is prolonged second stage of labor? With epidural, it is 4 hours and 3 hours for primes and multis respectively, and without epidural, it is 3 hours and 2 hours for primes and multis respectively. Second is arrest of descent. When it is not descending from more than +2 station, then we may have to cut short the second, then we may have to resort to instrumental delivery. So if the second stage is prolonged, then it results into high maternal morbidity after 3 hours because of extension of tears. Haven't we seen those boggy edematous vagina which will tear everywhere, and you go on doing multiple sutures everywhere in all places? There is higher risk of wound infection, sepsis, and need of blood transfusion. However, that is not resulted in neonatal morbidity if it is monitored continuously. So how many of us actually do one-to-one monitoring or have facilities for having continuous CTG? Certainly, everybody does not have the facility of doing continuous CTG. So whenever there is a prolonged second stage, we must realize that it can cause high maternal and neonatal morbidity if they are not monitored. So these are the indications when we would do a vaginal delivery, assisted vaginal delivery, to reduce maternal and fetal morbidity. So when should we not do an assisted vaginal delivery? So as a clinician and as a surgeon, it is very important that first we know the contraindications of any procedure that we are going to perform. So look at this woman. She is a gravida 2 para 1 live 138 plus weeks with spontaneous labor. She has had uneventful antenatal checkups. This is a good news for an obstetrician that multi-gravida has come with a spontaneous labor. She's 8 centimeters +2 station, well rotated, and she has the urge to push. So this is her CTG. We can see that there is a good CTG trace in the beginning of the trace, but slowly as the CTG trace ends, towards the end, there is acute bradycardia, which is not even coming back to the midline. So this is an acute bradycardia of more than 3 minutes or more than 2 contractions. Definitely the birth needs to be expedited, isn't it not? At 8 centimeters, definitely we need to expedite this birth. After doing intrauterine resuscitation, if it doesn't come back to normal, definitely we need to expedite birth. So is it that we can put a soft silastic, a smaller 3 centimeter Ventus can be applied? Definitely not, because what is the contraindication here? That undilated cervix is a clear contraindication, as is said by RCOG and ACOG both. It cannot be possible that you do Dewhurst's incisions and do an instrument, or because these are incisions, Dewhurst's incisions are when they are not done in trained hands or not done properly, there is a very high incidence of extension of cervical tears into vaginal fornix, into lateral uterine walls, resulting into broad ligament hematoma and causing tremendous maternal morbidity. So the risks with undilated cervix and assisted vaginal delivery is maternal trauma and the increased risk of blood and blood product transfusions. So the clear contraindications for assisted vaginal delivery are maternal, fetal, and other conditions. So contraindications are first and foremost, which I would really emphasize and would put it at the top of my list, is of operator inexperience. If I don't know how to put a forceps, if I don't know how to put a ventouse, I should not do it. Simple as simple as that. I should ask for help. When I know that this lady may need an instrument delivery, I should ask for my senior or my colleague to come and sit with me for the whole night. That's a different story, but definitely these are not the places where we can experiment at all. Incompletely dilated cervix, certainly, as we discussed. Unknown fetal position on unengaged head. Unengaged head, obviously, high forceps and stations less than 0 are not allowed in modern obstetrics. So unknown fetal position, definitely, because we should know whether it is occipital anterior, posterior, or oblique, because the application of ventouse or forceps and the direction of pull is going to depend on the fetal position. So contraindications are, again, another contraindications, malpresentations like brow and face, suspected cephalopelvic disproportion, ventouse delivery if it is less than 36 weeks of gestation, or if the baby has predisposition to fractures as suggested by the history, that is osteogenesis imperfecta, or the baby is diagnosed with or is suspected to have any kind of bleeding disorders. Certainly in these situations, we should not resort to instrumental deliveries. Like a wise person, we should choose our candidate very thoughtfully and wisely if we want to have safe outcomes. So what is the problem with preterm and ventouse delivery? If it is below 36 weeks, there is a high risk of cephalhematoma, intracranial hemorrhage, subgaleal hemorrhage, and that is why neonatal jaundice. However, between 32 and 36 weeks, there are some people who say that you may put a ventouse, that is outlet ventouse, but certainly most of the bodies, they are not allowing you to put ventouse or forceps below 36, ventouse below 36 weeks. I'm sorry about that. So ventouse below 36 weeks is a strict no-no. So again, we gather our evidence and select our candidate properly. First and foremost, you select your indication, think about your contraindication, and then select your candidate, whether you want to resort to an instrumental delivery or not. Other relative contraindications are vertically transmitted infections. Whenever you are going to experience a traumatic or a difficult instrumental vaginal birth, then it is better not to carry it on, because there can be a risk of vertical transmissions of these infections. And prior repeated fetal blood sampling, if we are doing from the scalp blood sampling, where there is already an abrasion and you put a ventouse there, you are certainly going to have a fetal scalp laceration. So we should avoid applying instrument in these situations. The problem here is obviously medical legal issues. That is what we are all worried about. First is maternal fetal outcome. You don't need a court to tell you that you should feel bad about your delivery or the morbidity that we have caused. We are at a stage where we know what morbidity we are going to, we do feel about the morbidities that we cause, but another important aspect is that if it is an unsuccessful vacuum or forceps or a traumatic birth or a low Apgar baby, we are almost certain that these patients are going to drag us to the court. And there have been incidences of maternal deaths who have been reported, and they have been dragged into the court, and they have made the life of the obstetrician very difficult. So how do we avoid all this to keep ourselves safe? The key is to keep ourselves safe, identify indications and contraindication, select a proper candidate, be safe medico-legally, and at the same time achieve the best outcome for the mother and baby in that clinical situation. The risk of intracranial hemorrhage is very high when you are applying forceps. That is 1 in 66, 64. Again, it is high in ventouse. Second is in CS in labor. We should also note that there is a risk of intracranial hemorrhage when the woman has spontaneous vaginal delivery. It is the lowest. 1 in 1900. So we should keep, this is one of the landmark article, although it is 1999, we quote again and again, because in a spontaneous vaginal birth, you may have a baby with intracranial hemorrhage, and here is the evidence to tell you that there is a risk of 1 in 1900. If you have 2000 births in your institute, one baby may have intracranial hemorrhage, 2000 SVDs in your institute, one baby may have spontaneous intracranial hemorrhage because of the passage of the head through the birth passage itself, isn't it? So these statistics are very useful in counseling the women. So compared with spontaneous vaginal delivery, obviously the vacuum has higher risk of death, intracranial hemorrhage, and any kind of injuries, which include nerve injuries, seizures, CNS depression, or mechanical ventilation for the baby. Death rate of vacuum and forceps is obviously very high, higher than the spontaneous vaginal birth, and that is why we should carefully select our candidates. So looking at other complications which may be caused, the maternal outcomes, that is episiotomy, significant vulvovaginal tear, obstetric anal sphincter injuries, postpartum hemorrhage, or urinary and bowel incontinence, all is higher with forceps than with Ventouse, whereas fecal hematoma, fetal facial or scalp lacerations, retinal hemorrhage, jaundice, subgaleal hemorrhage, and intracranial hemorrhage is higher with Ventouse than with forceps. Skull fracture and facial nerve palsy are known with forceps more often than with Ventouse. So we should keep these complications in mind when selecting the candidate. That is it a very high head? Is it going to need a rotational delivery? Is it going to need a very difficult strong pull? Now, how is strong pull? How do I tell you what is strong and what is gentle and what is moderate traction? It is an inside skill that we all need to learn as we live in the field of obstetrics through years, isn't it not? We say that, okay, this is a strong pull and this is not a strong pull. I cannot come and quantify how you are pulling, neither you can come and quantify how I am pulling or the other person is pulling, isn't it not? So that is why we should keep these complications in mind. And that is why, what is the safest way to do it? Have your prerequisites in the mind. ACOG, RCOG, and every book has told this time and again that until these conditions are fulfilled, do not resort to assisted vaginal birth. That is, cervix dilated, ruptured membranes, fetal head is engaged, position of the head has been well determined. Fetal weight is performed, it is not a 4 kg baby, pelvis is thought to be adequate, anesthesia or analgesia is adequate, maternal bladder is empty, patient has agreed and willingness to abandon the trial of operative vaginal birth and have a backup plan. Because I am not able to lock the forceps, I should be ready to abandon it and resort to the quickest mode of delivery next. Isn't it not? Is it that we are going to pull give traction even when the forceps is not locked? Certainly not. Another important point here has been said is the position of the head. Now, position of the head is well determined. It's very difficult in caput or when there is caput to determine the position of the head. And as we know, the clinical skill as the generations come by is dwindling. RCOG in its new guideline in April 2020 has allowed you to do vaginal, transvaginal ultrasound in labor to determine the position of position means occipito posterior or occipito anterior or occipito oblique. That is the only position. Station, obviously, you should know by doing your digital vaginal examination how away it is from the spine. So it does not say that it will tell you the station, but it tells you that it will tell you how the position of the occiput is. Is it anterior or posterior or oblique or whatever it is? So these are the mnemonics that are freely available on the web. They are by also Advanced Life Support Skills in Obstetric by American Academy of Family Physicians. These are the things we have posters in our labor room. We time and again revise it. Address the patient, ask for help. Is analgesia or anesthesia adequate? Is the bladder empty? Is the cervix dilated? Did you determine the position of the head? Did you think or prepare yourself about dystocia? Is your equipment ready? Is your forceps ready for traction? That is, check your safety points for the forceps. What are the safety points? Are the blades locked? Is the sagittal suture in the midline? Are the blades equidistant from the sagittal suture? Then give gentle traction. Elevate the handle through the curve of Keras. And then think about the episiotomy when the head is crowning, and J, remove when the forceps is available, jaw is reachable. Vacuum, again same, A, B, C, D, E, equipment ready is same. F is place the cup at fontanelles on the flexion point. What is the flexion point? This is too much of detail, but it is somewhere in between the the posterior fontanelle and the anterior fontanelle. Midway between anterior fontanelle and posterior fontanelle, it is the axis through which the fetal head is going to be flexed. Gentle traction, it is telling when should you halt. Then think about the episiotomy and remove when the jaw is visible. So these are easily available on the web. I would not go in more in detail about this, but we should have a labor room poster ready for this. Think about a poster for prerequisites. Think about a poster for forceps and vacuum application, and go on revising this with your staff. So is the clinical condition, is the fetal condition reassuring? Sorry. Is the clinical fetal condition reassuring? Yes. If it is, are the contraction adequate? No, then you should consider oxytocin augmentation. If the mother is pushing effectively, is the delivery of the baby's head arrested by the perineum? Does she need an episiotomy? Is the bladder empty? Is the position of the and the station of the head favorable? Should I resort to a forceps delivery? So these are the flow chart of the questions that should come in one's mind if we want to ensure the safety of the delivery of the mother and the fetus. So assess and then think about the operative delivery. Is she feasible for operative delivery, or should I resort to cesarean section? Is cesarean section safe at the station and at the position of the fetal head that is there now? If it is not safe, believe me, we all have seen the morbidity caused by wrongly performed cesarean section at wrong station is tremendous. We may have extensive cervical tears which may extend into the vagina, and we may suture those that cesarean section wound forever. If it is instrumental delivery, what kind of instrument should I do? Am I trained enough or confident enough to do this instrumental vaginal delivery? So the choice of instrument is determined by the most appropriate to the clinical circumstances. Suppose it is a preterm, then I would like to use forceps than for a ventouse, isn't it not? And our level of skill. This I repeat so many times. The operator's skill is the most and the prime important. So what are the conditions where you would prefer a forceps over ventouse? We all know, we have studied this. Poor maternal efforts, operator or maternal preference when either instrument would be suitable. Suppose there is a condition where I can put a ventouse or a forceps, then I would prefer a forceps, or the other person may prefer a ventouse. That is a different story. If it is a large amount of caput, then the ventouse is known to slip, or if there is a marked active bleeding from the fetal blood sampling site, then we would prefer forceps over a ventouse. If it is less than 34 weeks, then definitely we should think about forceps rather than ventouse. Obviously, after coming head of the breech and face presentation, we are not going to think about ventouse, we are only going to think about forceps. Operator knowledge and skill is of prime importance, and it will definitely, more than the instrument used, it is the primary thing which will determine the outcome of the mother and baby. So wherever the ventouse is preferred over forceps, when it is urgent to lift out the delivery without any previous analgesia, because for forceps we definitely need some kind of analgesia. If you are going to perform a rotational delivery, the morbidity caused by forceps is much higher than that of a ventouse, or if the operator or the mother prefers ventouse over a forceps, then I would prefer a ventouse. In a clinical situation where both can be used, then definitely ventouse is preferred by many because it can be applied very easily. So this is the chart that we all use. Think about the location where you want to deliver them, whether you want to deliver them in the labor room or you want to do it in the theater. If the rotation is less than 45 degrees from the midline, if the station is at +2, there is no caput, no molding, and there are good uterine contractions, and the mother is very cooperative, then I would do it in the delivery room. Whereas if these conditions are not fulfilled, I would take her to the operation theater if it is a rotational delivery, or if there is a risk that this may fail and I may have to resort to cesarean section. Straight away, if cesarean section, if the head is above the spines and there is so much caput and molding that I'm not able to determine the position of the fetal head, then definitely I would resort to a cesarean section. So this chart, if we have in our mind, it will be helpful. So we all must note that higher rate of failure of instrument is there if the maternal BMI is high or the baby's weight is more than 4 kg in occipito-posterior position or in mid-coitus delivery. We all in modern obstetric definitely don't resort to the last 3 situations where we would like to take a chance and cause more morbidity. These are the conditions where we may directly resort to a cesarean section. There is a woman who has had previous normal delivery of 4.4 kg. I would allow her 4 kg. Occipito-posterior position, progressing well, no fetal compromise, good maternal pelvis, I would allow her. And mid-cavity delivery, if I'm not trained, I would not do it. In Fernandez Hospital, we don't do mid-cavity deliveries. We do low and outlet forceps deliveries. Dr. Padmaja, we have two doctors, Padmaja and Vinata, who do rotational deliveries. So only they are there to do rotational deliveries. Otherwise, all of us do forceps and venous deliveries. I mean, low forceps and outlet forceps and venous deliveries. So the prime importance is that we should know when to abandon the instrumental delivery. If there is no progressive descent with each pull, it is I'm pulling, but there is no progressive descent, or after 3 pulls, it is not imminent that delivery is going to be there, or and with an experienced operator, these conditions are fulfilled, then we should abandon this. Alternatively, with one pull or one pop-off, if there is no progressive descent and the operator is inexperienced, he or she should immediately call the senior to be there in the delivery room. It is not that if I don't know anything, I finish all this, finish 3 pulls and 3 pop-offs and then call my senior at the last moment where nobody can actually do anything, because by the time a cesarean can be resorted to, the fetus will be in tremendous morbidity. So what are the benefits? Obviously, we need to know about this and counsel the patient that the assisted vaginal delivery is known to be, as compared to cesarean section, is known to reduce complication rate, analgesia requirement, hospital stay, quicker recovery, and increased likelihood of spontaneous vaginal delivery in the next pregnancy. So essential conditions, we should know that we should be confident and competent with this. Knowledge and experience should be there to manage the complications if at all they arise from this, understand the anatomy of birth canal, and have clinical and technical skill. So in medical legal issues, we have 4 critical spheres of concern. Did you select the patient correctly? Did you take the consent? Do you know the technique, and did you document the events properly? So in next 5 minutes, we will go through this and we end this. So how do you select your patient? This is the gist of my talk now. Have your patient selection correctly. Note down the maternal and the fetal indication. Is there any contraindication? Is the clinical situation appropriate for a assisted vaginal delivery? So select your patient properly. So whenever you have think about the risks and benefit. Is it that going for a cesarean section at this station is going to be more dangerous than a instrumental delivery? If the answer is yes, then we should not resort to cesarean section. Is it that the instrumental delivery is going to be difficult and traumatic for her at this clinical situation and at this station, then we should resort to cesarean section. Did we take consent? Elicit the patient desires. Did you discuss with her in antenatal period that just in case the need arises, do you prefer a ventouse over a forceps? They would definitely. So if we give them information and open the door for discussion, they would want to discuss these things, because after you do a delivery, there may be a time when the patient may say that, oh, my relative also had the same traumatic delivery. Then if we have known this, then we would have avoided this, isn't it? Somebody in the family had a traumatic forceps delivery, then I would like to avoid forceps lady. So ask her desires and document in her birth plan. By 32 or 34 weeks, we must discuss this with all the women, especially if they are primary pregnant. Did you take the consent? Information, as we said, has to be given in the antenatal period, and whenever the time permits. Suppose it is prolonged second stage or a delivery to cut short maternal second stage of labor because of maternal indication, then obtain a written informed consent. I will share my consent form with you. And is your technique proper? Are you well trained? If no, then we must go back and train ourselves on the mannequin. Nowadays, mannequins are available all over the place. It is imperative that we buy mannequins if we are in an institute and practice our technique and our moves on the mannequin rather than practicing on the patient herself. And perform these prerequisites. I gave you the prerequisite checklist. So perform these prerequisites before we resort to a instrumental delivery. And last but most important, document. If there is anything that would save you, it is the consent discussion and documentation of each and every event, isn't it not? So because it is the important witness, the acute events that have happened, you would immediately document in your case notes, and you can easily take those out and refer to that when they come back to you after 1 or 2 years. So if I talk about the indication, pre-application findings, timing of application, if there were any pre-existing complications, suppose there was already a vaginal bleeding or a tear or cervical tear, then if I apply forceps, it is not that it is going to it is not that because of my forceps there is a tear, isn't it not? And how is the condition of the newborn and the condition of the mother once the delivery is complete? So this is the consent that we all use at Fernandez Hospital, which says that what are the intended benefits of it, what are the serious risks to the mother, to the baby, and what are the frequent, very common risks, and if there is any extra procedure. And also it is written that there is a possibility of proceeding to cesarean section in case the attempt of operative vaginal delivery fails, and then document, sign, and take her signature, and after she signs this, then on the other side of the form, after you perform the operative vaginal delivery, you can see that we have drawn this. It is occipital anterior position, 0/5 palpable, full dilatation, examination findings, prerequisites have been completed, indications, classification, well-being of the CTG, if multiple instruments were used or not, and how was the procedure done, how was the maternal effort, how was the traction given, was the application easy, how many pulls were there, pop-offs were there, and post-delivery care. So if we document this, there is no need to stress our brain to remember so many points. Each institution, these forms are easily available at the RCOG website. You can tailor make it to your institute and have it in your institute. And so that we just fill up one page and it is just circle and dash, and that is all. The entire operative vaginal delivery record is there. You don't have to write pages and pages of notes. Last but not the least, document the baby's condition at birth by documenting cord blood gases. This all is also there, so that it is very objective evidence of fetal well-being at birth. Apgar score is again subjective, cord ABG is objective. So the best way to prevent an accusation of medical malpractice is to avoid, first and foremost, there is no running away from developing strong clinical skills, understand the role of operative vaginal delivery, develop your own protocols, and consider the woman's preferences. Suppose the woman says that I don't want Ventouse, but you go and put Ventouse, she is not going to be happy about her birth at all. Then make all the charts, add all your notes and document your findings, and debrief the woman after you have completed the birth. That why did you want to? So there are times to say that the baby's heartbeat was dropping, so I could not explain to you in detail, but let me explain. This is what I did. At that time, I could not explain to you in detail. Manage if there are any complications. Tell about the prognosis for future delivery also. To conclude, when there is an urgent delivery required and assisted vaginal delivery is possible, we should opt for an instrumental vaginal delivery that is deemed to be safe for that clinical situation. So, although it is present that forceps is quicker than Ventouse, there may be clinical conditions where one instrument is better than the other in the given clinical situation. So, to conclude my talk, I stress upon the point that instrumental vaginal delivery have their own role in modern obstetrics if we want to reduce the incidence of cesarean section rate. Thank you. Thank you so much.
Thank you, Dr. Anisha. Excellent presentation. Excellent presentation.
Thank you,
very practical. Lots of carry-home messages, and especially the documentation and then the consent, how it is to be taken. You really stressed it, and every point, like including how much pressure to be pulled, everything you have stressed on. I think it has really helped all of us. Any questions?
Yes, ma'am. There are questions in the chat box.
Yeah.
How safe are disposable vacuum delivery instruments?
Sorry, I cannot.
How safe are disposable vacuum delivery equipments?
Yes, we do use Kiwi cup. They are called, the company is called Kiwi. They are called Kiwi cups. They are very safe. They have got all the advantages of the Silastic cup, and of the hard bird anterior and bird posterior, the metal cups that we used to have. So they are like a curved cup. So they have a wider base and a narrower mouth. So the caput that is formed inside is the signon that is formed inside is unlikely to slip, and it creates good pressure. It has got the meter on which you can measure the amount of pressure that you are building. It builds the pressure gradually, and when you release the pressure, it releases the pressure gradually. And for single use, so that is the best thing. I would not like to use anything on me which has been used on anybody else. So I would not like to use the same for my patients also, isn't it not?
Yes.
1,000 rupees nowadays is not a big thing. It is 3,000 rupees, which is something very big for some clinical settings or some institutions. But in majority of institutions, it should, wherever there is not a problem, it can be used.
Yeah. So what are the practical tips for a good application of Venteuse, ma'am? We want the practical tips, like what you want to advise our viewers.
I would actually go to my slide which says that look at the prerequisites. Go at the prerequisites and follow this. In our hospital, we follow this: A, B, C, D, E, F, G, H, I, J. These are the practical. So address the patient. Tell her that, hello, Mrs. Whatever, your baby's heartbeat is dropping, and right now, in a vaginal examination, I would like to put a Venteuse. Ask for help. The neonatologist and whatever. Is the anesthesia adequate? Is the bladder empty? Is the cervix fully dilated? Did I think about the position of the head? Did I think about the shoulder dystocia? So we use this.
Yes, ma'am. Then are silastic cups or metal cups better for Venteuse?
So the metal cups are more traumatic, as has been documented. Silastic cups are better on the fetal head. They are softer on the fetal head. So nowadays we all prefer silastic cups only.
Okay. If there is a urinary retention after instrumental vaginal delivery, when should we put in a Foley's catheter?
Okay, urinary retention itself is a big topic, but urinary retention first and foremost is within 2 hours of any delivery, vaginal or instrumental or spontaneous. We should encourage her to pass urine. Sometimes there may be delayed passage of urine because of the epidural analgesia that they take, but we must still nevertheless encourage them to pass urine. But in case they are not able to void within 6 hours, then we may have to catheterize them, ask them to void urine, look at the post-void residue. If it is more than 150 ml, we catheterize them for 24 hours and then remove the catheter and again look at the post-void residue. In this, we should rule out vaginal hematomas, anything that is causing pain and retention of urine. We must rule out all that and then catheterize them.
How we must prevent the pop-ups in the Venteuse application? Many times we see, how can we practically reduce them?
Yes, there have been studies which have shown that there are pop-offs when you don't apply the Venteuse properly on the flexion point. That is inadequate application. If it is here, obviously on one of the parietal bone, it is going to pop off. If it is not on the proper flexion point, it is going to pop off. Second is the direction of the pull, and third is the pressure built. So these are the 3 main factors that we have to take care to avoid any pop-offs.
Yeah. One last question, ma'am. If there is a lateral vaginal tear after forceps application, how should we make sure that it has not extended into a supralevator bleeding or hematoma?
The first and foremost is don't finish your procedure before you look at the apex of any tear. It is not that you have not seen the apex and still you sutured whatever we can see and then I left her alone. We don't know how deep inside the tear is extending. So the primary dictum is to not finish the procedure. You may have to take her into the operation theater, give proper anesthesia and look at the apex, but we need to look at the apex. Unless we look at the apex of the tear, we should not let her go alone. Let her go out of the labor room.
Thank you, Anisha ma'am, for the excellent talk.
Thank you, everybody. I would like to thank the organizers, you, Dr. Geeta, Dr. Kasturi, and KVG Medical College, for allowing me to share what we do in Fernandez Hospital. Thank you so much.
I just wanted to ask Anisha, how often you have encountered supralevator hematoma?
The complications that we have most often in our institute are obstetric anal sphincter injuries, like Dr. Chandrasekhar has said.
Yeah.
Instrumental deliveries, most often we are having, most of them, the most common complication is obstetric anal sphincter injuries, followed by cervical tears. Thankfully, in my last 12 years of practice, I have not seen any supraelevator hematomas. But cervical tears, fornicial tears, all this we have seen. Very rare, but most often is obstetric anal sphincter injuries.
Yes, because the supraelevator hematoma is very dangerous. There
It
is
is
the one which is causing deaths and the sudden postpartum collapse, unexplained hypotension, etc.
It has been documented. It has been seen that these are found when we apply instrument at undilated cervix.
Yes, yes.
So we should avoid doing that.
Yeah. Thank you, Anisha. Excellent presentation. Yeah.
Thank you so much. Thank you, everybody.
Thank you. Thank you, Kasturi ma'am, and thank you, Vidya ma'am, for chairing these sessions. Now we move to our next session on PPH and obstetrician's nightmare.
A very good afternoon to everyone.
One second, ma'am. Yeah. For all those just joining us, you have logged into the National E-Conference on Labor and Birth, organized by the Department of KVG Medical College and Hospital, Sulya. So we move on to the second session of the day. We have 3 talks for this session. The first talk is by Dr. Rekha Ratnani. Chairing this session will be Dr. Swati Agarwal, Associate Professor and Nodal Officer, GSSK and Lakshya, Department of Obstetrics and Gynecology, Lady Hardinge Medical College and SSK Hospital, New Delhi. Ma'am has over 40 publications in national and international journals to her credit. She was a university topper in final year MBBS and she has been awarded various prestigious awards by FOGSI. Welcome, ma'am. The coordinator for this talk is our own Dr. Veena N, Senior Resident, Department of Obstetrics and Gynecology, KVG Medical College and Hospital. I would like Dr. Swati Agarwal to introduce our speaker and take over the session. Over to you, ma'am.
Thank you so much for the kind introduction. It is my great pleasure to be a part of this wonderful conference, and I thank the organizers, Dr. Geeta and Dr. Bhavya, for giving me this opportunity to be a part of this wonderful conference. This next topic that we are going to deal with is a very, very important topic. It's a must-know skill for every obstetrician, and it is, in true sense, a nightmare. For every obstetrician, all the obstetricians about how to go about managing this complication. And to give a talk on this very important subject, I have my great pleasure of inviting a very esteemed speaker, Dr. Rekha Ratnani. Dr. Rekha is presently the professor and head of the Department of Obstetrics and Gynecology at SSIMS Bhilai, also head of IVF and endoscopy unit at High Tech Super Speciality. She is the ex-professor and head at CCM Medical College, Durg, and has had held various senior positions in various other hospitals. She has many publications and presentations to her credit. She's been an examiner for MBBS and MD courses for the last 10 years and has been the past president of the Durg Obs and Gynae Society, as well as past secretary of the Raipur Obs and Gynae Society. So without further ado, I hand over to Dr. Rekha Ratnani to begin her talk. Dr. Rekha, please.
Thank you so much for my kind introduction. I would also like to thank the organizers for giving me this opportunity. Yes, you're absolutely right that it is an obstetrician's nightmare. PPH is something which I believe has caused a lot of anxiety in our mind one day or the other during our obstetric career. And all pregnancies, you know, even if they are So all pregnancies are at risk of PPH even if no predisposing factors are present. We really are stuck many a times in cases where we believe that nothing wrong would do. And when we say that it is around 2 lakh women who die from PPH every year, I think we are grossly underestimating it, because our best estimate is definitely a gross underestimate, especially when PPH is concerned. The paradox is that, when we look at the data from developing countries, we see that, deaths because of pregnancy-related are much less. Like pregnancy-related mortality ratio in US is only 17.3 per 1 lakh live births. But when we look at developing world like ours, there are many countries who have more than 1,000 women deaths per 1 lakh live births. So why is PPH a concern? We all know it is very important topic, and WHO estimates that of all the maternal deaths which are occurring every year, around 25% of it take place in India. And nothing, it is nothing that we should be proud about, because it is accounting to nearly 1/4 of all maternal deaths all over the world. We do face PPH in about 5% of all deliveries. And the worst thing is that the death occurs within 4 hours of the delivery, indicating that it is a consequence of 3rd stage of labor. Now, we know that diagnosis of PPH is usually reserved for pregnancies that have progressed more than 20 weeks. Coming to the definition, loss of blood more than 500 ml from the genital tract post-delivery of a baby in case of vaginal delivery, and more than 1,000 ml after cesarean delivery, or maybe excessive pervaginal bleed that causes hematocrit drop more than 10% that require immediate transfusion. These are the definitions which we read, but actually it is arbitrary and very, very problematic. Because, when we look at estimate of blood loss, it is very subjective and generally inaccurate. The studies suggested that caretakers, they consistently underestimate the actual blood loss. Another proposal suggests using a 10% fall in hematocrit value to define PPH. But again, this change is dependent on the timing of the test and the amount of the fluid resuscitation which we have given. More importantly, I think the diagnosis would be retrospective, perhaps useful for research, but not so in the clinical setting. We are so shocked at the amount of blood loss which we are seeing that it hardly, comes to our mind that let us see what is the blood loss and then treat accordingly. Also, another important factor is the differing capacity of individual patients to cope up with this blood loss. A healthy woman, we all know, has 30 to 50% increase in blood volume in a normal singleton pregnancy, and she's much more tolerant of blood loss than a woman who has pre-existing anemia or underlying cardiac disease or volume contracted condition secondary to dehydration or preeclampsia. So for these reasons, various authors have suggested that PPH should be diagnosed with any amount of blood loss that threatens the hemodynamic stability of the woman. Now, frequency. The frequency of PPH is directly related to the management of 3rd stage of labor. Now, we know that this 3rd stage of labor will be starting from completed delivery of the baby until the complete delivery of the placenta. Data from several sources, including several large randomized trials performed in industrialized countries, indicate that, in countries, in places where active management of labor was practiced, they were able to bring down the incidence to 5% versus when, it was 13% when nothing was used. Our prevalence rate of PPH of more than 1,000 ml was reduced to 1% when active management was practiced versus 3% when expectant management was used. Now, again, the question is why PPH is more rampant in developing countries. One of the reasons can be lack of widespread availability of the medications which are used in the active management of 3rd stage. Because we know that the same drugs which we are using for prevention or prophylaxis against PPH are actually going to help us again in the management of PPH. There can also be lack of experienced caregivers who might be able to successfully manage PPH if it occurred. We all know that at PHCs or primary healthcare centers, there is scarcity of doctors or trained health workers, and which can be a major contributory factor. Then coming to blood transfusion facilities, we all know that blood banks are not that frequently being attached to the primary health centers or at the primary healthcare level. So comorbidities, if they are already there, suppose patient is already pre-eclamptic, anemic, which we know that they are more common in Indian population. These are the patients who are actually going to fall prey to PPH because their tolerance to blood loss would be much less. So on an average, we can divide them into two types. You all know primary PPH and secondary PPH. Primary PPH, we know it occurs within 24 hours, and secondary is after 24 hours to 12 weeks actually after delivery. So when do we call a primary PPH to be minor PPH or a major PPH? If it is between 500 to 1000 ml with no clinical shock, we say that it is a minor primary PPH. And if it is more than 1000 ml, definitely it is a major primary PPH. Now, why bleeding occurs? We know that the placenta, which is removed, it relieves behind a 20 centimeter diameter wound that continues to bleed if uterine musculature does not contract and stay contracted, especially in cases of atonic PPH. Now, how much time do we have? Sadly, we don't have much time because it is going to give us only 2 hours in which we can actually save the patient, or we might fail to save that patient. And it is too less a time to act. So in a way, we can say that PPH is a nice way of saying that we let women bleed to die. Actually, if you don't do anything, you can easily see that patient passing in front of your eyes. Visual blood loss estimation often underestimates, as I emphasized, and more accurate methods would be blood collection drapes or weighing swabs. Now, coming to assessment of blood loss, it is very, very difficult, but yes, we have to do it in spite of the fact that it may be inaccurate. So there was this study which said that after simulated vaginal delivery, there was 16% underestimation at 300 ml loss, whereas this increased to 41% underestimation when the blood loss was more than 2 liters. Accurate methods such as blood collection drapes for vaginal deliveries, weighing of soaked swabs, active periodic estimation, a written and pictorial guide to aid visual estimation in labor wards may actually prime the students and the staff so that, on a daily basis, on a routine basis, they would learn to estimate this loss. So on a shorter note, I can just give a small diagram where it is like if a pad is fully soaked, it means it is 120 cc blood which she has lost. And if it is a large abdominal pack, somewhere around 450 cc blood which she must have lost. We should also remember to define massive obstetric hemorrhage, which is variably defined as blood loss from uterus or genital tract. If it is more than 1500 ml, or a decrease in hemoglobin of more than 4 gram%, or acute loss requiring more than 4 units of packed cells, or any hemorrhage which is associated with hemodynamic instability. We all know we cannot forget to our students to forget these 4 T's: tone, tissue, trauma, and thrombin. Uterine atony, which contributes the first and the most common factor for atonic PPH, is basically one of the major reasons for PPH. It can be secondary to uterine hyperdistension. As we all know, it can be because of a macrosomic baby, or due to multiple pregnancies, previous PPH, or maybe even because of prolonged labor. We should not forget that many a times the drugs which we use, halogenated as anesthetic agents, nitrates, NSAIDs, Maxulf, Duodenolons and all, Nifedipine, which we give for, as tocolytics, we should not forget that they do add to the atony. Recent data has definitely now said and ruled out that grand multiparity is not an independent risk factor for PPH. BMI is yes associated with obesity, and they said that as the BMI increases more than 40, the risk was 5.2% with normal delivery and 13.6% with instrumental delivery. Other causes include placental implantation site in the lower uterine segment. It can be secondary to, endometritis, endomyometritis, septicemia. It can be because of, hypoperfusion, hypoxia, or cuvalier uterus after abruptios, hypothermia due to massive resuscitation, or even if it is exteriorized for a longer time during cesarean section. Then coming to tissue, I think the most important factor would be retained placenta. Retention of a portion of placenta is more common if there has been a succenturate placenta and a lobe has been retained there. If we have not been very careful while going through our sonographies, and it has been seen that it is more common if the patient has delivered before 24 weeks. The chances of retained placenta are more, and it is more common in cases even if they are spontaneous or induced, but they are less than 28 or 24 weeks. Now, recent trials say that if you use misoprostol for second trimester termination of pregnancy, it will decrease retention of placenta compared to techniques which were using, intrauterine instillation of prostaglandins or hypertonic saline. Trauma, we know that it causes around 5 to 10% of cases. Most common it can be because of vacuum or forceps, as my previous speaker emphasized nicely. Cesarean section, yes, I would emphasize on this also, because cesarean delivery results in twice the average loss, we all know. But remember, when the incision is given in the poor contractile lower segment, it bonds to tear off very easily if it has thinned out. So I think PGs must have noticed in especially one previous section or two previous sections, or when it is about to rupture, or it is it has given away, and when you want to suture these scars, they are very difficult. They just tear apart and they keep on bleeding in spite of these sutures are given. So there has to be a technique which has to be taught well during the PGs, where because the upper segment, upper incision layer is thicker and the lower flap is very thin. There is vasospasm and clotting for hemostasis, which does affect. I will also emphasize about the episiotomies. When episiotomies are given in the early, by early students or the fresh students, many times it just extends if not proper support is given in the perineum, or if no proper flexion of head is maintained during vaginal delivery, and head just comes up and extends out. So there are these periurethral tears which are very common if our freshers are taking the deliveries. Uterine rupture, again, in a poor setting, in a rural setting, yes, we do overcome this problem very frequently in our setup also. We should also never forget to go through a detailed history, because the patients who have undergone myomectomy surgeries or uteroplasties for congenital abnormalities, or corneal and cervical ectopic resections, or perforation of uteruses during dilatation and curettage biopsies, they do cause retained placenta. I have a patient in my department ward right now with retained placenta. She has only history of 2 abortions, and in those 2 abortions she had undergone dilatation and evacuation, and we have now put her for methotrexate, and hopefully she'll do well. But yes, we shouldn't forget that these are the patients who can create problem. Trauma after very prolonged and vigorous labor, especially if patient has relative or absolute CPD, or if she has been stimulated with syntocinon or prostaglandins for very long, they do cause traumatic vaginal deliveries. The trauma may also result as secondary to attempts to remove a small bit of placenta which is remained there, if you try to remove it manually or with some instrument. So you should be very, very careful while doing that. And if there is a retained placenta after the baby has been expelled, I think all of you must be knowing it, and it is very practical to go for intra-umbilical vein saline or oxytocin or saline misoprostol injection, which can prevent you to remove it manually. Cervical lacerations are very common. I will not go into details because this has been taken care of by my previous speaker. Vaginal side wall lacerations, yes, it is very common secondary to forceps. If the forceps is not locked properly, if it is not a proper outlet forceps, if it has been applied little early and then you try to pull it out, it is going to cause massive vaginal side wall lacerations, and they can actually extend in the lower uterine segment also. I have seen it happening during my, when my PGs apply it. So we have to be very, very careful while applying forceps. Yes, you all know that abnormalities can be pre-existent or acquired. Thrombocytopenia may be related to pre-existing diseases if she is having idiopathic thrombocytopenic purpura, or it can be secondary if she is a patient of HELLP syndrome. So we have to keep eyes open, and we have to have a high suspicion of PPH if this patient is having abruptio, or if she is going towards DIC or sepsis. Yes, we will be troubled by her because she might go into PPH after delivery. So coming to one of the causes which I'll be highlighting, that would be uterine atony, and PPH in a previous pregnancy is the major risk factor, and every effort should be made to determine its severity and cause. In a recent trial in US, birth weight, labor induction, augmentation, chorioamnitis, max self use, and previous PPH were actually, they said that these are the major causes of PPH if you want to elaborate. Now coming to the prevention, we have to identify the risk factors that may present antenatally or intrapartum period will help us to plan the delivery. As I said previously in my opening statement that most of the cases of PPH have no identifiable risk factors. But yes, the major thing, one thing which we can really emphasize is that active management of third stage of labor will lower the maternal blood loss and reduce the risk of PPH. Active management of third stage, I won't go into the details because it was taken care very well by my speaker yesterday. But yes, we have to again re-emphasize use of uterotonics, uterine massage, and control contraction. I would definitely like to add few slides, because when I was listening to my previous speaker yesterday, that was WHO recommendations 2012, but there are few changes in recommendation of WHO in 2018. So I thought I should speak about it. Now, the latest 2018 recommendation has said that for prevention, you can go for 10 international units, IV or IM. Carbetocin, which yesterday speaker told us very nicely, it can be used, but it is, because it is heat stable, it can be kept above like more than 30 degrees temperature, but it is costly and it is still not available in India. Misoprostol, I want to emphasize that previously it was 600 micrograms, but the various studies have said that it gives good result for prevention if we use it only 400 micrograms. So this is something which we can practice. They have said that if still you don't have these drugs, then use of ergometrin 200 micrograms IM/IV. If you rule out all the contraindications like hypertension, anemia, and cardiac diseases, you can go for it. Or even combination of oxytocin and symptometrin can be used for prevention. There is definitely no for injectable prostaglandin F2 alpha, that is carboprost, for prevention of PPH. But they said that in settings, how would you decide? So they said that in settings where multiple oxytocin agents are available, go for the showstopper, which is oxytocin. But in settings where you know that the injectables cannot be kept in proper temperatures, then definitely you should ask for misoprostol as a second degree, because it can be easily used by skilled health personnel and it is very cheap. So recommendations for prevention of PPH regarding cord management and uterine massage, they are very clear. They say that where the skilled birth attendants are available, who know how to do it, please teach them control cord traction, because if you if you are able to actively manage the third stage, definitely control cord traction is going to help. But they say that if skilled health birth attendants are not available, they say please do not ask them to go for control cord traction, because it is in fact going to cause more harm. Coming to late cord clamping, they said universally it has been recommended that you have to clamp the cord late after 1 to 3 minutes after birth, and it has got strong recommendation. Early cord clamping less than 1 minute after birth is not recommended until and unless the neonate is asphyxiated and you really want to move that neonate to the resuscitation room. Sustained uterine massage is not recommended as an intervention to prevent PPH who have already received prophylactic oxytocin. But yes, you have to keep on putting your hand on her abdomen to find out whether the uterine tone is maintained or not. So control cord traction is regarded as safe, and it says that the average reduction of blood loss is around 11 ml, and the duration of third stage of labor has been reduced by 6 minutes. And if you want to use ergot alkaloids like methargine for prevention of PPH, then CCT, that is control cord traction to minimize placental retention, is regarded as essential, because otherwise it will cause retention of placenta. There is insufficient evidence to determine the benefit or risk of control cord traction when used in conjunction with misoprostol. Now coming to recommendations for prevention of PPH in cesarean section, again it is same, oxytocin IV or IM, strongly recommended. Cord traction is strongly recommended for the removal of placenta in cesarean section. So it has to be control cord traction during cesarean section also. Now, remarks, they said in terms of blood loss, there was not enough evidence to recommend oxytocin infusion over IV bolus injection. So to avoid adversely hemodynamic effects considered, if an IV bolus injection is used, a slow injection rate is preferred and a rapid injection rate should be avoided. The combination of oxytocin infusion after an initial IV bolus after cesarean delivery reduces the need for additional uterotonic agents. Carbetocin is more expensive than oxytocin, but it is definitely better. Now coming to management of PPH, yes, communication, resuscitation, then monitoring, investigation, and arrest the bleeding. Communication, very, very important. You should alert all the relevant professionals, all the HODs, all the unit heads, whoever is available, just call for help. A major PPH can be averted if you activate a red alert or if you activate the entire team. Call the team of experienced gynecologists. If you're practicing privately, call all your friends, call team of anesthetists, alert OT team, inform blood bank, ask them to be ready with blood and FFP, delegate one member to keep minute-to-minute record of vitals and blood loss. Very important, never forget, communicate with patient and family members with clear information on what is happening. Do not forget the ABC of resuscitation. The measurement of resuscitation depends on the condition and degree of shock. Assess the airway and breathing. Give oxygen 10 to 15 liters per minute with face mask regardless of maternal SpO2. If airway is compromised due to impaired conscious level, need to intubate with anesthetic assistance. Evaluate circulation. Remember, 2 wide bore cannulas, 14 or 16 gauge, you have to put. If there is PPH, you have to put 2 wide bore cannulas, gray or green color, not pink or blue. Take 20 ml of blood for blood count, coagulation profile, RFT, LFT, fibrinogen, grouping cross-matching for 4 units stat. Position the patient flat, give a lateral tilt, keep the patient warm, catheterize the patient, give crystalloid infusion, that is Hartmann solution, and in major PPH, transfuse blood as soon as possible. Now, until blood is available, total volume of 3.5 liters as we teach, crystalloid infuse up to 2 liters of warmed crystalloid Hartmann solution, Ringer, you have to give around 2 liters, and about 1 to 1.2 liters of colloid as rapidly as required if blood is still not available. You may require disseminated intravascular regime, that is 4 units of FFP for every 4 units of packed cell, or if her PT or APTT is more than 1.5 that of the control, or if platelet is less than 50,000, you have to give platelet concentrates. If fibrinogen level is less than 1 gram per liter, then you have to transfuse cryoprecipitate also. Aim is to restore both blood volume and oxygen carrying capacity. Volume replacement must be undertaken on the basis that blood loss is often grossly underestimated. I would again emphasize that. The therapeutic goals of the management of massive blood loss is to maintain hemoglobin more than 8 gram%, platelet count at least 75,000, PT should be less than 1.5 that of the control, APTT should also be less than 1.5 times that of the control, and fibrinogen, you have to maintain it more than 1 gram per liter. Now, role of recombinant factor 7A therapy. It is used in treatment of hemophilias. It is used in reducing the bleeding in PPH. In life-threatening PPH and in consultation with a hematologist, you can think about it. Dose is 90 micrograms per kg. Now, role of antifibrinolytic drugs, there is definitely role of tranexamic acid in obstetric hemorrhage. Now, there was this crash to trial, reduced death due to bleeding with no apparent increase in vascular occlusive events. Subgroup analysis showed that tranexamic acid was only effective when given within 3 hours of injury. In 2012, WHO guidelines recommended that tranexamic acid should be used for the treatment of PPH when uterotonics fail to control the bleeding or when the bleeding is thought to be due to trauma. The evidence of this recommendation was extrapolated from trials in surgery and trauma, showing that it is a safe option. Now, coming to the women trial, in which they underwent the efficacy and safety of tranexamic acid in PPH, patients were randomly allocated to receive 1 gram of tranexamic acid or placebo by slow IV injection, and investigators were advised to give 1 gram in either in 100 ml of saline of tranexamic acid intravenously at a rate of about 1 ml per minute. And if bleeding continued after 30 minutes or it stopped and restarted after 24 hours of the first dose, a second dose of 1 gram of Texakyne or tranexamic acid was given, or placebo was given. So what was the conclusion? The results supported the inclusion of tranexamic acid in WHO treatment guidelines for primary PPH. It supported, but it suggested that treatment should be given as soon as possible after onset. Now, coming to WHO recommendations 2018 for the treatment of PPH, they clearly say that it has to be intravenous oxytocin. It is nothing but IV oxytocin alone is the recommended uterotonic drug for the treatment of PPH. Strong recommendation and moderate quality evidence. If intravenous oxytocin is unavailable, or if the bleeding does not respond to oxytocin, the use of IV ergometrin or oxytocin ergometrin fixed dose or a prostaglandin drug, including sublingual misoprostol 800 micrograms is recommended. The use of isotonic crystalloids is recommended in preference to use of colloids for the initial IV fluid resuscitation of women with PPH. The use of tranexamic acid is recommended for the treatment of PPH if oxytocin and other uterotonics fail to stop bleeding, or if it is thought that bleeding may be partly due to trauma. Now, coming to monitoring and investigations, take 20 ml of blood, I told as previously. Monitor her BP and pulse rate every 15 minutes if it is minor. Continuously, if monitor BP, pulse rate, respiratory rate in major PPH. Use oximeters, cardiac monitors, automated BP recordings. Put a Foley's catheter to monitor the urinary output, as well as we put it in immediately as soon as patient is having bleeding. Anesthetic management, yes, we need an an anesthetist by our sides because we need to assess, we need to initiate and continue resuscitation. So anesthetist by our side is always a great help to restore the intravascular volume and provide an adequate anesthesia. Even if there is a mild cardiovascular instability, then definitely it is a relative contraindication to regional anesthesia. And then blockage of sympathetic system can potentially lead to worsening hypotension. So general anesthesia is more appropriate. Ventilator with good oxygen, high oxygen concentration should be by your side. Arrest. So arresting the bleeding depends on the cause of the bleeding. Commonest cause, as you all know, is uterine atony, and we need to arrest the bleeding by mechanical means, pharmacological means, or surgical means. Mechanically, yes, bimanual uterine compression to stimulate uterus to contract. Yes, we should do it. Everybody knows it. It should be taught in during undergraduate teaching also, or it should be taught in PG teaching very well. What about the recommendations 2018? Yes, WHO says uterine massage is recommended for the treatment of PPH. Coming to aortic compressions, if she's bleeding and you want some time before shifting her, or you want to do some arrangements and you want to stop the blood flow, yes, the recommendations are that use of external aortic compression for treatment of PPH due to atony after vaginal birth is recommended as a temporizing measure until appropriate care is available. Non-inflatable anti-shock garments. Use of non-pneumatic anti-shock garments as per WHO recommendation 2018 as a temporizing measure until appropriate care is available. Weak recommendation. Pharmacologically, we know that we use IM Synto, then we repeat, but recommendations are very, very clear that for IV oxytocin. So WHO recommendations, again, I would emphasize IV oxytocin alone is the recommended uterotoxic drug as first drug of treatment for PPH. Then I have again told you that if it is, not responding, then you can go for combinations or go for sublingual 800 micrograms. Now coming to if placenta is not expelled spontaneously, then definitely I had mentioned this previously also, treatment of retained placenta. In this you can go for prostaglandin E2 alpha for the management of retained placenta, but it is not recommended. And whenever you feel there is retained placenta, don't forget to give a single dose of antibiotics. Packing recommendation is absolutely no recommendation for uterine packing after birth for atony. Now coming to surgery, if pharmacological management is failed and you don't have time because you have to really rush and keep on trying one after the other, so it depends on the circumstances and the amount of bleed or the time which the patient is giving you. If the pharmacological management is not responding, just shift to the balloon tamponade. There are various methods. The Bakri balloon, it is very costly. We don't use it in our setup. But yes, we use CG balloon. If time will permit, I will show you the video also. It has been named CG balloon after Chhattisgarh, my state. It has been made by one of my colleagues in my previous medical college, Dr. Nalini Mishra and her team. It is very, very helpful. I ask all my PGs, I keep it ready in my OT all the time because we really don't know when we might require it. So it is a must in your tray. It is basically very good because it gives you a tamponade test also, like after you connect it with a Eurobag, and if there is no bleeding inside after inflating, you say that test is positive. That means you are able to control the PPH. But if it is blood keeps on coming from in the Eurobag, you say it is a negative test because it is not being controlled and it is not being helpful. Now, no evidence of how long the balloon tamponade should be kept in place. Most cases, 4 to 6 hours of tamponade is adequate. It should be removed during daytime hours with presence of appropriate senior staff, as further intervention may be necessary. Now, if a woman does not respond to treatment using Uteronics, as I told you, the recommendation by WHO are that use of intrauterine balloon is recommended. Very weak recommendation, low quality evidence, but yes, after Uterotonics, it is the second line of management. If these measures fail, then definitely we have to go for uterine artery embolization. If you have it, I have it in my college, so I can easily boast about this facility that uterine artery embolization can be done. We have done it in one case right now. So it is, it is a boon if your college has a cath lab with you, or this machine with you. It is useful in situations in which preservation of fertility is desired when surgical options have been exhausted in controlling PPH, which is atonic or traumatic. Major drawback is that you really need a 24-hour availability of interventional radiologist or a cardiologist with the entire team to transfer the patient to cath lab. We do it through femoral route approach by injecting the gelatin particles. Use of polyvinyl alcohol particle is actually permanent. Success rates are very high, say 75 to 100%. Complication can be local hematoma at the site, that is femoral site. There can be ischemic phenomena, including uterine necrosis, although rare. Emergency indications are persistent atonic PPH and surgical complications like uterine tears and bleeding following hysterectomy. Now, in elective cases, you can do it when you are suspecting a case to be of placenta accreta or previous cesarean scars which have been diagnosed. So in those cases, you can try. We have not done that. And the strategy used for elective cases in minimizing blood loss, number of blood transfusion, ICU admission, which works with balloon inflation, and if it doesn't, then it can be a route for embolization as well. Now, coming to surgical management, if it doesn't stop after embolization also, then they say that if bleeding does not stop in spite of uterotonics and other conservative interventions, use of surgical intervention is recommended. So this is the fourth line of management after the first three which I have mentioned. First and foremost, if we have opened the case, we have to go for stepwise devascularization of uterus. I teach all my PGs, when they go for their cesarean sections, I tell them during my first or second surgery, I teach them uterine artery ligations, because they should know all the surgeries before leaving the hospital after completing their PGs, because they can save lives. So stepwise devascularization of uterus is a must. You all are well versed. First of all, it is the uterine artery which we ligate, and if it doesn't stop, then we go a little lower and go for cervicovaginal artery, and if it doesn't stop, then we go and give a higher suture upwards for the anastomotic branch of ovarian artery. These are again the same diagrams: suture 1, suture 2, suture 3. Again here suture 1, here it is given, again here it is given. Now, Beal-in suture is such a boon. It is a great boon. Everybody, every single postgraduate student passing out from the institute should learn Beal-in suturing. It is given in YouTube. You should take a purse, a small pouch, a purse or a portly, which we call it, and you should keep on practicing on it. It is given in YouTube. It is very simple, but you should know how to give a Beal-in suture if you are going for a cesarean section. You should know how to go for Beal-in suture. It is little, the incision has to be open. It is more often used in cases of cesarean where you have already opened the lower uterine come from behind. It is little difficult if I tell you like this, but if you see the video or if you practice it, it is very easy. What I teach my students is a modified Bealage. I teach them frequently. I also teach them while doing hysterectomies in patients of normal hysterectomies. I teach them all the ligations, because as it is, I'm going to remove the uterus. So that is the best time where I can demonstrate all the sutures. But while doing a cesarean section, when there is a little atony and when I'm about to do modified Bealage, I ask all my PGs to come and wash, or I tell them to learn, because it is very simple. Yes, you have to take a round body needle, a big one, and number 2 catgut, chromic catgut, which I usually use. It has been recommended number 1 also. I don't use that because it breaks easily. I don't use Vicryl because it may cause necrosis, because It gives very tight suturing. So just you have to go anterior-posteriorly, come upward, and just fold the uterus and then give a nice tie, hold it with the artery, and then again take a second suture, go posteriorly, come up, and then give a tie upward. Hold it with the artery. By the meantime, when you are folding the uterus, this knot gets loosened up. So you have to again open the artery, tighten it up, again put the artery there, and again by this time this loosen up. So again tighten it up and fold further. So you have to keep on doing this till you are able to give nice sutures at the fundus. Now I came across this MY suture, Matsubara Yano suture, which I was not doing it, but I feel that it is very good, because what happens when we are giving these two sutures, modified Beelage, they tend to slip off. They tend to slip off from the Cornwall ends. So this MY suture just takes the help of these two transverse sutures, 2 or 3, and it prevents them from falling off. And Cho square sutures, they are very important. Multiple square sutures where a needle transfixes the uterus from anterior to posterior and then from posterior to anterior, and it is done such a way that these squares are formed. They are very important for preventing the bleeding in cases of atonic BPH. I came across this suture. I have never used it. It is Pereira suture, where they are going, they use the needle and the suture material. They don't go inside the cavity, but they just go serosa, and little bit of myometrium is taken, and they take these running sutures vertically and transversely, and they try to use it for constricting the uterine cavity, or making the uterus tonic. So it is unique that in this the needle does not enter the uterine cavity. The uterus is wrapped up by several transverse and longitudinal continuous sutures. The needle picks up the uterine serosa, subserous myometrium, making several bites, and finally the thread is placed in a circular fashion around the uterus. This is the first transverse circular suture, and it has to be repeated 2 or 3 times. This is how it looks after we apply the Pereira suture. Coming to internal artery ligation, a must for all the PGs who are leaving this hospital after taking their, before taking their MD degree. I make it a point, I always tell my colleagues whenever we take a patient for Bardheim cystectomy, when the anatomy is extremely clear, that is the time when your PGs or your UGs should be called. They should be asked to wash, and we should show them clearly. We should take out the fear from their mind about these arteries and vessels. Open the broad ligament between the round ligament and the infundibulopelvic ligament. Identify the psoas muscle. Clearly you can see the external iliac artery. You can clearly see the uterine artery. You can very well see the ureter in the posterior leaf of the broad ligament. Just slip it away. See that internal iliac artery is giving 2 branches, the anterior and the posterior. We are not bothered about the posterior branch because it is going to give parietal branches. It is the anterior branch which we are worried, which we are going to tackle. Just with the help of mixture, you have to take the suture and tie it. As it is about to give the branches, you have to tie it here. So role of internal iliac artery ligation is to control the intractable pelvic hemorrhage. It was described long back in 1893 in cases of cervical cancer cases. It is a life-saving procedure for PPH bleeding, and it is also, you can do it in selected cases as an option during intraperitoneal bleeding where exact location could not be identified. So, bilateral internal artery ligation is much better because it is seen to prevent the blood loss by 49% and pulse pressure by 85%. And after bilateral ligation in long-term period, the collateral circulation will be maintained by refunctioning of the internal iliac artery. There is defemoral artery which is going to supply it, and it is going to take care of the vasculature. Ovarian artery will also give some blood flow to the uterus. So in spite of the bilateral ligation of internal iliac artery, future reproductive potential is not affected totally, and term pregnancy have also been reported. So, this is how you can just open the ligament. It is a cadaveric dissection. You all must, talk to the faculties in the college, all the colleges, and you should ask the PGs to practice internal iliac artery in cadavers. There are many colleges who are doing it. So I like this diagram very much. This is common iliac. This is external, this is internal, and here beautifully you can see this uterine artery going here. And this is the point where you have to take the suture. Now, one slide about secondary PPH. It can be because of endometritis. It can occur after 24 hours till 12 weeks. Patient can come to you with bleeding. There can be many factors for endometritis. She may be an anemic patient, diabetic, choriamnitis, or we have done some intervention to her. It was maybe MRP or forceps, vacuum, cesarean. We have to be very, very clear what is the cause of infection. Swabs should be sent, and good antibiotics, and then later on I'm very sure that once it is taken care of, we can handle secondary PPH. Now I have not discussed hysterectomy as the last option, because most of the time after practicing all these things, very few cases are there who would be requiring hysterectomy. I would emphasize again and again that if you are finding the uterus to be tonically contracted and patient is still bleeding and you have tried everything till internal iliac artery, and now you are going for hysterectomy after ruling out her DIC, her thrombin being a cause, see that you go for total hysterectomy. I see here patients refer to me in shock, in which the referring doctors have done hysterectomy, but they have done subtotal hysterectomy. They have not done total hysterectomy, which is not going to serve the purpose. And for all the patients, all the students who have not done total hysterectomy, they should not be ashamed to call their seniors to come and help them if they have to take this, because nowadays with so much of litigation, each and every obstetrician should know all the methods of prevention, treatment of PPH. May it be anything, you should be well versed with all the methods. So I would again conclude my slide. I don't know, someone is just writing on my slide. Conclusion is that postpartum hemorrhage is common and it can occur in patients without risk factors for hemorrhage. Active management of third stage of labor should be used routinely to reduce its incidence. Use of oxytocin after delivery of anterior shoulder is the most important and effective component. Oxytocin is more effective than misoprostol for preventing and treating uterine atony. Routine episiotomy should be avoided to decrease blood loss and risk of anal lacerations. Appropriate management of PPH requires prompt diagnosis and treatment. I always tell that PPH is like house on fire. Don't try to, treat that fire with a spoon or a mug or a bucket. You have to call fire brigade. You have to use all the measures, and you have very less time in hand. It is only 2 hours. So while we are treating PPH, most of the time it is one and the other. You just start with, if you have opened the abdomen, see that you do uterine artery ligation. If it doesn't do, go for stepney down, go for ovarian, go for V-lange, go for internal iliac. Just keep on doing it one after the other if it is not working for you, because you don't have time. And I've seen many patients who just keep on doing the massage and they keep on shouting blood lao, blood lao, blood lao, blood lao, and patient ko bolo, call the patient for hysterectomy, consent. No, you have to be very careful. There have been many litigations in which you have done hysterectomies and the patient party has questioned your treatment protocol, that why all the methods recommended by WHO were not tried in her. So documentation is very important. You need to have a person who has to write down every little thing you are doing. Every little thing has to be mentioned. And remember, you need good amount of blood. You should know how to calculate it. 3.5 liters. Initially, it is 2 liters of crystalloids. You should be, 1 to 1.5 liters of colloids. You need fresh blood. You have to compensate the fresh blood. If you are given 4 units of Paxil, you have to give 4 units of FFP, monitor her platelets, monitor her fibrinogen level, and I'm sure that all of us can, through small efforts, we can bring a lot of change in reducing the maternal mortality in our country. And with this, I finish my talk, and I'm so thankful to all of you for being such patient listeners, and thank you once again to the organizers for giving me this opportunity. Thank you so much.
Thank you, Dr. Rekha. That was an extremely crisp and comprehensive coverage of this very vast topic. We have a few questions by the audience. I think most of the questions you've already covered in your talk, but just a few pending ones that I would like to you to answer. There's a question that does hydration during first and second stage of labor reduce atonic PPH?
A patient has to be hydrated well, not too much, not too less also. But yes, I have seen, it is absolutely correct. I have seen patients in labor room where a drip is going on, a syntocinon drip is going on, and infusion rate is there like 6 or 12, and no other fluid is going. They are deeply dehydrated. We never try to consider this as an important aspect, but yes, she has to be well hydrated, and it can be a precursor. Yes.
Yes, and I think I would like to add here that if the patient is well hydrated, she will be able to tolerate the blood loss better.
Actually, yes.
Not actually prevent PPH, but makes her more tolerant to the blood loss. I think that is what is important. The questions were the role of tranexamic acid and role of factor 7. I think you've already covered this. So I'm going to move on to the next question, which is the ideal time to repeat hemoglobin and hematocrit after PPH.
See, if the PPH has stopped, then definitely you give 24 hours for it. But yes, if patient is bleeding, there is no fun if your patient has not stopped bleeding and you ask the blood bank or the pathologist to tell you how much is the bleeding, or how much she's bleeding. But yes, as soon as you feel that patient is bleeding, I told you, you have to take 20 ml of blood and immediately send, and definitely you can repeat it after 4 hours to begin with. Yes.
Thank you, ma'am. There was another question of role of intrauterine balloons for the management of PPH. You've already covered that, so we're not going to go into that. There's a question on the maximum dose of oxytocin for the treatment of PPH.
See, the maximum dose which WHO has recommended is 10 international units only. They say that 10 international units bolus. In fact, till yesterday or before preparing my slide, I was also following 2012 WHO recommendations, and we would be using 10 international units intramuscular. Then we were putting 20 international units in the drip, in the infusion, and then we were increasing the drips to 40 international units in the infusion, and we were just carrying on. But WHO says IV bolus 10 international units are to be given immediately. If it doesn't work, you have to definitely add. I went through few studies which said that if you give 10 international units bolus, and then you put around 40 international units in the infusion and continue it for 4 hours, it can help in maintaining the effect. But WHO has not said anything about that.
Okay, yeah, ma'am. I would also like to add that maximum dose for the antenatal patient, it is, when we are doing induction, it is usually mentioned as 84 milli international units. But for PPH, there is no maximum dose as such mentioned anywhere. But yes, you can give a maintenance dose. We usually give it for like 3 VATs over 24 hours, each containing 20 units, 20 units, and then 10 units.
Yes.
That's the usual practice that we can do.
Yeah.
Next question, madam, for you is the role of carboprost in treatment of PPH, as it is still being used in many centers.
Yeah, somehow carboprost, I love that drug, especially if I am doing a cesarean section. 250 micrograms of carboprost intramyometrial is really, really handy. You know, you really come to know the tone because it is in your hand, you are using it. It is a good drug. But you can use it every 15 minutes, as it has been mentioned, up to, 8 doses, I think they have been mentioned. So carboprost, yes, it is a good drug, but not for prevention, but yes, for management of PPH, it has been recommended.
Yeah, ma'am, I would agree with you that it is a good drug. But to just share my practical experience, I think that is the reason that WHO also doesn't recommend it now, because carboprost gives a lot of side effects in the form of vomiting and
Yes.
diarrhea.
Yeah,
And a patient who has already lost blood due to PPH, this diarrhea can be an additional volume loss. That becomes a problem. We have faced situations where the patient was, there was incessant diarrhea, and there was a lot of problem in managing the fluid. We could not overload the patient because she was a pre-eclamptic. We could not give her more fluids, how to maintain that input-output. So that becomes a problem. So it is not a preferred drug, but yes, it may be used if your other measures fail. That is what my personal opinion. The next question, madam, is that after how much time should we go for surgical management?
There is no time. Actually, if one thing is not working, you have to rush to the second stage. If second stage is not working, you have to rush to third. Third stage is not working, you have to rush towards so 30 minutes is enough. 30 is enough. If it is not working, you have to open her up. Because you can really save her life. You can really save her life if it is atonic PPH. By doing these modified B-Lynch and these ligations, you can actually save her life.
Yeah, we'll move on to the next session.
Yeah,
they're running short of time. Like we are already.
Thank you so much.
Yeah.
Thank you so much.
It was a wonderful session with a lot of questions, because it's a very important topic.
Yeah.
But we are short of time, so thank you, madam, for a wonderful session. It was so thought-provoking, and I would like to invite our second speaker, Dr. Purnima Jaydev, to give a talk on conduct of labor in this COVID-19 pandemic. Because everything has come to a halt in this COVID-19, but deliveries and obstetric practice cannot be put on hold. So that is the Dr. Purnima will elaborate on how to go about this. Dr. Purnima is the acclaimed teacher. She joined government service in the year 1991, and she has worked in various PHCs and hospitals. She's worked as a clinical coordinator for KMC Mangalore. She's a master trainer in IUCD and PPIUCD, resource person for POSCO Act, PCP and DT Act, training involved in training of ASHA workers, Anganwadi workers, and has given talks in Akashvani television channels, and conducted laparoscopic camps in various rural areas. So it's our great fortune to have such an acclaimed speaker to talk about such a pertinent issue in today's time. Dr. Purnima, please. Dr. Purnima, you'll have to unmute yourself.
Dr. Purnima, unmute yourself. Hello?
Hello?
Yeah. Okay, thank you.
Can you hear? You can hear?
Yes, madam.
Yes, ma'am.
Yes. Thank you for giving me this opportunity to be with you all in this COVID-19 pandemic. We have been through this for almost 6 months now. You all know that this disease was identified first in the Wuhan city of China in December 2019. That is why it is called COVID-19. And WHO on 13 March 2020 characterized COVID-19 as pandemic. By that time, Italy and America and other countries, and now more than 200 countries worldwide are having COVID-19. Whether you do lockdown or stay at home or you do social distancing, you cannot stop deliveries. You can just postpone only the antenatal checkup. And I've seen many obstetricians stop their practice in this COVID-19, and many hospitals, private nursing homes doesn't want to take pregnant women. So where these pregnant women will go for deliveries? Government took the burden of delivering all these patients. I know how much difficult it was for Lady Goshen Hospital, Wenlock Hospital at Mangalore, and I'm at least fortunate to be here in Bangalore now. And I now work in Jayanagara General Hospital. We are having 300-bed hospital. Out of that, 120 beds are for COVID-19 patients. We have dedicated 120 beds, not for pregnant women. And all the pregnant positive ladies will go to either Victoria Hospital or to Lady Goshen Hospital in Bangalore. And some COVID-19 dedicated hospitals are identified. So all our patients will go there. And total number of deliveries from March to September in our hospital is around 2,741. Out of that, we had 87 at term, and total number of positive deliveries done vaginally is 3 because we couldn't do the examination before, and it was done during the admission, and after delivery, the results were positive.
Excuse me, madam, you share your slides, no?
Yeah. It's not coming?
No, it's not come. You have to share my slides, no?
Yeah, I got into that.
Share my screen, madam.
Yeah. It is not coming?
No.
Screen has never opened her PPT.
Yeah. Share the screen. Open your PPT, madam.
Yes.
And start slideshow like that.
Only this is coming? Not coming?
No, madam, your face is in, that's all.
Okay. Sorry. No, I'm unable to do that.
Share my screen anta kodi, madam.
Share my screen.
Ma'am, on the bottom of the screen, you can see the green option, share screen. You have to click on that. And then your PPT, which you have minimized, you maximize it and start your screen sharing. First, you click on the green option, ma'am, share screen. At the bottom of your screen, you will find it. Bottom or top.
Hello?
Yes, ma'am.
I cannot see.
Madam, double click on your screen, madam. Then you'll see green. PPT is open on your computer, madam. PPT.
Yes.
Now you double click on your screen, madam. In the center of the screen, just double click.
Yeah.
Now you are seeing the green share screen option is there. Green color.
No.
Down, madam. Down in the just about bottom bar box. Sometimes top it will come, sometimes down it will come.
No, I'm not getting.
Another option is, ma'am, you can email the presentation to one of the organizers who can share the screen. That's an option.
Madam, you can mail your PPT to us.
Now?
Yeah.
We'll start with the next speaker.
We'll start with the next speaker.
We'll have your session.
Okay.
Next session will take you, madam.
Okay, okay.
Mail ಮಾಡಿ madam.
Okay, okay, ಮಾಡ್ತೀನಿ.
Sarvan. Namaste. Next co-speaker ಬರ್ತಾರೆ, coordinator. Namaste. ಇಲ್ಲ, I know him.
Right, so that was a little technical glitch, but we'll be back with Dr. Purnima's session in just a while. For the next session, I invite Dr. Virendra Kumar. Sir is a professor and unit head at BMS Bellary. Has a teaching experience of 20 years. He's the president of Bellary Obs-Gynae Society for the year 2019 to 21. He has contributed many chapters in textbooks and monograms. He has around 100 presentations in various CMEs and conferences. He is the chief coordinator for Wisdom 2008 to 11 and organized MUSCON live workshops and CMEs, has various publications to his credit, and he was the organizing secretary for KSOGA 2019 Bellary. And sir is going to speak a very pertinent topic of breech delivery, that is, kind of a dying art, and which needs to be revived. We feel very, very strongly about this. And sir is going to deal how confident are we in conducting breech deliveries, and I'm sure the audience is going to benefit by the wisdom of sir. So the stage is all yours, Virendra sir.
Thank you, madam, for the nice introduction. First of all, I would like to extend my gratitude to Dr. Geeta and MUJ KJV Medical College Sulya for giving me an opportunity to talk on this very important topic. Just 1 minute.
It is coming, sir. Carry on, sir.
Yeah. Can you see the presentation now? 1 minute.
No, sir.
No, no.
No, yeah.
No, sir.
Now? Can you see the presentation now?
Yeah, open your PPT, sir.
Open the PPT.
Yeah, I'll open.
Share the screen. You
Open the
your
PPT.
PPT, sir.
Can you see it now?
No, sir, not yet.
Open the PPT, sir. Open the PPT.
Yeah, I opened actually.
Okay. You have to share the screen, sir. Only PPT.
Can you see now?
Sir, you have to minimize it.
Okay, I've minimized.
And then
Resume
open
sharing.
Minimize the Zoom screen, sir. Then open the Zoom, then share your screen through the Zoom, sir.
Yes. Can you see now?
Yes, sir. Yes,
now
sir.
make it full screen, sir.
Okay.
Yes,
Yes,
we
sir.
can see you, sir.
You can see. Okay.
Yes, sir.
Thank you very much. Exactly 22 years back, as a junior resident, I had broken a femur of a breech fetus. Okay, then I was very guilty. Then my teacher, Dr. Suyagna Joshi, later on consoled me, and he took a class on breech for 4 hours in bedside clinics. Another incident, we had a patient wherein the dangling fetus was referred to us. By forcibly, the outside practitioner had decapitated the baby, and head was inside the uterine cavity. Then we had to do cesarean section for an aftercoming head, which was decapitated in the uterine cavity. These are all the horrifying incidents. So that's why we need to know about breech delivery. Once upon a time, we had a patient who was presenting with a breech with dangling body in between the thighs of the patient, and the obstetrician did not know how to conduct the delivery because the head was very big. Then she came to us in the medical college. We simple perforation of the posterior fontanelle, did the magic, and patient delivered within 2 minutes. Clinicians have long recognized that there is going to be increased mortality and morbidity associated with breech presentation. The master obstetrician, F. Morrissey, he told that, just wait for a minute, I am seeing some chart box in front of my screen. Yeah. The master Morrissey told several unnatural postures wherein the child presents themselves at their birth are the cause of most of the bad labors and accidents, for which usually recourse is to head to chirurgeons. This was told in 17th century. Then Paul Portal, he said, if the feet of the child comes foremost, you must take care to baptize them immediately. That means we have to do cesarean section for footling presentation. Rolf Wright, way back in 1959, he said, any patient of more than 35 weeks of gestation who entered labor in breech presentation should be born by cesarean section, provided there are no contraindication for cesarean delivery. Over the last 50 years, there has been a phenomenal shift in clinical practice from breech birth to cesarean section. Worldwide, the vast majority of breech babies are now delivered by planned cesarean section. Breech presentation, what we should understand is the mode of delivery will not increase or decrease perinatal mortality. The breech presentation themselves has got a high risk of mortality compared to cephalic presentation because of higher incidence of congenital anomalies, birth asphyxia, birth injury, and most importantly, prematurity. Rate of cord prolapse in non-frank presentation is also more in breech presentations. Sadly, nowadays, we are, for each and everything, the young obstetricians think that cesarean section is the answer. This is like using cesarean section as a hammer. If the only tool you have is a hammer, you tend to see every patient as a candidate for cesarean section. This does not hold good for breech delivery because we need to revive the art of breech delivery, vaginal breech delivery. The art, of course, medical science, we call it as obstetric science, is particularly an art. The art should not be allowed to die. The technique of vaginal breech deliveries will remain integral component of obstetric practice because cesarean section may be inadvisable or not feasible in many patients. Many women may opt for vaginal breech delivery. There are still unresolved issues regarding the best practice of delivering preterm breech and breech presentation, especially in multiple pregnancies. Some women may come in advanced labor when there is no time to do cesarean section or the facility for doing cesarean section may not be there. So we should know about breech delivery, whether you like it or not. Learning the art of vaginal delivery, especially breech delivery, is essential. Cesarean breech delivery also demands a clear knowledge of the same maneuvers which are used in vaginal breech delivery. Gimowski, in his famous article, says, in fact, a poorly performed breech delivery during a cesarean results in injuries similar or more than that sustained during vaginal delivery. The injuries may be like brachial plexus injuries, bony fractures, spinal cord injury, or crush injury to the viscera. Hence, even though you don't want to conduct vaginal delivery, but you must know the maneuvers. My teacher, Dr. Swegna Joshi, used to say that delivery of breech is like delivering an inverted triangle. If you deliver a cephalic presentation, it's an upright triangle wherein the most broadest part, incompressible part, delivers first and very easy to deliver the apex. Whereas it is not so in case of breech delivery. Here you are delivering inverted triangle. The base of the inverted triangle is more, especially in preterm babies or extremely premature babies. That's why, as the picture says, here 3 triangles are there. The first triangle is less than 33 weeks. The middle triangle is between 33 to 38 weeks, and the last triangle is a term. The relation between bitrochanteric, bisacromial, and BPD is more favorable near term. That's why they advocate doing cesarean section for between 26 to 34 weeks because of this relation, because increasingly there may be difficulty of delivery, especially after coming head. So in this talk, I am not going to much elaborate on the techniques. I am going to touch upon the techniques, and also we will critically analyze the infamous or famous term breach trial. Diagnosis of breach is very important. Sometimes what is seen in the ultrasound may change because of spontaneous version when the patient comes in labor. So routinely we must use Holland's maneuver. In our PG style, in the examination they tell Leopold maneuver. But in practice, actually what we are doing is Holland's maneuver. Whenever patient comes, suddenly put our hand on the abdomen to know what is there in the lower pole. So this is called as Holland's maneuver. 95 to 97 presentations are cephalic. So hence we should use Holland's maneuver in the first setting rather than Leopold maneuver, which is ritualistically told in the examination. Frank breach, especially the extended legs are splinted against the head, and compact breach in the pelvis may be confused to vertex presentation. Vaginal examination, dilatation is tardy, bag waters unusually elongated, and irregularly fetal parts may be felt. This may be a clue towards diagnosis of breach examination. Especially the ultrasound may not be always be available. During labor, swollen face may be confused with breach. Absence of gum ridge in the anus with rule out face, and drips when ruling out shoulder. These are all very practical points. This must be taught to our all junior resident not to miss breach or to miss shoulder presentation. Blunder is to mistake a shoulder for breach. The mechanism of labor in breach is more complex compared to cephalic presentation. Attitude of the fetus as well as attitude of the obstetrician is definitely matters in vaginal breech delivery. As all of you know, bitrochanteric diameter is the diameter of engagement. Internal rotation of breech, shoulders, and head should occur, whereas it is not of much consequence in cephalic presentation. Here, lateral flexion occurs, whereas the flexion occurs in cephalic presentation at the cervical vertebrae. Here, the flexion occurs lumbar vertebrae. It may be problematic in frank breech because of the splinting action. The prognosis of vaginal breech delivery, maternal risk is same that of vertex. Increased chance of perineal injuries, especially in primigravidae. Perinatal morbidity and mortality is high, which is not just related to mode of delivery. It is also the inherent problem of the breech also contributes to increased perinatal morbidity. Increased death rate is seen in breech presentation. The autopsy of stillborn fetuses and early neonatal death revealed 75% of the cases had intracranial hemorrhage. No time for molding of the head because too rapid delivery of the aftercoming head. It is called as Cork-Champion effect. It leads to tentorial rupture, tentorial tears, so that there is intracranial hemorrhage. Head compression is more dangerous in breech delivery than cord compression. Most of us think that cord compression will lead to death of the fetus. It is not so. Head compression leads to most often death of the fetus. Birth asphyxia due to long delay in delivery, and cervical dislocation of spine and rupture of the liver can occur during breech delivery. And indication for cesarean section, I don't want to elaborate. Most pertinent to doing C-section for breech delivery are prolapse of the umbilical cord, especially in footling breech, small babies or large babies, hypererection of the fetal head, and footling presentation. These are the indication for doing cesarean section in breech. The trial of labor should be considered after weighing the pros and cons and ruling out high risk parameters in the patient. Frank or complete breech, The gestation age should be ideally between 36 to 42 weeks. The weight should be between 2.5 to 4 kgs. Flexed or neutral fetal head, adequate maternal pelvis, and there should not be any contraindication. So to know whether baby's flexed or neutral fetal head, usage of intrapartum ultrasound is mandatory, especially if you want to conduct vaginal breech delivery. So conditions for trial of labor in breech deliveries: adequate descent of breech must occur. No heroic vaginal procedures are performed. Here, your ego should not work. You must have willingness to abandon the procedure, and there must be facilities to immediately perform cesarean section. Induction of labor is not recommended for breech presentation from practical point of view. A trained professional in neonatal resuscitation should be attendance at the time of delivery. An experienced obstetrician in vaginal delivery should be present at delivery. The problem is nowadays we don't have obstetricians which are highly trained or highly experienced in vaginal breech delivery, thanks to the infamous term breech trial. So I want to talk about management of uncomplicated breech and management of complicated breech. What do you mean by uncomplicated breech? Here, no complications occur, like no nuchal arm, no impaction of the breech. So here, leave things strictly to the nature and intervene only to assist the birth of the shoulders under the aftercoming head. The delivery maneuvers by the clinicians are performed only in the final stage of expulsion. Fetus should be positioned so that back is always anterior. Untimely interference, such as breech extraction, will lead to greater difficulty in extracting the head. In fact, there is no role for breech extraction whenever you are planning to conduct vaginal breech delivery, unless there is a complication or an emergency. So we routinely ask assisted breech delivery, whether it is a the multi or priming, this should be the start. We should not allow the fetus to deliver spontaneously. Assisted breech delivery is the mandatory when you are planning for vaginal breech delivery. So whenever I ask what is assisted breech delivery, many fail to tell the answers, and here is the answer. The assisted breech delivery is series of gentle, unhurried, deliberate maneuvers so as to affect the delivery of shoulders and the aftercoming head without much damage to the fetus and mother. So it is a series of gentle, unhurried, and deliberate maneuvers so as to affect the delivery of shoulders. That is assisted breech delivery. The best policy for successful delivery of breech is no interference except episiotomy until the body is born to the umbilicus, and hard bearing down and expulsive efforts by the mother during contraction, and the maintenance of suprapubic pressure during descent to aid deliver and keep the head in flexion. Once the umbilicus has been delivered, time becomes an important factor. The remainder of the birth is expedited gently and skillfully, as I told earlier. A free airway to the mouth should be available, and within 3 to 5 minutes to obviate anoxic brain damage. The 3 to 5 minutes is a hell of a time. Definitely, you no need to hurry, but at the same time, there should not be undue prolongation. Then management of complicated breech. The arrest of buttocks at the brim may occur. In such situation, it's better to recourse to cesarean section than doing heroic procedures. However, situation may arise such that you may encounter a situation wherein buttocks may get stuck at pelvic outlet. Here, extension of the leg is the commonest reason, as splinted legs prevent lateral flexion, and wedges formed by head, shoulder, and legs is too large to enter the brain. Breech extraction, I told there is no role for breech extraction in modern obstetrics. Probably the only role of breech extraction in modern obstetrics is delivery of a second twin. It requires considerable skill and should never be attempted by an inexperienced surgeon. Should be a smooth and slow operation with an assistant always providing continuous fundal pressure as well as suprapubic pressure to give cranial flexion. As I told earlier, I am not going to much tell in detail about the maneuvers. Here the topic is how confident are we. So it becomes important factor on my part to discuss about TBT. So decomposition, if you are encountering the complete breach and you are not able to deliver the legs, the decomposition of the breach should occur. One should insert the hand inside and catch hold of the foot, and it must be, the hip must be adducted, and then the foot is drawn out. That is called as decomposition of the breach. Suppose if you encounter extended breach, then you have to perform Pinard's maneuver. The decomposition of breach occurs in flexed breach, that is complete breach, wherein there is flexion both at hip as well as knee joint. You have to catch hold of the foot and draw it across the body, especially hip must be adducted. If you come across extended breach, you must perform Pinard's maneuver. Here the hand is inserted, and over the popliteal fossa, the gentle upward and backward. Here you are going to do abduction, slight abduction. Once you perform abduction, there will be definitely flexion of the knee joint, and you can catch hold of the foot and you can decompose as I explained earlier. This is called as Pinard's maneuver. Lauset's maneuver. Here the principle of Lauset's maneuver is that because of the inclination of the pelvis, when we ask Lauset's maneuver principle, my students start answering about the methodology. I am not interested in methodology. I am going to ask what is the principle. The principle here is because of the inclination of the pelvis and the hollow sacral bay, posterior shoulder will always be below the brim. This method does not involve any intra-vaginal or intrauterine manipulation. If performed correctly and gently, it will not entail any risk to the fetus and mother. So as I told earlier, because of inclination, always posterior shoulder is below the brim. You turn the baby by 180 degree, definitely the posterior shoulder will be below the symphysis pubis and very easy to deliver the shoulder. The another problem which may come across is nuchal arm. Here, excessive traction may further complicate. Once you suspect nuchal arm wherein you are not able to deliver the arm, the correct treatment is to rotate the fetus in the direction in which the hand is pointing. The occiput slips past the form, and friction of the rotation causes the shoulder and elbow to flex and become accessible for delivery. So this is the nuchal arm. The hand is pointing towards the left. You turn the baby towards that direction, and naturally the arm can be easily delivered. Again, there must be sweeping of the arm across the chest. If you don't follow this rule, you are likely to break the humerus. You must always sweep the arm across the chest, and that means you have to perform adduction. Only in Pinard's maneuver you are going to abduct because your aim is to flex the knee joint, whereas in delivering the decomposing the leg in complete breach or delivering the arm across the chest, as in case of delivery of the arm, should always follow adduction rather than abduction. Otherwise, you will break the humerus or femur. Fetal head entrapment during vaginal delivery is an obstetric emergency. After coming head, again I tell, attitude matters. Taggidavanu baliyanu ante. So whenever there is after coming head difficulty is there, you must maintain flexion of the fetus. Here, by constantly applying suprapubic pressure, otherwise which is called as Christelos maneuver, you are going to present subrachmatic diameter to engage so that it is less than 10 centimeter. If the fetus shows the attitude, hyperextension attitude, then it becomes increasingly difficult, and such fetuses may die. So in the delivery of the breech, you must always maintain flexion. Again, after coming head, so many maneuvers are there. Wiegand-Martin is there, wherein the same obstetrician, Akosher, uses his dominant hand and non-dominant hand to deliver. In Morris-Mew-Smith delivery, both dominant and non-dominants are used to deliver the baby, whereas assistant applies suprapubic pressure. And another method which all of you are familiar is Burns-Marshall method. fetus is allowed to hang. Once the nape of the neck is seen, the grasp in between the feet and swept in wide arc over the maternal abdomen. In preference to Burns-Marshall method, most of the textbooks, guidelines, and professional bodies actually advocate Morrissey-Smell-Viet method in preference to Burns-Marshall method. In Morrissey-Smell-Viet method, fetus is placed in a horse riding position across the non-dominant hand. The two fingers should be placed over the molar prominences to maintain the flexion of the fetus, and the middle finger, should not be inserted inside the mouth. You must use your two fingers over molar eminence to promote flexion of the fetus. The middle finger of the dominant hand should be put on the fetal occiput to promote flexion, and the index and ring fingers on each of the fetal shoulders to promote traction. So here the word of caution is, you should not put your hand inside the mouth of the fetus, otherwise you may cause damage to the fetus. So after coming head, the first application of the forceps for after coming head was in fact advocated by Morrissey. However, it was popularized by Pipers. If you have Pipers forceps, it is best to use Pipers forceps for delivery of the after coming head. Sometimes, as I told earlier, always you must try to keep the back of the baby anteriorly. Sometimes there may be a situation wherein you may come across the abdomen may be anterior. In such a situation, you must use prog method. There may be a situation wherein you have allowed preterm babies or non-viable fetuses for vaginal deliveries. The most common complication which may occur such cases is incompletely dilated cervix. If the head fails to deliver despite additional maneuvers, then consideration should be towards performing cervical incisions. These are known as Duherson's incisions. Incision is taken at 2 and 10 o'clock position, and most of the times the cervix yields and can be delivered easily. And sometimes, if necessary, the additional incision may be taken at 6 o'clock position, so that you are avoiding injury to the descending cervical artery. If performed incorrectly, or if it is not your day, the cervical incision may extend upwards within the broad ligament and may cause hematoma. Sometimes you may come across a patient, you know that already baby is abnormal, baby has hydrocephalus, and patient comes in labor with the dangling body in between the thighs. If you know that it is hydrocephalus, you must not perform reverse Giovanelli method and do cesarean section. Very simple procedure, just perforate the posterior fontanelle, the CSF is drained and skull collapses, and it can be easily delivered. It looks like a miracle for especially young residents, junior resident, if they see such maneuver. Sometimes you may get a baby hydrocephalus, there may be spina bifida lesion in the spine. So then instead of perforating the posterior fontanelle, you may insert a draining catheter through the spina bifida defect, or you can do spondylotomy. Just if it is a communicating hydrocephalus, all the CSF drains. So in such cases, definitely one must not perform cesarean section. Otherwise, as I told in the beginning, an anecdote wherein after coming head, a patient, we had to do cesarean section because it was decapitated because of the excessive traction by the private practitioner. So then comes the famous or infamous term breach trial. Term breach trial research has turned breech birth around. Last 50 years, there has been a phenomenal shift, not only due to TBT, I'm just talking about the landmark the research. Last 50 years, there has been a phenomenal shift in clinical practice from vaginal birth to cesarean section because of the increasing safety, because of the new emerging indication for doing cesarean section. Now world is moving towards cesarean delivery for most of the cases. Now worldwide, vast majority of the breech babies are now delivered by planned cesarean section. Realistically, the trials publication, despite the deficiencies, have accelerated the trend to cesarean section for breech deliveries almost to the point of no return. This is very sad thing as far as obstetrics is concerned.
Need the ID.
Even before term breach trial, many voted with their scalpels. Many used to advocate cesarean section for breech deliveries. Trial results, critical medico-legal climate in the present scenario further consolidated this approach of doing cesarean section for breech. National guidelines, you look for any ACOG guidelines, RCOG guidelines, Canadian guidelines, French guidelines, they write specified, especially fully informed consent, further hardened the resolve of the women to opt for planned cesarean delivery. If you tell all the complication, suppose your baby's head may get entrapped, if I don't deliver within 3 minutes, it may die. If you tell such complication, no woman will give her consent for vaginal breech delivery. So the national guidelines, the trial results, the critical medical legal litigant people are pushing us to perform cesarean section for most of the cases. So this is the famous article, that is Lancet, Hannah et al. Planned cesarean section versus planned vaginal birth breech presentation at term, a randomized multi-centric trial. It was published in the Lancet, October 21, 2000. So a brief information about TBT, term breech trial, a multi-center trial of planned cesarean section versus planned vaginal birth. It was undertaken at 121 centers, including both developing and developed countries, involving 26 countries. Initially, it required a sample size of 2,800 women with a singleton fetus in a frank or complete breech presentation. Following an interim analysis of 1,600 women recruited, the Independent Data Monitoring Committee recommended recruitment to be stopped early owing to a significant higher event rate than expected, because they noted the higher mortality rate, perinatal mortality rate in the vaginal arm of the group. And the study concluded that there was no difference in maternal morbidity between the groups. However, there was statistically significant increase in perinatal mortality in planned vaginal birth deliveries. What is the impact of term breech trial? Within a few months of term breech trial, had transformed obstetric practice worldwide. Within 2 months following publication of the term breech trials, the overall cesarean section rate for breech presentation in Holland is reported to have increased from 50% to 80% within 2 months. Just say 2 months. Rarely in medical history have the results of a single research study so profoundly changed practice. This was told by Glezeman in 2006. He was one of the collaborators of TBT trial. He posits such a change in the attitude towards TBT. In New South Wales, Australia, the rate of vaginal birth declined from 17% in 1992 to 14% in 2000 and to 4.5% in 2001. That was the impact of term breech trial. New Zealand, 72% offering vaginal breech delivery prior to the publication of the TBT. After this rate declined to 20%. 80 centers in 23 countries reported a 92.5% change rate in clinical practice to planned breech babies. Again, ACOG committee is always a fence sitter. In the opinion, in the interim update of 2018, it says the number of practitioners with the skills and experience to perform vaginal delivery has decreased. This is the statement by ACOG. Even in academic medical centers, where faculty, example medical colleges, where faculty support for teaching vaginal delivery to residents remains high, there may be insufficient volume of vaginal deliveries to adequately teach this procedure. This is the statement by ACOG as latest as August 2018. The American College of Obstetrician Gynecologists Committee on Obstetrics Practice recommended that planned vaginal delivery of a term singleton breacher was no longer appropriate. This was the statement in 2001. Planned vaginal delivery of a term singleton breech, it says in its opinion, may be reasonable under hospital specific protocol guidelines for both eligibility and labor management. I am just giving the evidence so as to know how the evidence, the litigant world has shattered our experience and confidence in conducting vaginal deliveries. The decision regarding in 2018 recommendation, the decision regarding the mode of delivery should depend on the experience of the obstetric care provider. Where is the experience? Cesarean delivery will be the preferred mode of delivery for most physicians because of diminishing expertise in vaginal breech delivery. Obstetricians should offer and perform external cephalic version wherever possible. All these statements are only for most of the times theoretical consequences because world has embraced TBT trial without critically analyzing it. In those instances in which breech vaginal deliveries are pursued, great caution should be exercised and detailed patient informed consent should be documented. Just look at these sentences. It's really horrifying if you want to really practice evidence-based medicine. Before embarking on a plan for a vaginal breech delivery, women should be informed of perinatal and neonatal mortality or short-term serious neonatal morbidity may be higher if cesarean delivery is planned. Planned vaginal delivery of a term singleton breech may be reasonable under highly specific protocol guidelines for both eligibility and labor management. So we are practicing in the shadow of TBT. When the TBT were being published, many experienced clinicians urged caution in accepting studies' initial outcome. However, it was like a cry in the forest. It is in Kannada, it is called as Aranyaroda, and nobody listened to them. And even the interim analysis by the same group in 2 years follow-up was reassuring. They told that there was no difference in major outcomes in respect to death or neurodevelopmental delay, both in planned cesarean and in planned vaginal delivery. They themselves accepted that there is no change in the long-term outcome. However, the world had moved very fast and nobody bothered to see this outcome. So time has told a different story. However, the trend to deliver term singleton breech presentation by cesarean section has continued unabated. Now, in 2002, Grant J. in his Bijavoji, he says, he critically analyzed the evidence of TBT. TBT and its aftermath is a prime example of how the evidence itself can be put on trial. The term breech trial is an example of a randomized trial that was impeccable as regards its methodological design. It was very nicely designed, but it was questionable regards its clinical design. Now, after nearly 12 years of TBT, Gerald Lawson, he writes an article, the term breech trial 10 years on, primum non nocere, means first do no harm. Ever since TBT trials were accepted without any questioning or without much applying our wisdom, many deaths have occurred during cesarean section. To prevent perinatal death, many women have lost their life because of the inherent complication of surgery. So we have obsession with randomized control trial. Randomized control trial have got better evidence or better methodology compared to other studies. However, if RCT is poorly monitored, it can become a fishing expedition in which every conceivable results may be included, however irrelevant, and that disconnected adverse outcomes may be included in the final analysis. In the TBT trial, they say like must be compared with like. You cannot compare third world scenario with the advanced country scenario. Many centers of the TBT trial did not have ultrasound and CTG, and 40% of the centers had no access to USG. So that's why in the beginning of my talk, I told that intrapartum usage of ultrasound is mandatory if you are planning for vaginal breech delivery, because you may ignore hyperextended head and ultimately the fetus may die because of the inherent problem of the fetus rather than the mode of the delivery. Many of the perinatal deaths which occurred in term breech trial had no relation to mode of delivery. There was an issue with quality control in the term breech trial. Protocol violations were aplenty, but the results were included in final analysis. Like it said in the beginning, singleton pregnancies will be included. However, in their report, they tell about 10 cases of term breech wherein they had twins. So live baby, 5 cases were recruited when the baby was already dead inside. And 7% of the cases, they did not have experienced skill provider. Even though trial was planned, many women, because they say planned vaginal delivery breech versus planned cesarean section, however, many women entered the labor, the group when they were in labor. So Anna et al. Had no concern for such violations. However, they commented in the end of their result that there was exceptional compliance for this study. The degree of experience and training of the accoucheur appeared to be highly variable because it was 26 countries and 121 centers. It was very difficult to monitor the quality of the obstetric care provided. The enrollment of women had to be ad hoc rather than consecutive, leading to selection bias. Units unable to provide emergency cesarean delivery within 1 hour were also included, which was again protocol violation or providing substandard care to women. There was a bizarre prediction by the Turnbridge trial authors. They claimed that only 7 extra cesarean are needed to prevent a death in one death in low resource with low PNMR settings. However, it was debunked by the Dutch study. They concluded that it would take either 175 or 320 cesarean section to prevent one perinatal death. That means the TBT authors were prejudiced or their methodology was definitely flawed. So TBT trial, many of the critics tell that it is like politics, full of compromises, but no confessions. There was recruitment bias, there was protocol violation, flawed analysis of the results, prejudiced opinion about the outcome of the study, and most importantly, fast tracking of the publication. If you send any of your article for publication, especially international reputed journals like BJOG, Lancet, it will take minimum 2 years to get published. However, the results of the TBT were published within 6 months of stopping the trial, in spite of prematurely stopping the Turnbridge trial. Again, systematic analysis was done. It was published in 2014 RCOG. The risk of planned vaginal breech delivery versus planned cesarean section for Turnbridge birth, a meta-analysis, including observational studies. The conclusion says perinatal mortality and morbidity in the planned vaginal breech delivery were significantly higher than the planned cesarean delivery. However, in the same article, they say that relative risk RR may be more with vaginal breech delivery, but they say that the actual risk with vaginal delivery is low. I don't understand what is the meaning of this. And in the final analysis, they say, instead of conducting a comparative study on planned vaginal breech versus planned cesarean section, they are advocating a comparative study of vaginal breech versus vaginal cephalic delivery. That means the professional bodies themselves are professional bodies themselves are not confident on their statements. So everybody knows about Turnbridge trial, or sometimes we have to ask PGs what is TBT. Even many of them do not know what is TBT. However, many of us or many of the students do not know about PREMODA study. PREMODA study is presentation and mode of delivery study, analyzed over 8,000 deliveries. It was almost 4 times the number of Turnbridge trial. Interestingly, this study did not find any significant excess risk associated with planned vaginal delivery. It was published in American Journal of Obstetrics Gynecology by Goffinet et al. It did not find, contrary to the findings of Turnbridge trial, PREMODA study, and this is more reassuring because it gives confidence to conduct vaginal delivery. Preventing breech births. So ACOG also recommends you perform ECV. Instead of allowing for breech delivery, you convert breech into cephalic. So alternative methods is external cephalic version. Even though it is not a part of my this, just for the sake of completion, I am mentioning this external cephalic version. And moxibustion therapy can be used as preventive ways to decrease incidence of breech presentation. The one word about moxibustion therapy is it is a Chinese herb extract. The dried leaves compacted and rolled like a cigar is lit and burned at a specific acupuncture point of bladder on the outer corner of the little toe of each feet. So this is the moxibustion therapy, and the partner, the husband, may be trained to do this thing. And it is used in Chinese medicine, sorry, used in Chinese medicine for centuries. And they claim the success rate of 85 to 90%. However, there is insufficient evidence to support this. So as you know, because of the embracement of Turbridge trial, because of lack of experience, new generation of obstetric accouchers is emerging who are increasingly unskillful about vaginal breech deliveries. Hence, responsibility of the National Obstetrical Training Colleges, like we all teachers should ensure that all trainee obstetricians have the capacity to handle an unexpected vaginal breech delivery. If skill development do not happen, women will left to have potluck, because she has to have luck to have her baby alive. When confronted with the inevitable breach, the doctor or midwife hopefully knows what she is or he is doing. That's why I said, if skill development do not take place, women will be left to have only potluck. The inevitable persistence of the breech deliveries, we have to revive the art, because breech presentation can still be undiagnosed prior to labor. Women may arrive in advanced labor, wherein the condition may be too late to have a cesarean section, or some women having done their own research. All of you know that many of them Google their condition themselves. They are Google doctors, having done their own research, and they can make a considered decision not to have a cesarean section. In such a case, you have to honor the decision of the patient, and you must be trained, or you must know about what are the maneuvers. And repeated LSS, more importantly, if you keep on performing LS for each and every small indication, you will run the risk of placenta accreta, then definitely maternal morbidity and mortality will increase. Robert Hutchison said in his famous medical written, which we have read in our Bailey and Law, putting knowledge before wisdom. The knowledge of TBT has been put before the wisdom of experienced doctors. Science before art. We are embracing evidence-based medicine, whereas conducting vaginal delivery is an art. You are putting science before art. Too much zeal for what is new. It was a fashion to talk about Hannah et al. It was fashion to talk about TBT, and contempt for what is old. And Robert Hutchison, he says, "Oh, good Lord, deliver us from such nonsenses of the medical practice." So I advise everybody, even though we are performing cesarean section in uncomplicated cases, we must revive this art, so that the prayer of Robert Hutchison, we must not put knowledge before wisdom. Wisdom must prevail over knowledge, and art must prevail over science. And we must not contemptuously look at what is the old practice of breech delivery. So hence, it is responsibility of the present day teachers to revive the art. Regular breech drills must be conducted. Simulation of the technique during LSCS itself can be done. During extracting a breech during LSCS is also not easy, because you must know the maneuvers, as I told earlier, and use of mannequins, and the right use of ultrasonogram and cardiac during labor will definitely give us more confidence to conduct delivery. If this does not happen in present day practice, tomorrow we may not have any person who can perform vaginal breech delivery. I thank Dr. Geeta madam and my senior Dr. Veena. She was my senior in WIMS. I was trained by her in labor room. Thank you madam for giving the opportunity. Thank you for your patient hearing.
Thank you, sir, for such a wonderful and beautifully elaborated session on the variety of evidence that you showed us. You took us through all the evidence, right from the Hannah trial to the various studies. A few comments that I would like to make, that the RCOG guidelines that came in 2017 said that the perinatal mortality associated with a vaginal breech delivery is not significant as compared to what is a vaginal cephalic birth or a cesarean section. It's just 2 per 1,000 as compared to 0.5 per 1,000 for a planned cephalic birth and 1 per 1,000 for a cesarean birth. So I think if these figures we explain to the women, they can be more receptive to have a breech
Vaginal
delivery. The
Yes,
HANA trial was definitely very, very much flawed. It is said that 31% of the deliveries that were conducted, they did not have any skilled healthcare professional, and 13% did not have any healthcare professional. The FGR babies were included, and so much and so forth. And I agree with you totally, sir, that it is the responsibility of on us, the present day teachers, to revive this art of breech delivery. I would like to quote just last week an incidence of a patient who was primary breech, who came with leaking and was given over to me for doing a cesarean section. I was on duty when I examined the patient. The patient was already 5-6 centimeters with a beautiful pelvis, and doing a cesarean in a breech in advanced labor can cause more damage. There are more chances of extension when the breech is low down in the pelvis. So I just did an intrapartum ultrasound, found that the head was not hyperextended, the baby was average size, and she delivered beautifully. Within the next 2 hours she delivered beautifully a vaginal delivery. So but the residents need to be given this confidence from us, the teachers. Otherwise, you're right, there'll be nobody left to conduct a breech delivery. We just have to keep 3 principles of breech vaginal delivery in mind. That is all for all the residents who are here. We just have to allow the mother to push and not pull from below. We need to keep the back anterior. And third is give a suprapubic pressure. If we remember these 3 cardinal principles, there shouldn't be absolutely any problem if we have selected our patient carefully. And I think this art should not be allowed to die, that rightly sir has said. 1 or 2 questions, sir, that we have for you from the audience. How do you manage uncomplicated term extended breech at a mother asking for vaginal delivery?
Yeah, so if the patient meets all the criteria like no hypertension of the head, they must be allowed to deliver till there is crowning of the breech at the perineum. Till then, you should not do any maneuvers. If you have, in fact, the extended breech is a good dilator of the cervix compared to other complete breech, because it is more compact. It dilates the cervix nicely. And first thing is, once there is crowning of the frank breech at the perineum, periotomy should be done, and the delivery of the breech should be allowed till umbilicus without any much manipulation. And you must have a pelvifemoral grip. You should not hold at the abdomen, otherwise it will cause visceral injuries. So pelvifemoral grip is very important, and you must see that always you have back as anterior, as I elaborated earlier. Hello? I'm not able to hear you, madam.
Sorry, sir. So the second question is that if there is a twin pregnancy with first breech and no maternal comorbidities, and the mother asks for a vaginal delivery, how do you proceed?
Definitely, it can be undertaken. If the patient, because we have seen in many times, there is so much of vaginal deliveries in medical colleges, especially twins, because most of the times the weight is less. Most of the babies weigh less than 2.5 kgs. Definitely is not a contraindication. And the twins, if you read indication for cesarean section, non-cephalic presentation of the twins is an indication for cesarean section. It does not always hold good. Even if twins with the breech presentation as a first baby can definitely be allowed for vaginal delivery if they meet the criteria of trial of labor for breech.
I totally agree with you. I totally agree with you, because it is a relative indication for cesarean section, and many times in our medical colleges we find patients who are severely anemic, thrombocytopenia and all other comorbidities. So doing a cesarean section in such a woman would be more hazardous, and we have actually delivered non-cephalic presentations, first presentations in a breech in a twin pregnancy, and the patients do fairly well.
Basically speaking, the obstetrics must be institutional practice.
Yes.
What happens is we don't have support of midwives in India. There are a lot of obstetricians are there. We are doing every work of so starting from seeing BP, doing para-abdominal examination, seeing FHS. What happens at the end of the day, the individual private practitioners are, they are all tired and exhausted, and they are not in a mood to wait too long for vaginal deliveries. This is what happens. So my teacher used to say, obstetrics must be institutional practice wherein there is rotation of duties, there is monitoring, constant monitoring. In private practice, what happens? Every responsibility lies with an obstetric practitioner, and they will err on the side of cesarean section than vaginal delivery. That's why we see a lot of deliveries, vaginal deliveries happening in institutions than in private practice, individualized practice.
Thank you very much, sir. The next speaker is ready. Thanks for
Okay, sir. Thank you very much, sir. Thank you for the opportunity.
So may we have Dr. Purnima slide up, please? Dr. Purnima Jaydev is going to speak on the conduct of labor in COVID-19 pandemic. We welcome you, ma'am.
You can share, madam, or we should share from here. Yes, started.
Yes,
Hello?
visible,
Yeah,
madam.
you can see, madam.
We
Now
can
visible?
make it full screen. Yes, madam.
Yes, I'm from General Hospital, Jayanagar now. We are having 300 bed hospital at present, and 120 is given to the COVID. In there, we are having separate delivery section, and we are delivering only the negative patients now. All positive COVID patients will be shifted to either Victoria or other COVID dedicated hospitals. Whatever we have delivered the patient and got the results afterwards. That's why we are having delivered vaginally 3 patients are positive and LSCS 50. And after the recovery, there are 4 patients we have delivered. But most of them, as soon as we get the results, we are going to refer them to higher hospital where they are conducting COVID-19 because they'll have separate settings. I will tell you later. And we have observed oligohydramnios, thick edematous scar, meconium stain, amniotic fluid in these COVID positive patients. Maybe this is of some help, but at present it is very small study. We cannot conclude anything. As the WHO tells, it is the woman's right to safe and positive childbirth, whether or not they have confirmed COVID-19 infection. So we have to give them the full safety, full positivity. Then that is, we have to have a attender with them. We have to speak with the patient properly. Nowadays, I've seen with COVID-19 patients, nobody want to go near the patient at all. And I'll tell you how it will be very easy with my talk. Educate the health staff initially. That means you have to train health staff periodically with graded stage comprehensive training. That means you have to periodically train them because every day we are getting new SOPs from the government side, and we are getting a lot of studies which are telling you, you do this, you do that, like that. And we have to do the graded. That means for doctors, we have to train in a different way. For staff nurse, we have to train it in a different way. And even for Group D and our lab technicians, so many of them, we have to train in a stage, and comprehensive training is very much essential as we do it in NABH, as we do it in NQAS, that is National Quality Assurance Scheme. Then also our Lakshya program and also Kayakalpa program from the government. Infection prevention and control measures has to be taught to all healthcare providers. Donning and doffing area. This is very important and it has to be done systematically. Donning is wearing the PPEs and doffing is removing the PPEs. Appropriate use of PPEs to be taught to everybody, how to wear the mask, gown, gloves, face shield, eye protection and shoe cover, which has to come first, which has to go last, you have to teach them. And Importantly, waste disposal practices to be followed stringently, and that is very much essential. We know with our wearing gowns or gloves, we are going to infect other people, so waste disposal should be properly done. And all of us are wearing this for the past 6 months, and I know how difficult it is to work with these gowns and other things on our body. What are the general principles followed in maternity unit? There are SOPs for the particular healthcare unit to be followed. Every health institution should have their own SOPs. So with that, it will become very easy that SOPs to be taught to all the healthcare workers present in their health unit. Infrastructure of the health unit to be modified according to its need. Infrastructure changing is very difficult sometimes. At least in the government sector, we are telling that in our hospital only this is done, you go to other hospital for something else. But in small institutions, where small nursing homes, where they are having only one labor room, it is very difficult to manage, I know. You have to have a triage area. Triage area, whether they are positive, they are negative, you have to ask for the history to be well taken before, but now I tell you, consider everybody is having positive. Personnel to be trained continuously, that is very, very important. Availability of PPE all the time. Initial stages when COVID pandemic started, we didn't have PPE. At that time, many doctors, many healthcare workers were affected, but now PPE availability is so much. At least in my hospital, I always tell proudly that all our health personnel are very well equipped, and only I got around 30 among 300 workers positive. Then infection control practices to be followed always. Always, I am been telling in all my slides, infection control practices. Wash your hand and wipe the surfaces. Don't use extra things in your OTs or in labor room so that the virus will sit on those things. Then restrict visitors to hospital is very, very, very important. And I have seen for one delivery, there will be 10 attendants coming with the patient, and that has to be reduced. Use of the mask to be compulsory for patients and also for the attendants. And don't go out of the labor room on and off. This is for patient and also for the patient attendant who is with them. And what about the antenatal care? So I have told we can restrict the number of antenatal care. We can postpone the antenatal care visits, but you cannot postpone the delivery. And ICMR tells only 4 visits at least is enough. One at 12 weeks to see the nuchal thickness, at around 20 weeks for the anomaly scan, and any problem you can terminate the pregnancy as usual, even if they are COVID positive. At around 32 weeks for ruling out diabetes, and if you want to give injection TT or any other to talk with the patient, you can call her at 32 weeks. Again at 36 weeks, you plan for the labor. You have to instruct her to get her RT-PCR 1 week prior to the EDD, so that you know that they are positive or negative. And if they come in labor pain at any time during their pregnancy, you have to do RAT. RAT is rapid antigen technique, antigen test, and it will come positive for the positive patient. And if it comes negative, it will be 50% positive again. So if you do rapid antigen test and it is negative, go for RT-PCR again. And with fever, cough, anosmia, any other symptoms, you can do RAT at any time and admit the patient and get RT-PCR as it is required. And how will you manage the COVID-19 positive patients when they are in labor? Management of labor is not altered in COVID-19 positive patients. This you have to remember. It is like normal delivery, normal patients, you have to treat them, except for person-to-person contact should be limited. That means you don't have much healthcare workers even in the labor room. Restrict the number of doctors, number of staff, and you can have only the particular doctor and staff should be attending that particular labor, and they can be given off the next day or alternative days they can work. And time in the labor to be limited. That means patients should deliver and go from the labor room as early as possible. So for that you have to give them, make them to undergo active management of labor. I'll tell later. only one attender. If at all you are allowing any attender inside, you have to allow only one attender. That too has been tested for COVID-19 and found negative. See, in the foreign countries, Western countries, they always have their husband with them during delivery time. And for us now in Laksha program, government is telling you identify one person to be with the patient always. So we are trying to do that. I know it is very difficult to do, but we have to have an attender for all the problems, because sometimes PPH, very less healthcare workers, PPH workers, nobody is there. At least that attender will be there to call the doctors or the nurses. Preferably in room with negative pressure. You deliver the patient with negative pressure rooms, and even OTs to be negative pressure. Separate entry into isolation ward, labor ward, and separate exist. If it is available, it is well and good, so that they are not mixing with the COVID-19 with the negative patient. COVID positive will not have this one with the negative patients. And separate operation theater is need of the day, because we don't know who will be coming positive, who suspected cases will be there, so many, and they'll come in labor without any test. And I've heard patient refusing for testing. They don't want. If they test, if they tell positive, it is like one very bad moment, very sad. And they not understand it is, they think it is untouchable. If they become positive, it is untouchable. So baby corner is also to be planned. It should be at least 2 meters away from the delivery bed. We have seen delivery bed and the baby corner that this one is very nearly placed, incubator. So we should not keep it. It should be 2 meters away, and remove all the unnecessary things in the labor ward. I insist, remove all unnecessary things, keep only whatever is needed. And when you do cesarean section, it is as for any other, and COVID-19 infection is not an indication for C-section. That you have to remember. And anesthetists should use proper infection prevention control measures. They are also very, very scared. They are more scared than the obstetricians in my hospital. And they tell, without COVID test, you don't enter into the OT. That is good for everybody, even for them, even for the obstetrician, all the healthcare workers and other patients we are going to get the next on the table. Anesthetists should decide about type of anesthesia. They are preferably doing with spinal or epidural. General anesthesia is taken only when there is a need, because they don't want to have aerosols when they are introducing. There are now video laryngoscope. They are using video laryngoscope, and that will be of very help. They can use video laryngoscope in this set. And how will you manage suspected cases in labor? I tell you, suspect everybody is positive now in this pandemic. We don't know who is positive, who is negative. So suspect positive, that will be better. So institute infection prevention and control measures, use PPE. Everybody should use PPE, whoever is handling the delivery cases. Transfer them to an isolation room, even if it is suspected, or they should have a separate isolation room. That is always better. Do not delay obstetric care in order to get COVID-19. Some people have seen, without test, we are not going to take. If they are in labor, and I have not heard anybody delivering on the road, as patients are dying on the road, and I didn't get anybody delivered on the road in our setup at least. Treat as confirmed 19 until the test results are available. See, you might have sent the results. Don't wait for the results. You carry on with your PPE and other whatever infection control program you are going to take. Induction of labor. What to do induction in COVID positive patients? COVID-19 infection as such is not an indication for induce of labor. Amniotomy can be done to augment the labor, and they have found out that in the amniotic fluid or in the vaginal fluid or in the breast milk, there is no virus as for now. 1 or 2 studies tell out of 100, 1 patient had in the amniotic fluid, 1 had in the breast milk, but still the studies has to be more. Amniotomy with oxytocin, misoprostol with oxytocin will reduce the time of stay in labor, and that is what we use it in active management of labor. And what will you do in the intrapartum? You can use Dopplers, you can use continuous CTGs, and encourage the patient to wear mask all the time. And healthcare workers, of course, PPE should be used, and always stand near the leg and foot end of the patient rather than the head end. And especially when they're having the second stage labored breathing, sometimes they'll remove the mask patient, or in labored breathing, there will be aerosols in the this one room. Be careful to wear PPE at that time properly. And what about transmission to child from mother? There are no studies as far as now, and only 1 or 2 studies tell that there is a vertical transmission. The baby was found one day after within 24 hours or within 48 hours. 1 or 2 babies were found out of 100 positive, other 99 no. So as such now we can take vertical transmission is not reported. And as I told, there is no virus found in placenta, amniotic fluid and breast milk. Early cord clamping is advocated. As in this one, they were telling active management of third stage of labor, do delayed cord clamping only in the patient, babies who are compromised. You have to do early cord clamping. But in COVID positive, they are telling you do early cord clamping, thinking that there will be transmission of the virus from mother to child, so that it can be reduced if you do early cord clamping. Breastfeeding is encouraged with mother wearing the mask. Initially, they were telling you keep the baby separate, mother separate, you feed the baby with this one. But as you know, for HIV positive patient also we were doing, and we found more babies dying due to malnutrition. So diarrhea, with so many problems with the bottled milk or whatever they used to feed. Even with formula milk, they had problems. So that's why now government is telling better you keep the baby rooming, skin to skin touch will be there. And always a mother should wear the mask when she's feeding the baby, and baby to be kept away from the mother 6 meters when she's not feeding. That's all. And if mother is too unwell to breastfeed, if they are in ICU, they can give express milk or donor human milk from the milk bank if it is available, or no other go, you have to go with formula. And how will you manage postpartum? Vital signs, uterine contractions, maternal mental health conditions should be monitored as you do for other patients. But here I feel you should be the maternal mental health, you have to focus. Because as I told already, if they are positive means they will lose that confidence. They become depressed. I have seen many patients going for depression. So we have to encourage them that COVID positive will not do anything. They'll always tell, I'm going to die with COVID positive patient. COVID positive, I don't know. Even otherwise, normal patient coming to my room, if they are COVID positive, they tell anything happens to me, madam, like that. Nothing will happen. We have to give them moral support and attention to be paid for the prevention of PPH, thrombosis, etc. Like normal people, morbidity will be more with the diabetes, hypertension, tuberculosis. Even in pregnancy, if they're hypertensive, diabetic, having some liver problem, kidney problem, cardiac problem, they may go for serious symptoms, and they may need sometime ICU care. And the neonatologist should be informed half an hour before delivery to take appropriate measure to isolate the newborn. After 2 hours, shift the mother to isolation ward if vitals are found normal. After delivery, protection procedures should be followed, like wipe the surface instead of spraying. Preferably, ultraviolet irradiations can be used once and twice a day, and 30 minutes ventilation after irradiation. If once you do irradiation, 30 minutes ventilation you should do. Then at that time when you are doing irradiation, nobody should be there in the room. So to conclude, see, I've taken you very fast. I know I've been a little late. And as we've started in the COVID, this one pandemic, we don't know how to do. But now we know what to do, what not to do. So we can go very fast. And I always tell to all my doctors not to get panicked, because I've seen for the past 4 months, doctors are not working in the hospital. Those who are 50, 55 plus, they are scared. So I'm giving them, if we don't work in the hospital, who else will work? Who else will tell the patient, you will be all right, don't worry. All health units should have facilities, infrastructure, personnel to deliver or suspected confirmed pregnant women of COVID-19, and all women have right to safe and positive childbirth experience. Principles of labor management in COVID-19 pandemic remains the same, except the facility for isolation should be there. Pregnant women do not appear to be more susceptible to the consequences of infection with COVID-19 than general population. and multidisciplinary approach involving anesthetists, neonatologists, obstetrician, and infectious disease physicians is essential. And telemedicine like this, with the patient, this on video conferences also can be set. So that has been now the trend everywhere. We always have on phone call or WhatsApp, whatever you choose, you can go. And with this, I thank once again Madam Geeta Madam for giving me this opportunity to be with you. And very simple topic, but it is very scary also, because I've seen COVID, they just tell, no, I don't want to touch the patient. But please don't do. If we do not see this pregnant woman, who else will do? So I think I've made it very simple as possible. Thank you so much.
Thank you, Dr. Purnima, for an excellent and a very concise, crisp session on COVID-19. Just one comment that if you want to reduce the admission of asymptomatic COVID positive patients, like in our hospital, we have made a policy of defer the non-urgent admissions pending. We tell them to first, like post-dated patients, we on the outpatient basis, we can do an NST and an AFI. In the OPD itself, tell them to get the test and then get admitted.
Yes.
Number two is we can get a test rather than RT-PCR. There are other tests like TrueNat and CBNat, which have a quicker turnaround time. So they can be utilized, and we are utilizing them for getting the reports earlier.
Definitely, but don't deny in doing RT-PCR, because 50% of them will be negative. That you have to remember. So please see to that next day when you get, you have to isolate them, and whatever is given treatment you have to give. That is very important.
Madam, that is for the rapid antigen test. For the TrueNat, it has got an excellent sensitivity as well as specificity. It is like a PCR test wherein a sample is sent. So TrueNat and CBNat have got an excellent specificity and sensitivity, and it is said that we don't even need to do a repeat RT-PCR if that comes positive. Although RT-PCR is a gold standard, so that is what we are doing in our institute.
But we are not having in our facilities to do that. Maybe if the facilities are not available, we will be doing like this, we tell. Okay, thank you.
Okay, Madam, just a question on the, we have the rapid antibody tests. So one patient on the rapid antibody test, IgM is negative, IgG was positive.
Okay.
So now she had been infected earlier.
Yes.
And definitely we took universal precautions, delivered her, but RT-PCR was sent. And after one day we got the RT-PCR as positive. So what to tell about this patient? Is she infectious to us? Because RT-PCR will be positive even for few days, even if the patient is not infecting us. Maybe they are there.
Yeah, even dead viruses are present. It will show positivity. But the most infectious period is the second week. That is, once they are infected, the second week, not the 7 days. From 7 to 14 days, they are most infected. So if after that, even if it comes positive, it is not that much to be worried. But you have to have all precaution. Better. Once they are positive, better you use all precautions.
Yes.
If I can make a comment, madam. The Government of India guidelines now, they do not recommend doing a repeat testing for a patient who has been positive. They are kept for 10 days, they are kept in the facility, for 7 days home isolation, and after 17 days, they are considered non-infectious, and a repeat testing is not at all advisable.
Not at all, yes.
Gives rise to a lot of confusion as to what is the status. So they are considered non-infectious after 17 days, and no repeat testing is advisable.
Yes.
That is better.
Yeah.
Yes. Thank you.
Thank you.
Thank the organizers for giving us an opportunity to have us here. It was an excellent session, and I hand over to Dr. Veena to conduct the later session. Thank you.
Thanks a lot, Dr. Swati, for chairing our sessions for a long time and giving your inputs. We thank you very much from the organizers. And thanks a lot, Dr. Purnima ma'am.
Thank you.
Practical experiences, because I had heard your talk on POXO. That's why I wanted you to give a talk on COVID, because we want the practical things to be told. Situation.
Thank
the
you.
need of the hour.
Yes, thank you, madam.
Thanks a lot, Purnima madam. Thank you, Swati madam. Now we'll start with the next session, the panel discussion.
I would like to thank our coordinators, Dr. Veena, Dr. Uma Shankar Borkar, and Dr. Geeta Doppa. And also thank you to our chairperson and speakers of the sessions in the morning. So good afternoon to all the delegates of the conference. You have logged into the National E-Conference on Labor and Birth organized by the Department of Obstetrics and Gynecology, KVG Medical College and Hospital. So moving on to the last session of this conference, the panel discussion on case scenarios. The moderator of the session will be Dr. Ravikant Jio, Organizing Secretary, Associate Professor, Pelvic Endoscopic Surgeon of Department of Obstetrics and Gynecology, KVG Medical College and Hospital, Sulia. He is a very skilled laparoscopic and hysteroscopic surgeon. And the panelists of this session are Dr. Padmalata Venkataram. She's the lead consultant at Rangadore Memorial Hospital.
It's okay. I have been introduced yesterday. Thank you.
Yes, ma'am. I would like to introduce you today too, ma'am. She is the president of Bangalore RCOG Trust, faculty and research guide at Svyasa, past president, Bangalore Society of Obstetrics and Gynecology, national expert on diabetes and pregnancy, trustee doctor for SEVA. She has won the India Positive Award from CNN IBN for reaching out to people in 2012. Welcome, ma'am.
Thank you.
Our next panelist is Dr. Pradeep Ganiga, currently working in AJ Institute of Medical Sciences as HOD of department. He completed his MBBS, from KMC Hubli. He has done his MS OBG from Bangalore Medical College. He is a member of IAGE and member of Indian Association of Sexual Medicine Practitioner. His area of interests are male infertility, male sexual dysfunction. He has published many articles on national level. He is also a very good Yakshagana artist, the traditional culture of coastal Karnataka. The next panelist is Dr. Prasanna Kumar Shetty, Professor and Head, Shema, IVF Lab, KS Hegde. He is also President of Mangalore Obstetrics and Gynecology Society, past Secretary 2018 and 19, and formerly a lecturer at CMC Vellore.
Thank you. Thank you.
Welcome, sir. Our other panelist is Dr. Srimati Raman. She's a consultant obstetric and gynecologist at Rangadore Memorial Hospital, Bangalore. She has been awarded 10 gold, 13 prizes and medals during MBBS at college and university levels. She has been invited as speaker, moderator, and panelist in various conferences. She's a faculty in CTG, Obstetric Emergency Training Workshops. She has publications of posters and paper publications in state, regional, national, and international conferences. And her special interests are maternal medicine, medical disorders and high-risk pregnancy, advanced labor ward management, clinical governance, guidelines and protocols, and medical education, MRCOG, and CTG. Welcome, ma'am. And our other panelist is Dr. Prakruti KP. She is a fellow in maternal fetal has done a fellowship in maternal fetal medicine from Rangadore Memorial Hospital. She has completed her MBBS from JJM Medical College, Davangere, her DGO from KLE Institute, Belgaum, and successfully completed her DNB from Baptist Hospital, Bangalore. Her special interests are fetal medicine, advanced labor ward practice, guidelines and protocol development, and keen on skill drills. She has special and personal interests in serving the underprivileged section of the society. Welcome to all the panelists. And now I'd hand over the session to our moderator, Dr. Ravikant.
Good afternoon, everyone. Good afternoon, all the panelists.
Afternoon.
Good afternoon. It is a post-lunch session, a little more drowsy, which may be. So good afternoon, everyone. Once again, I am Dr. Ravikant, bringing greetings from the KVG Medical College, Sulia. Today's panelist just now our student has introduced. We have panel of 5 members. So we have a case scenario on 5 cases from normal labor to breech vegetation, so complicated, normal to complicated like. And we have one special rapid fire like questions, like one yes or no type questions which we come across in clinical practice. One for some of the funny situations which may come across in clinical situation, like in Natika Chuska, which our student has suggested. Case scenario on normal labor. Normal labor is following a normal conception. So as we all know, conception is a natural phenomenon. But it should end up in a normal labor in most of the situation. But sometimes what happens, there can be abnormality which need to be detected early as possible and need to be managed. But still, most of the cases end up in normal delivery without affecting much of the difficulty to the mother or the fetus. But while preventing the complications, we may end up in increasing the number of abdominal deliveries. But to reduce as much as possible the incidence of abdominal delivery, we have 2 day conference on understanding the physiology of labor and abnormalities of labor and various methods to conduct detect the early abdominal labor and manage the abdominal labor. So much of discussion has been done. So now today we shall try to apply on a real patients in our clinical practice how this knowledge can be applied in our patients. We shall go ahead with the first case of normal labor. She is a case of priming grada with 40 weeks, 2 days gestation. She was pursuing fetal movements well, and she came for regular safe confinement. On per abdomen examination, she had occipital lateral position. And per veg examination, the cervix was medium. That means all the Bishop score was not adequate. It was less than 7, so it's not a good Bishop score. But only pelvis was adequate for average stage baby. Pelvis was adequate. But, the impression, priming grada with 40 weeks, 2 days gestation. She was euthyroid on thyroxine, had a small 3 into 5 centimeter fibroid uterus, and she came for safe confinement without any complaints. And on admission, we did ultrasonography, which showed single live internal pregnancy of 39 weeks, 3 days with adequate Liker, and the estimated fetal weight was 3.9 kg. And our NST was reactive. So this is the situation of this patient. So just to avoid confusion, I'll just take the name of each panelist so that just to avoid confusion while answering the question, with your kind permission. Dr. Lata Madam, should we wait for spontaneous onset of labor or go for induction of labor?
Yeah, she is post-dated and she has come in with some niggles, and I think you can go in for induction. Cervix is fairly favorable. So I don't think you will be unnecessarily landing her up in section. So you can go in for induction.
Okay. So, Dr. Pradeep, so what is the preferred method of induction in this patient?
Yeah, first of all, it's when we read theoretically about post-dated pregnancy or past dates, whatever. So always the one thing what we makes to think twice, postponing the induction or waiting for normal labor. I mean, normal labor, normal spontaneous onset of labor. There's something called unexplained meconium staining of the Liker. Okay, that's the incidence is given. It increases after the whatever we call 40 weeks of pregnancy, significantly increases. So this is the one concern, because for clinically she may be looking everything all right, but there is one entity called unexplained meconium stain Liker. So it may cause further problem to the fetus if you postpone the delivery. Second thing, there is no clear-cut guidelines about as per the country is concerned, when exactly we have to induce the labor in such a scenario. It is the clinical decision left to the individual patient and to the individual clinician. But as per overall consensus among the treating doctor is not to wait more than 2 days, 3 days after the expected date of delivery. Thinking in terms of there could be a possibility of meconium strain liker, because of exact reason we don't know. There may be all the factor evaluation may be normal. Still, it is you have to keep in the mind. So, as a clinician, I prefer to induce when she crosses 40 weeks today. That's my opinion.
Okay. Okay. What is the preferred method of induction in according to you?
Pardon?
Sorry, can I just add on, please, if
Yes,
you didn't
madam.
mind?
Yes, madam.
Meconium staining of labor could be physiological. As the gestational age progresses, I think at term, from 37 weeks onwards, I think we're 7% at 37 weeks to nearly 15%, 11 to 15% at dates is what usually is seen. Meconium staining of the liquor can happen as a sign of maturity of the fetus. It need not be pathological. So we don't have to get unnecessarily alarmed about it, is what I wanted to say. And for each week of gestation, post-dated especially, it can increase up to 25% by 42 weeks of gestation. So one has to carefully monitor the labor with fetus rather with CTG if there is meconium stain liquor. And if the lady is not very keen on induction, I would have given her some more time, probably waited up to a week after the dates. There is, Indian data is actually lacking at 41 weeks. Yeah, people prefer to sort of deliver the women a bit early in India. There is only one paper to say that Indian babies mature early, and by 40 weeks, probably it would be like 41 weeks. So probably there's nothing wrong in inducing this lady because she is 40 plus 2 weeks, she has come to you. And if she is willing to be induced, fairly okay bishops, 4 is not too bad.
But WHO recommends routine induction 39 weeks, which gives them more chances of normal delivery.
No. Sorry. Yeah. Srimati, you want to say something?
No, ma'am. ARRIVE trial does come out with a recommendation that we can induce women at 39 weeks, even if it's a low risk primary section rates being very, very less. So I don't think we can extrapolate to our population and start inducing women at 39 weeks on a routine basis. If she's a high-risk pregnancy for various reasons, then you might want to consider at a routine low-risk primary gravidity. I don't think inducing routinely at 39 weeks would be a good idea with the limited evidence which we have got from ARRIVE trial. And of course, maturity of the baby keeps going. The CNS maturity keeps happening till about 39 and 40 weeks. So we wouldn't want to be doing long-term neurodevelopmental problems for the offspring by inducing them at 39 weeks.
Okay.
And also, the pregnancies might not be dated properly, so we might be delivering them prematurely. Also, early terms have more morbidity, neonatal-wise, and also long-term development-wise. So we have to be sure that we have crossed 39 weeks, which might be difficult in India, and there might be a lot more sections also. Thank you.
Yeah, as far as the method of induction is concerned, the specific
yes, sir.
that Dr. Ravi has asked.
Yeah. Yes, madam.
Now,
Yes,
there is no hard and fast rule which method of induction we need to employ, say PG2 or PG1 or whatever the clinical circumstances dictate, and whatever the obstetrician is more comfortable with and familiar with, that I would say is the more preferred method of induction. And as far as the time of delivery is concerned, I agree with the Srimati Raman that ARRIVE trial has indicated that routine induction at, a strategy of inducing everyone at 39 plus weeks can reduce the incidence of past dates and attendant complications. But in Indian scenario, once the patient reaches 40 weeks or EDD, psychologically, we tend to be, back when I was working in Vellore, the inductions were closer to 41 weeks. And when I came out of there, it was always closer to 40 weeks or 40 plus 1, 2, people start hyperventilating. And then as far as method of induction, as many obstetricians, as many methods. Particularly, it is prominent in teaching hospitals. You go to one unit, it will be one preferred method, and another unit, it will be, the preferred method. So it is really your comfort with the your comfort levels with the method of induction. And
don't we think that we should be having uniform protocols in the hospitals that we work? I think it's important so that people speak the same language.
I agree.
Yes, it should be individualized in an institutional protocol. Should be followed.
Yes.
Thank you. We induced her with the 50 microgram of misoprostol vaginally.
My only comment there would be probably chance of hyperstimulation would be more with 50 micrograms. We need closer monitoring. 25 micrograms appears to be safer, and also oral misoprostol appears to be more effective.
Okay, point taken, madam. So how many doses can be repeated, madam? How many doses? Like in the textbook they mentioned up to 6 doses also can be, but in practical?
Up to 5 actually. Some books say you can go up to 5. You can repeat 3 to 6 hourly actually, according to the level of uterine contractions. Sorry, the question was for ma'am. Sorry.
For me, yeah. Okay. For me, yeah. Yes, we do give them, as he said, 5 doses per day. That would probably take them up to 10 hours. Because we give them every 2 hours, 25 micrograms of oral misoprostol. We rest them overnight and might repeat the same thing the next day also. Yeah, I don't want to sort of talk about, well, if she did not respond on day 1, what we are going to do, maybe we will have a question later, or do you want me to continue?
Yes, we have questions later.
Okay.
So she was monitored regularly for her vitals, uterine contraction, fetal heart rate. What is the preferred method, madam? Whether continuous electronic monitoring should be kept or intermittent oscillation is okay?
Well, you are talking about induction, isn't it? Yeah.
Yes, madam.
Intermittent auscultation, if she's a low risk woman without any fetal compromise, and if the traces have been satisfactory post misoprostol, I think intermittent auscultation would be fine. But for our own evidence, I think it is important that we have a trace probably an hour after misoprostol. Whether it is vaginal or oral, I think it is important to document a normal trace. And even prior to induction, it is important to document a normal trace. Later on, it can be intermittent auscultation. If there are problems with auscultation, then you can do intermittent tracing. But in our practice, truly in our practice, we do tracings on and off at least every 4 hours. The woman would have had some form of tracing just to reassure ourselves. Sometimes you can't rely on the staff completely. That is another problem.
Dr. Pradeep, what is your take?
First, it's very well understood that all low-risk pregnancies, continuous monitoring has no additional benefit. That's a take-home message known to everyone. Yeah. But my question is, should we put this post-dated pregnancy, will put under a high risk or low risk? Again, the one more entity comes. I think if you individualize, depending on your resource availability and other things, you can put, it's not a mandatory to monitor with the continuous electronic monitoring. I think intermittent auscultation will hold good.
Okay. So if the facility is available, initially 1 hour of induction, continuous monitoring, and afterwards you can go for auscultation.
That is probably not continuous, 20 to 30 minutes.
Okay, madam. Okay.
Trace. So I would say intermittent electronic monitoring rather than intermittent electronic monitoring. Yeah.
So in our for this patient, though we have the facility for continuous electronic monitoring, but for this patient we did the intermittent auscultation.
Sure.
After 4 hours, she had only 2 contractions lasting 20 to 30 seconds, and the patient didn't improve much. From 5, it became 6. That's all. So we repeated misoprostol 50 microgram vaginally once again after 4 hours. So after induction of labor with misoprostol, how long can we wait to call it as a failure of induction, madam? Srimati, madam?
See, basically, for the induction of labor, the definitions are very varied. Each society has come up with varied definitions, but whatever ACOG says is you complete a course of cervical ripening, which means that as we discuss, if it's going to be oral or vaginal misoprostol, at least give them 5 to 6 doses. And after a course of cervical ripening, then you would see if you can rupture the membranes if it's favorable. If not, maybe you can continue with cervical ripening, or if not, if you're going to give oxytocin, at least 24 hours of oxytocin. And if you have failed to get them into established labor or not having regular contractions, that is when you should actually diagnose as failed induction. So if you look at the definition, it is actually a pretty long period. So you might argue 24 hours of oxytocin induction is not practically feasible in a normal day-to-day setting. So that is why I think it's important to consider a repeat course of a different cervical ripening. If you have given misoprostol, then maybe you would want to consider a PG, sort of PGE2, or maybe a mechanical induction, and give her a proper cervical ripening, provided the maternal and fetal conditions are satisfactory, and then consider rupturing the membranes and starting oxytocin. But be very careful before you deem this patient as a failed induction, before giving her a proper cervical ripening and a proper induction.
Dr. Prasanna, sir, what is your take, sir?
Yeah, like ma'am said, this kind of look at Arul Kumar's mechanism of labor, then the definition is quite different, and the recent studies they are much shorter. What they say is 1 cycle of induction, and also we must remember that the lines between cervical ripening and actual process of induction are being blurred, because some people go into labor with your misoprostol or cerviprime, and some books say that with good uterine contractions, and she has not the cervical dilatation is not gone into active labor. So these kind of things are also qualify as induction of labor. And my take is, if the indication is not urgent, then you can, if it is urgent, you can repeat maybe PGE2 after 6 hours, or 3 to 4 doses of PGE1. If the indication is not very urgent, you can counsel the patient and give a break and repeat your this thing. Because as long as the membranes are not ruptured, there is no point of no return. So you can always, the patient can sleep on it and decide the next morning. Patient and doctor both can sleep on it and decide the next.
Yeah, if she hadn't responded, probably we can even review the indication for induction, and then probably
go back to the dates.
Bring her back. Yeah, because in this case, there is no hurry actually. If she hadn't responded, I don't want to put her unnecessarily under the knife. So,
like 24 hours
indication, induction should be considered in all seriousness as an intervention.
Yeah.
And what our residents and we fail to remember is that at the start of the process of induction, we must take the consent for both intrapartum cesarean section as well as whatever the intervention. So it should be taken with utmost seriousness that it is an intervention, and the attendant complications.
Proper counseling of the patient before induction is very, very important, telling them that it can be a long drawn process, and they may have to be patiently waiting if you want to give her a proper induction process. Because just though NICE guidelines also say 1 course of cervical ripening, and then you can call it as a failed induction, but I think we wouldn't be doing justice to the patient by just giving her 1 course and then if everything is satisfactory, calling it a day and doing a section. So it's important that we counsel them and be patient, provided of course maternal and fetal conditions are satisfactory.
Yes, madam. Like normal labor patient or maternal condition, fetal condition is normal. So how many doses we can wait that to tell that she's not going to respond to
1 course of cervical ripening. So if you're going to give vaginal misoprostol, maybe you'll be repeating at least 5 doses. After that, the only problem is we tend to give oral misoprostol, so it becomes very short. Whereas if you're going to give vaginal misoprostol, the recommendation by WHO is 25 micrograms 6 hourly. So if you're going to give 4 or 5 doses, then that is going to be itself a long drawn process. So we generally give 25 micrograms 2 hourly, finish a course, and if nothing has happened, you rest her, and then again repeat it with another cervical ripening agent. Either we go for, sometimes if it's very favorable, then we might even go for a repeat misoprostol, or if not, we look at whether we need to do a mechanical dilatation, because it's always better to use an alternative cervical ripening agent so as to mix and match and make sure the uterus responds better.
Okay. Dr. Prakriti?
Sir.
Yeah, this initial observation of continuous or intermittent monitoring with NST, are there any finding favors that we should stop monitoring, like continuing the induction of labor?
So I'm unable to hear clearly.
Yeah. Suppose if you are doing a continuous electronic monitoring for this patient.
Okay.
Like after 1 hour, 2 hours, if any NST findings that may tell that we should not go further, in only electronic monitoring findings goes against the continuation of induction of labor.
Okay, only if there is a pathological CTG. If suppose there are persistent variable deceleration which are deteriorating and with poor variability, any such things which of pathological findings, we think of it's better go for a abdominal delivery. If in case it is suspicious, still we resuscitate mother by giving fluids, left lateral position, wait for it to improvement. And in case if there is no improvement and deterioration, then we think about no point going ahead.
But many a time we'll see variable decelerations most of the time in first stage of labor. So,
yeah, recurrent variable deceleration with atypical features like, as I said, poor variability or loss of shouldering or W wave pattern. These are all the atypical features. If such things are seen for the next 30 minutes, then we consider it as pathological. Otherwise, we can continue resuscitation, give her fluids, and watch for further few
means
hours.
1 or 2 episodes of bradycardia, tachycardia is not an indication for abdominal delivery.
No. Yeah.
Okay, thank you.
If you are really worried about the trace, probably you would ARM her, and if possible, and see what's the color of liquor. And then meconium, if there is meconium, it becomes significant. So,
one point I wanted to add is if the mother is hyperstimulating, and if you're worried about the CTG,
absolutely,
please do not ARM, because people tend to start doing ARM because they're worried about the CTG. She's already hyperstimulating, and then we go and do an ARM, then we are going to further increase the strength and the number of contractions. So when she's hyperstimulating and we have worries about the CTG, then the ARM is not recommended. You would rather just prophylaxis and resuscitate. But if not, yes, ARM is definitely helpful.
Sure.
Thank you.
And also, if there is hyperstimulation, especially when you're using 50 micrograms of misoprostol, if there is hyperstimulation, then I would give her terbutaline also to settle down the contractions and see whether the trace improves. That is part of resuscitation.
9.5 hours, she still had only 2 contractions for 30 seconds, and fetal head also not descended. Bishop score also not much improved. So for this client, so should we change the preparation? Now we are used misoprostol, should we change the other preparations? Can we go like that, madam?
Yeah, I mean, 9.5 hours from when? That is insertion of the first misoprostol.
First misoprostol.
I think you can still continue with misoprostol.
Misoprostol.
You don't have to really particularly change
No point in
the
changing
method
the
of induction.
preparation.
There's no harm. Yeah, and if if the lady is objecting to vaginal misoprostol, probably you could change it to oral misoprostol. That is one of the things. I don't think I will change the induction agent at the moment.
Dr. Pradeep, what is your take on it?
Yeah, that's what we also do. Same thing. Once we adopted one method, I think we will continue. The augmentation will be done, but the changing again to another method is not
Stick to
practically
same
right
kind of
thing to do.
preparation.
Yeah, sure.
You should stick to the same kind of preparation.
Yeah, same protocol and continue as per the required doses. Then you reassess. That's the thing, what we do.
Okay.
Because jumping over to one more method is not, I think it ultimately it makes more confusion, doesn't serve the purpose. Before that, I think when you selecting the method only, I think you could have selected something else rather than misoprostol.
So
That's
did
what
you
my
select some other induction method for this patient?
PG gel would have been the better. That's what my feeling actually.
Okay.
Especially in a
Why do you think like that?
Thought about Propes more than gel. We prefer Propes if you think the bishop is very unfavorable. Then we give them a vaginal prostaglandin. We give PGE to pessary 10 milligram. So that stays in for 24 hours, and it has got a better effect in terms of cervical ripening. And obviously, you do not have to do repeated examinations like you have done in this case. So if you think the bishop is really unfavorable, you think that she might need multiple doses, maybe you can consider even giving her a vaginal insertion.
One more thing I take into consideration clinical practice, the liquor. Whenever the liquor is a good amount of liquor, my preference is always like misoprostol is not a problem. But when the liquor is borderline, especially that happens in a post-treated pregnancy, I feel the PGU2 would have been a better option than the PGE1, according to the liquor estimation and all.
Okay.
Would agree with you, Dr. Pradeep. And also probably, Foley's induction probably would be better. If you are really worried, for example, IUGR or severe oligoamnias, if you're worried about the contractions and the monitoring, how much you can depend on the staff, etc., I think mechanical dilatation of the cervix is a better option.
Yeah, actually, chances of quite underrated. If you put Foley's, another good thing about Foley's is once it dilates, there is no waiting period. You can actually start oxygen.
That's right. Yeah.
This is also one of the advantages.
Yeah. And we combine Foley with
fallen out of favor these days.
Also, sir. We combine Foley with misoprostol also. So that also seems to have a better effect. So we put the Foley, same time give them pharmacological, sort of reduction. So combination of both. So Foley's and miso seems to be working very well for us.
Yeah, but not in case of oligoamnias. Yeah.
No, not in case of oligoamnias.
My only thing is the dosage of, like ma'am said, instead of 50, I think 25 micrograms, not about the method actually.
Okay. Vaginally, 25 would have used this.
Vaginally, every 2 hours, it's very difficult for the patient to
Madam prefers every 2 hours, 25 orally.
Orally.
25 orally, and
there is evidence.
25 6 hourly.
Okay. What about the Foley's method of induction? Does it increase chances of cervical incompetence in future pregnancy, madam?
No.
Well, we haven't come across any studies, but neither have we done any studies. But it doesn't. It's a very gentle dilatation of the cervix.
Because
So
suddenly over 4 hours, 5 hours, it dilates up to 4 centimeter.
right, that's right. Yeah, that is what happens in labor also.
It is mechanical
Gradually.
dilatation.
Yeah, it is. But we haven't come across any studies. Neither have we done any study, to be very honest with you. But I don't think it's a very gentle, very interesting question, but it's a very gentle dilatation. It's not like 18 Hagar, 20 Hagars being passed one after the other, breaking the cervical, collagen and the rest.
Yes, after 11.5 hours, patient had 3 contractions for 40 minutes. She's going into labor, but still parabdominal head is just 3/5 palpable. Cervix, only the length of cervix has decreased. Otherwise, same rest of the findings of the Bishop's Coras should we use prophylactic antibiotics routinely, madam?
We don't use prophylactic antibiotics routinely. There is no evidence for that also.
Okay.
Dr. Ravi, before I go to that, the fundamental question here is
Yes, sir.
11.5 hours from what, actually?
Sir, from the time of induction, sir. First dose
Meaning
of,
the time you put the misoprostol?
yes, sir. First misoprostol. She was not in labor.
Grows with, because the clock starts ticking from, as far as my personal opinion, the good or the time when she actually goes into labor. So otherwise, what happens is most of the times the patient is inside your labor room with the Serviprime or misoprostol, and people prefer to keep her inside, and the relatives think that, oh, my daughter or daughter-in-law is inside for so long, and they will also start counting from that time. So we should have a clear distinction between that first dose, and if you have taken a post Serviprime or misoprostol trace and the uterus is quiet, we can actually send her to the pre-labor.
Okay. She should not be in first stage of labor.
Particular time, I have this thing with. So that we should guard against, because patients' relatives start counting from that time.
Yeah, definitely, patient's apprehension and relatives' apprehension will be there once taken into labor room.
I think we should keep them in the room along with the relatives. Okay. That's what we do. And they require less analgesia. They make less fuss and they wait longer.
Okay, so madam doesn't prefer any antibiotic. So 3 questions were, we give routinely when the patient a second dose of prostaglandin is given, we usually give ampicillin 2 gram for first dose and then 1 gram 6th hourly.
Do you feel, in your practice, did you have any studies, or did you feel that the chances of infection are more if we did not give antibiotics?
We found like that, madam. When we were giving only around the time of episiotomy or around immediately after the delivery of the patient, we used to give antibiotic. We are finding more incidence of episiotomy site infection. So when we stand even lower abdominal pain, not puerperal sepsis we can call, but puerperal fever we could have called. Such patients were increased. When we started antibiotic, then significantly reduction was there.
I agree with madam that antibiotics are totally not justified for low risk.
Because we are doing a PV examination, so that's why we thought.
I think we can leave it to the institution protocol. I think always we discuss antibiotic use and misuse. I think institution protocol, we have to stick to that according to your department guidelines. Madam is also, I agree, it's not an indicated, but if your institution protocol does like, you can go ahead, nothing wrong in that.
Even in some protocols in Western countries, they are very particular about antibiotics. In India, we are lax. But PROM, even term PROM people do not advise antibiotics.
Yeah, unless infection is there.
Because
the hospital protocols are important, but I think we need to be making sure that it is indicated, because unnecessarily the mother to antibiotics may give rise to antibiotic resistance in the mother and the offspring. So I think we need to be a bit careful when we are drafting protocols.
And also high doses of antibiotics given every 6th hourly, there can be there will be transplacental transfer, and it does affect gut microbiome of the fetus, which is getting programmed actively when the lady is getting into labor or through the labor.
Ampicillin mainly directed towards the GBS, group B streptococcal infection.
Group B, we don't find it very much in our
India.
country.
One of my postgraduates did a study. We hardly found anything here.
Okay. Point taken.
Handled outside cases really, referred to you after a long time in labor, etc. Then you can start an antibiotic. I mean, empirically, repeated examinations, etc. Yeah. Otherwise, in your own booked case, the patient probably not required.
Okay. Thank you, sir. So, does ambulation in the first stage of labor will improve the progress of labor?
Yes. upright position, ambulation, some of the, what can I say, postures, all these help.
So should we go for ARM now, madam, because edit 3/5 palpable, it is not yet engaged because around 11.5 hours over. Should we go for ARM or still we can wait for some more time?
No hurry. No hurry for ARM.
Okay.
That's all I would say.
So after 13.
I mean, if you really had to do ARM, even if the head is not engaged, you can. But there is no hurry for it here.
Okay, ma'am. Okay.
You can just leave them alone.
Because once we break the membranes, as Dr. Prasanna sir was saying, the clock starts ticking. You're worried about infection, isn't it?
Yeah.
So
And also, you're bound to put her on oxytocin and you will tie her down to the bed.
Yes,
So you get distressed, she gets distressed, all of us get distressed.
Absolutely.
So we call the anesthetist and cause the ultimate distress of section.
Okay. So after 13.5 hours, she had a good uterine contractions. And even FHR also started moving towards the midline. And Bishop score also improved. So now uterus cervix was 4 cm dilated. We did ARM under aseptic precaution.
Yeah.
So can we anticipate fetal distress due to prolonged labor? Though the maternal condition and fetal condition was normal, did you anticipate a fetal distress even though maternal vitals and fetal FHR are normal?
So I'm not sure whether you should label this as prolonged labor.
Prolonged labor.
It is only induction. She's not yet gone into labor at all. So, I don't think we should even label it as prolonged labor. Obviously, if the labor is prolonged, then there is always a worry, how long the membranes have been ruptured, how many examinations have been done, whether she's going to get infection. If that is the case, then there is going to be some concerns on the fetus. But otherwise, this is not even prolonged labor is what I would say.
Actually, she has progressed quite well.
Dr. Prakriti, what is your take on?
Prolonged labor itself will not cause any fetal heart rate variation. Maybe if there is, because of prolonged labor, if there is any chorioamnitis or anything, that can show up the changes in the CTG. And that can result in the distress.
Uterine contractions are there for a long time. Like uterine contractions are there for 7 hours, 8 hours.
That's okay, but she has been well hydrated and maternal and fetal parameters are normal. We can continue with the labor.
Okay.
And she has just been ARM'd. No problems.
Yeah.
Okay, thank you. So if labor analgesia is used, so does it prolong the active phase of labor? That is like many people don't accept for labor analgesia just because they think that labor will be prolonged.
No, there is no evidence for that. In the latent and active phase of labor, there is no evidence that it will prolong the duration of labor.
Correct. The evidence is that epidural, especially the low dose, doesn't prolong the active stage of labor. But if you look at the contemporary labor curves, there is a slight change, both in numbers as well as in multiple. There's a slight shift when epidural has been used, but it's a very slight shift. So for that reason, I don't think we should be worried and not give them epidural. But that is something which you would need to keep in mind. But generally, evidence is that epidural should not, in a great way, affect the labor progress.
Second stage,
especially
yes.
the first stage of labor.
So no, sir. If you look at the contemporary labor curve, if you look at how the curve starts, even from the first stage, there is a slight shift towards the right, both in the null depth and in the mul depth when they have had epidural, but it is a very marginal shift.
Dr.
But
Pradeep,
second stage, definitely, sir. The second stage, definitely, there is a marked difference.
I don't, there's no changes. I don't think there's any changes in the duration of, progression duration.
Okay, thank you. So after 15 hours, now she has strong uterine contractions and she has entered into second stage of labor. So when should we give position for the conduct of labor in second stage of labor?
Just because she is fully dilated, we should not ask her to push. That's what I emphasized yesterday. We should give her some passive second stage. If she doesn't have expulsive, forces, rather, if she is not having expulsive contractions which are making her strain, then I think we should just wait for it to descend. It is 0 is palpable, vertex at +1. There's no hurry. And CTG, if it is normal, I don't think there is any hurry. So please don't position her in lithotomy just because she is fully dilated. Ask her to get pushing, and then she gets tired, you get tired, and she lands up in instrumental delivery. So I think passive second stage is very, very important if the lady is comfortable. So let it descend, and let her use minimal efforts to push. So you will have a successful vaginal delivery, spontaneous vaginal delivery.
Means what position, when we give position, madam, what is the station you should be at least? Or...
Well, if she has, if she is I mean, whichever position she is comfortable in, you can.
No. When we should give conduct of labor position, like what stage she should progress? In second stage of labor also, she should be given when she reaches
active pushing. You don't have to put her in lithotomy. You need not put her in lithotomy at all. Actually, you can just leave her on the bed. She can keep pushing, and yeah, she can flex her legs and push, or she can squat and push, whatever. Yeah, until you are ready to deliver her. So delivery position can be different, but active pushing can be in many different ways, or lateral position and pushing. So many ways of pushing.
Prasanna sir?
Yeah, I would agree with ma'am, because maternal pushing actually contributes to very little of the force required for the second stage, because many uninformed if you have to educate our sisters to stop urging mothers to do this horrible thing right from the time like the rectum is dilated, and it is not actually required. So position wise, we've just had in the morning a session about entire positions of labor, because it doesn't really matter. But only problem is monitoring the fetal heart and looking for. So the most commonest by convention in our country, we have been used to the dorsal position. When the head is seen on the perineum and it is not going back, probably I would make a
she was ambulating all the way through first.
I would keep my set ready, everything, I would, when it is not going back, or yeah.
Yes, she was ambulating throughout the first stage of labor. So when should we tell that we can take her for conduct of labor? Like what the station should be?
She can continue.
She will guide you. She will tell you.
Yeah.
I'm not around anymore. She will go back to the bed, and she thinks that. Yeah, that's the thing.
And she says that something is coming out, and I really have great urge to push. And then you can put her on the bed and see whether the head is visible actually.
Yeah.
Okay, so when the head is visible, we can give the position.
Yes.
Yeah.
Why not?
The position is only needed if you have to operate.
One thing, this is all depends on the which setup you are in a medical college setup, especially in a government hospital. So me and Prasanna did from Bangalore Medical College in Vanivilas Hospital. I think we have to, otherwise delivery is guaranteed in a So we have to tell them this is the time you have to shift, confine to your bed, don't move around, and make her to deliver in a delivery room. Other than delivery will happen in some other places. I think it depends on the setup.
I would agree with that. Yes. Otherwise, delivery will happen in the toilet.
Yeah, sure. So that is, I think, as an institution, we are both of you are working in an institution. I think we have to have certain guidelines when she confined to the bed. In a nursing home or in a private corporate hospital, that may differ. But in a medical college, when many women are delivering at the same time, I think we should make them to confine to bed for better. I mean, both for the clinician and for the patient.
Okay.
Yeah, depends on the setup. I don't dispute that. But ideally, that is the most convenient, comfortable for the lady to be walking around, doing whatever she wants to. And then, lie down whenever she is just about to deliver. That would be very kind to her. That's what I would say.
What is the preferred position, madam, to conduct the labor?
I think Again, it depends upon, as Dr. Pradeep and Prasanna have been saying, it depends upon your institutional preferences. But generally, we seem to be delivering all of them in lithotomy position. But if you look at midwives delivering, they deliver them in various positions. They deliver them in all fours. They deliver them in the niches position, squatting. So I think it depends upon what you are comfortable with. See, if I'm not comfortable with a lady delivering in squatting position, and I'm going to encourage her to squat and deliver, then I'm going to run into problems. So I think it depends upon what position you are generally comfortable with, and I think you should follow that.
Thank you. So client was given a propped up position with lithotomy when the 3 to 4 centimeter of fetal head was visible without separating the labia. Now, how long can we wait in the second stage of labor to deliver, madam?
So you actually did that, what I was saying. Okay.
Yes, sir. How long we can wait in
second stage of labor with the stable, sorry?
Vital, sir. Like
okay.
Metal findings of a normal, fetal heart rate also normal.
From epidural and the primi, the timings are quite flexible now.
Yeah.
2 hours, and now with everything going right, you need not be so rigid about it.
At least 2 hours of active pushing in a nullip, in a prime. Yeah.
Yeah,
we don't have to say that she is getting tired. We should know how to make her relax in between the contractions, keep her hydrated, etc., etc. And we should have a high threshold for instrumental delivery and section, and I think many things will be sorted out.
So just because arbitrary time limit of 2 hours over, so no need to worry.
No need to worry. It depends. Every case has to be individualized, so no need to worry. There is nothing to say. It's like we have to just go and deliver her if everything is all right. And there is descent. There should be descent with active pushing, progressive descent. Otherwise, there's no point. If there is,
Dr. Prakruti. So when the patient is second stage of labor, strong uterine contractions are there. So just because fetal heart rate is normal, can you assure that fetal condition is normal?
Yeah, definitely. Sir. Yeah, we can wait as.
Because many of them it happens that after the delivery, baby will be admitted in NICU.
No.
There are some studies which have shown a very long duration of second stage of labor can be associated with some worse maternal perinatal outcomes, say if they've had more than 4 hours of second stage. So, but obviously we will be monitoring the mother and the fetus, and then we would be deciding when to be intervening. But we don't want to be leaving. See, how long is too long? This is what ma'am was giving in a talk yesterday. So we still don't know, but whatever evidence or studies have been done have shown that beyond 4 to 5 hours of second stage, there can be slightly increased complications in the mother and the baby. So we need to be very careful. But at the same time, not denying the adequate hours in second stage is going to be also riskier for the mother and the baby.
On an average, how much time?
If there is, adding on a point, if there has been descent plus 1 centimeter, she is already at +1. So 1 centimeter at least per hour. She should be delivering by 3 hours. So if she is not delivering, then you want to think why. See, we usually in our practice, what we do is at the end of 1 hour of active pushing, we assess the lady and see what's happening. Very important to see what's happening. Even if the fetal condition, CTG is absolutely fine. Because you want to prepare for where you want to deliver, how you want to deliver, etc., etc. And you want to keep your anesthetic and pediatric colleagues alerted. So I think it's important that we give them adequate time, but not too long. Even if beyond 3 hours, the chances of normal delivery, vaginal delivery also comes down according to some studies.
I was going to tell you that this was the most exciting part of the labor, actually.
Yes, sir. Yes, sir.
This is where if the time limit crosses, say 1.5 to 2 hours, your antennas should be on the alert.
Yeah.
So that is what ma'am meant.
Yes,
so
sir.
we should be, like she said, we should make all preparations, reassess the pelvis outlet and other things, rotation, etc., etc. I mean, all the works. So contractions, etc., etc. And in the unforeseen event of having a second stage cesarean, make all adequate preparations for it. So being prepared, you should be on the alert. This is the most difficult and edgy part of labor, I would say.
On the average, climax of labor.
Yes, yes, madam. On an average, how much time do you think that they will deliver? Like, on average, not talking about any abnormal, average baby, average.
Not about the time only. It is, I mean, everything you take it holistically. Like, what is the situation? What is going on? Like ma'am said, what are the deceleration? How is the liker? And how is the mother, etc., etc. So
okay,
it's not just the time.
Okay, thank you. So suppose if there is incomplete rotation is there, so we try to
manual rotation of the presenting part. Yeah, I'm very, very fond of manual rotation because it allows descent also. If there is not much of a descent, if I feel that it is an arrest situation, I just manually rotate, okay? Digitally rotate, I would say, most of the time, and it tends to come down. Yeah, if you rotated it into AP, when it has crossed the spines, yeah, the sagittal suture to AP, then it descends. Whether it is OA or OP, it tends to descend.
But one thing I want to tell here, see, we have adopting the whatever guidelines about antibiotics or waiting period and all, actually time duration and all. But if you go to the postnatal ward, a significant number of babies will be receiving injectable antibiotics, that is for 7 days, 14 days and all. Then how we will justify? Because whenever we question the pediatrician, the straight away tell, means not on the record, they tell it's because of the prolonged labor might have happened. This answer usually comes. I feel always saddened because the baby's mother will be there in this COVID crisis. I was ready to discharge on second day, but that sister will tell no, the antibiotics they have planned for 10 days, 12 days, injectable antibiotics. So how have you to, justify this situation? Because avoiding the antibiotics, allowing her to the enough time thinking that everything is all right, but making the baby to receive antibiotics for quite a long time, staying in the hospital, all those things, how you will justify as obstetrician?
I think you have to have a very strict word with your pediatric and neonatal colleagues, yeah, and have again a combined protocol, mutually agreed upon protocol, because it is important, as you very rightly said, we feel churned to see these babies because we hesitate to give one dose of antibiotics prior to delivery. And we see them receiving multiple doses of antibiotics, which really upsets us. So I think at the drop of the hat, antibiotics should not be administered to the neonates. Just because it's a prolonged rupture of membranes, I don't think, or pre-labor rupture of membranes, etc. I don't think they should be administering antibiotics. There should be strict criteria for administering antibiotics. So
maybe
that's
this is the time where we
have to insist upon. Yeah, and also that is where the perinatal meetings go a long way in discussing the protocols and also exchanging our views and deciding on uniformity.
Okay, thank you. So is rimming of perineum is useful during second stage of labor?
Rimming, I think you mean by stretching the perineum.
Yeah, stretching the perineum. Routinely they do it.
See, what evidence and whatever studies have been shown have shown that if you want, you can do massage of the perineum. That can, to a certain extent, help to decrease the perineal test. But as such, stretching can be very painful. May not have a very remarkable effect in whatever you're trying to do. So I am not too sure that rimming is going to be a very useful technique.
And also it can sometimes become quite edematous also, or quite friable also with rimming. And you can have the oozing from the perineum, which can be difficult to sort of suture. So I'm not for Rimi.
So in the second, Dr. Prakriti,
Sir.
if there is a bradycardia in the second stage of labor, so is that an indication that fetus is in a harmful condition?
Some kind of variable or early decelerations are common in second stage because of the head compression, prolonged pushing, and some loss of contacts when she's pushing in the CTG. But bradycardia, definitely we should be careful if it's more than 3 minutes. And if we are able to deliver the fetus at that moment, we have to go it.
One word of caution, sometimes you might be picking up maternal heartbeat. Yeah, because we have to be sure that it is fetal. And if there is significant bradycardia, it is better to get on and deliver.
Yes, yeah.
So what is the role of scalp page tester or even a transcervical intrauterine pressure catheter?
Scalp pH testing is sort of very much propagated in UK. Even US do not do much of a scalp pH testing. I mean, we have done it whenever we have doubts about the CTG, when it is an abnormal CTG, and especially if she's not in a deliverable condition, we do scalp pH testing. But doing it in second stage has got its problems. So we would rather be very careful if you're going to do it in second stage. But unfortunately, scalp pH testing in India, in Indian setting, we have not been able to do it much because of the, sort of the capillary tube adaptation and all which we need to be doing. But even in UK, there is lots of controversy. We be continuing with scalp pH testing. Can we move on to something better? So that is when the ST analysis came into play. So scalp pH testing has a very limited role in women who have had abnormal CTG, wherein you are in a dilemma whether to continue with labor or not. But if you're able to understand the physiology of the normal labor process, physiology of what is happening in that particular patient in our CTG, to a great extent, we have been able to give vaginal deliveries or prolong the labor even without recourse to scalp pH testing. So I think it's important to understand the pathophysiology behind the trace, which is more important.
What about intrauterine pressure catheter? Is it being used anywhere, madam?
The intrauterine pressure catheter is more an US thingy. I mean, even in UK, we do not follow, we have not used intrauterine pressure catheters. So basically in US, they use it for monitoring the intensity of the contractions because it is going to give you an accurate Montevideo unit in terms of the actual, amount of pressure within the uterus. They do recommend it in US and they try to monitor how much of contractions, what is the strength of the contractions, because they say at least 200 Montevideo units should have been, sort of recorded for it to say it is an adequate contraction. But practically, we have not used it in UK. It is more a US kind of, setting wherein they use IUDCs.
So tocodynamic is fair enough for the intrauterine pressure.
I don't think it has much place. Actually, it's quite invasive. It might not record properly also. There are lots of drawbacks with this catheter. And whenever you want to augment a lady with oxytocin with a VBAC, when you're giving her a trial of vaginal delivery, with the previous section, then probably there is a place. That was the only indication where we were using when we had to augment her for whatever reason. So, so that was the only place. Otherwise, routinely it doesn't have any place.
Tocodynamic is fair enough for the intrauterine pressure monitor, madam?
No, TOCO, unfortunately, doesn't reliably give you the pressure. It gives the frequency of contractions more reliably, but not the pressure. Not the pressure. It's very, I mean, actually there are lots of variables which can affect the, what can I say, the TOCO tracings. So I don't think we should rely on TOCO for pressure.
Thank you, madam. So is episiotomy indicated routinely?
Not really. Not really. Yeah.
Dr.
Not
Pradeep?
really. Depends on assessment of your obstetric assessment of the perineal body.
Dr. Pradeep, what is your take?
It's right. Depending on the parity, gravity status. The madam told no assessment of the perineum rigidity and all. You can take a decision.
So routinely it is not advocated.
Routinely it's not advocated.
Prasanna sir?
Actually, I have worked in a unit which the professor, unit chief was totally against episiotomy for normal labor. The other two units used to criticize, and also the residents used to be very critical of it, because the second stage used to appear, it appeared to take a long time. And also people will be itching in their hands to give the episiotomy. So that is one thing. Evidence about, but because the UK and the US and all, they said that studies showed a lot of perineal sphincter disorders and other things, perineal floor problems, etc. I actually worked for a whole year in a unit which actively desisted from giving episiotomy. Sir was Dr. Matthews Mathai, to be exact. I remember him. So, but it was very, very difficult. It is not easy to practice, I'm telling you.
Does it increase chances of perineal tear, sir?
Yeah. Perineal tears weren't that much. Perineal tears used to happen for some other reason, big babies or something like that.
Okay.
But the time, it used to seem to go on for second stage. So that is one of the things, and people used to instinctively go for the episiotomy scissors, and it was very difficult, I must say. But routine episiotomy is not indicated according to most modern obstetrics literature.
Okay. Does squatting during bearing down help in the delivery?
I have no idea.
We don't have much experience with squatting during bearing down. I think you need special training to deliver a lady who is really
don't have the
squatting.
culture of midwife-led units, obstetric
That's
units like in the UK.
Yeah. Africa, I think it's very common. Squatting is very common in Africa. But
squatting stools, birthing stools, and separate things which we can use. But as Prasanna sir said, midwives do follow that, but we do not have any great experience personally. We see them squatting, and then when we are called in, immediately put them on the bed, because that's where we are more comfortable.
Yeah.
As one WHO manual of labor progress is there, madam. The recent WHO manual of labor progress.
Yes.
They were suggesting squatting increases chances of normal delivery.
Yeah, it could be. It could be so, because upright positions can.
I think we should lead the way. Actually, those of us who are working in teaching institutions should lead the way, conduct a study or do something.
Sure.
There's no other way.
Yeah.
So alternately, should we give advise squatting exercises?
Again, is part of your earlier question. So we are unable to answer this satisfactorily.
Yeah, squatting exercises are important because it pushes the head into the pelvis. Okay, so that is what we have found with some yogic postures also. It pushes the head into the pelvis. So same thing with squatting also. It's likely to do, because it's going to alter the pelvic dimensions and allow the head to get in.
The second stage of labor is prolonged. So when do you think that we should go for instrumental delivery, sir?
Is that for me?
Yeah, Prasanna, sir.
Okay. I think the standard indications for instrumental delivery should apply. I mean, if you find there is fetal distress and the second stage is really prolonged, I would stick with the standard indications.
Okay, so there is nothing like, even if the second stage is just gets prolonged, like 1 hour, 2 hours, up to 2 hours, we can wait in second stage of labor.
Active
2 hours of pushing.
2 hours
pushing.
of active pushing. Okay.
In an hour from multiple. But it should not be, indication should not be obstetrician's exhaustion.
Yes.
That is the only thing. I think we have to sort of keep our hands out and also our body out of the labor room, you know. So it is very tempting to sort of do something if we are in the labor ward to expedite delivery, but I think we should just keep away from the labor ward unless it's very much required or the lady is about to deliver. We shouldn't.
Okay. What is the preferred instrumental delivery, madam? Whether ventus or forceps, which is preferred?
Depends on how one is, what one is comfortable with, but it depends on the position and also if it needs rotation and if you are unable to manually rotate it, obviously ventus or Keelan's if you are, if you can manage, but ventus if it is a rotational delivery that you're wanting to do. If the caput is very large, then you don't want to really use ventus because the chance of failure is high. If you are unable to decipher the position properly, but if you think that you definitely can achieve a vaginal delivery, probably ventus would be safer. Forceps, you need proper determination of the position of the fetal head. That's very, very important. So it depends on what you're comfortable with and on the individual situation.
Depends upon the indication. Say, for example, if it's a prolonged second stage, and as ma'am was saying, there is excessive caput, and she's got a dense epidural, she's not actively pushing, maternal pushing is not very adequate, then you might have to go and do a forceps, because if you're going to do a ventus in such conditions, you are more likely to fail and end up with a sequential instrument. Whereas if it's a straightforward fetal distress, the head is descending very well, mother is pushing well, she doesn't have a dense epidural, then maybe it would be easier with the ventus. So I think it depends upon, as ma'am said, the individual case scenario, and of course the experience and the comfort of the operator to some extent.
And also availability of proper equipments.
Okay, madam. Like how many?
Sometimes all of a sudden you find that the ventus machine is not working properly and things like that.
Go for forceps. How many pulls is allowed in a to call it as a fail?
Fail. If it is not this, usually traditionally it says 3 pulls, but if it is just not descending with even 1 good pull, I would be very worried. Okay.
I think it is a
So,
continuous assessment of it is.
Yeah.
If you have
And
applied
we
the
want to
vaccine
reassess.
twice, and you don't do it again. So it's as simple as that. And 3, it should be out.
Okay.
So that is a standard, number of attempts which are mentioned in most literature.
Dr. Pradeep, what is your
You have to
take?
be absolutely sure all the criteria for the particular instrument is met. Otherwise, you should be worried even much before you assemble your instruments.
Yeah, my attitude is little reluctance toward operative delivery once I landed in Bangalore, because I know that irrespective of your expertise, there is definitely some complications are there compared to the non-operative delivery. So 100% you should look into the indication. If it is a really indication is there, fulfilling all the criteria, try for one whichever you have expertise. Otherwise, I feel at my level, at my personal level, little reluctance about going for operative vaginal delivery. As a teacher.
So should we do nasal suctioning after the delivery of the head in all the cases?
No.
No.
Let the baby sneeze.
Nasal sectioning is not recommended because you would rather cause more trauma and more problems. So unless there is an actual obstruction, you don't need to be suctioning.
No need to do
Nasal or oral, both. Actually, if you are touching the posterior wall of the pharynx, it can cause apnea, bradycardia.
Okay, so this patient delivered a male baby at 3.7 kg with the right middle lateral
Wow. Very nice.
20 minutes after the full
Very
dilatation
nice.
surgery.
Congratulations. Good, great.
So now early or delayed cord clamping, what do you prefer, madam?
Delayed cord clamping.
Delayed cord clamping, unless there is a maternal or fetal urgency or worry that you'll have to clamp it. Otherwise, you go for delayed cord clamping, especially in term vigorous babies.
Absolutely. And also, one word again of caution. Many people are opting for cord blood banking. So we should not clamp it early for the sake of cord blood banking, because we will be jeopardizing the fetus, I mean the baby, of at least 50 ml of blood, autologous blood transfusion, you know. So I don't think we should be, doing that. I mean, worrying about collecting the cord blood and clamping it early. You can clamp, delayed cord clamping, and then you can collect. But
sometimes
not
the
the other way around.
pulsation lasts even more than 6 minutes. So what to do in that case, madam?
So usually the recommendation is 1 to 2 minutes.
Only 1 minute, 1 to 2 minutes. That's all.
1 minute.
Matter.
So how long we can wait for the signs of placental separation after the delivery of the baby?
I mean, I would say probably if there is not much of bleeding, 30 minutes.
It depends upon whether you have done active management or passive management. I don't think we do passive management here, but generally you can used to give passive management. So then, you know, after 30 minutes, you would then move them on to active management. But if you've already done active management, as ma'am said, 30 minutes. Provided mother is stable, she's not bleeding, and you know, observations are satisfactory.
Suppose if it is delayed, so should we go for intraumbilical oxytocin injection? Is it helpful?
I mean,
well,
we
it is
used to,
debatable.
routinely do it if there is any, you know, sort of delay in the separation of the placenta. We used to do 10 units of oxytocin, 10 ml of normal saline injected with proximal clamping. It did help us, but studies have not shown a great benefit in them preventing any problems.
Yeah, somehow I haven't found much benefit here.
So some people even letting down the cord blood to pass itself, means without pushing the clamp to the maternal side. That also they practice, and they're, according to the senior gynecologist, some are telling it is beneficial in the placental separation and in the reduction of blood loss.
In fact, when you have collected the cord blood for cord blood banking, most of the time the placenta separates out quite well and within a short interval. I have hardly come across any manual removal of placenta or anything like that when we have collected cord blood sample for cord blood banking.
Thank you. So in PPH following a normal delivery, so when do you decide that this medical management is enough, we should go for surgical management?
Very difficult decision, actually. I think it's very important to make sure that you have done all the, I mean, used all the medications to the maximum, and also you have tried tamponade, you have corrected her DIC if she is going into DIC. In spite of all this, if she is still, if it is still not coming under control, then probably you will have to go for surgical management, particularly to exclude trauma. I mean, an examination under anesthesia is very important. And then we'll have to decide whether it is just, if we are able to sort of take care of all these, I mean, if we have medically managed her well, if we have corrected the DIC component, if we have tried tamponade, decision to go for surgical management very rarely arises.
Means should we will not waste significant amount of time in the medical management.
No.
Even surgical management also should not fail. Like
That's right. Yeah. Yes. Golden hour should not be lost.
Most of the studies have been told that there is a blood loss is more after misoprostol 50 microgram and incidence of, we have, I think in the Bangalore Medical College, the first study what we have done in Bowring Hospital in 2000 with the 50 microgram, that has been clearly indicated that the blood loss is more and the vaginal tests, cervical tests are relatively more compared to the other methods of induction. So in this scenario, you have to be mentally, you have to be ready. I mean, you have to be ready with because your response should be fast. So I think putting a time limit is not a right idea. I think you have to assess individually and you have to respond.
No, it is not about a time limit. What and all should have been done to tell that now it is enough, we should go for surgery.
See, you have exhausted all your medical treatment and you have tried to correct the DIC. In spite of that, she has gone into a vicious cycle where you want to remove the uterus. That is the indication.
It is not stable in spite of exhausting
And
all
also,
the...
you want to exclude trauma. So many times there can be atony plus trauma. Trauma can be missed. I have come across that quite a few times. So we have to keep trauma in mind and then examine them under anesthesia. And then probably if you have gone into a vicious cycle, if there is no trauma, if you're still in the vicious cycle, you're caught in the whirlpool, then you have to take it as the last resort, but not a late resort.
Earlier the better, yeah.
No, one thing is an unofficial statement. In this era of a strong uterotonics in our hand, the most of the time, unless ruled out, it is a traumatic rather than atonic, because we have so many drugs in our hand. So the response also will be little earlier, taking into consideration. That's what my feeling.
Thank you for that. So with this, we'll take up the next case. That is pre-labor rupture of membrane, which popularly call it as premature rupture of membrane. So she was a primigravida, 39 weeks, 2 days gestation. She came with history of PV leaking since 1 hour. She was pursuing the fetal movements well. There was no history of pain or PV bleeding. For abdomen examination showed left occipital lateral position. First speculum leaking was present, it was clear liquor. And PV examination showed Bishop score of 6. Now she is a primigravida, 39 weeks, 2 days, cephalic presentation with pre-labor rupture of membrane. Her ultrasonography showed single life intrauterine pregnancy of 38 to 39 weeks gestation. Estimated fetal weight 3.2 kg and AFI was 8. NST is reactive. So should we wait for spontaneous onset of labor or should we induce us right away? What is your opinion, madam?
See, basically, both of them are fine. Conservative, expected management, or active labor. I mean, in fact, I know the term prompt trial which was done, which showed if you're going to be waiting, there is a slightly increased risk of infection. That is what we are worried about. But if you look at various guidelines, they say we can give them a short period. But unfortunately, none of them have come up with a clear recommendation as to how short is short or how long is too long. But in our unit, we tend to give them 12 to 24 hours because many of them do go into spontaneous labor by then. Provided the maternal and the fetal conditions are satisfactory, it is important that we closely monitor them because we need to be careful that they do not get into infection. But if everything is satisfactory, we can give them a short period of expectant management.
Short means how short, madam?
That is the question because none of them have come with a clear recommendation. But generally 12, some have said 12, but up to 24 hours, they are pretty all right. Beyond that, I think we would be a bit worried.
Prasanna, sir?
Yeah, now the spontaneous, earlier we used to really give a time limit of 24 hours, but many studies, I mean, including the initial studies, they gave options like you can directly straight away induction with oxytocin would also, there were many studies. Like early induction is better in case of rupture of membranes. And maximum you can wait is 24 hours.
Yes, madam.
I have a different method. I always tell, when she comes to go for a Leica assessment, again, if the Leica is quite good, irrespective of leaking, my waiting period, it increases. If Leica is already borderline or coming less than 5, my waiting period decreases, irrespective of infection risk. That I will take into the account, the Liker volume.
Yes, madam, Lata madam, what is your opinion, madam?
Usually we tend to wait. We definitely restrict the number of vaginal examinations. We actually don't even assess them. Actually, when they come with ruptured membranes, if CTG is all right, etc., we just confirm with a perspeculum examination whether it's a true rupture of membranes or not. And then we avoid digital examination of the cervix. So to reduce the chance of infection, we leave them alone usually for 12 to 24 hours. I mean, without, just before the induction process, we examine them and then decide on the method of induction.
Okay, it means 12 to 24 hours wait is good.
Yeah,
But
we do wait.
What happens
we do
is
wait.
usually people, yeah, sorry. In practice, what happens is people do wait for 6 to 8 hours and then start induction. It is only the mothers mothers or relatives who would be anxious that their labor should be expedited. So
proper counseling of the woman and her relatives is very important. They think once the Liker has drained, the baby is going to get distressed. It is not, I mean, we have to say that it is not fish out of water. It's not like fish out of water, you know. So we have to explain to them and ask them to wait. Many of them set into labor by 12 to 24 hours. And
but usually they'll go to other doctors and discuss and come, madam. Like
that's the problem. I mean, all of us should be talking evidence-based medicine. It's not just the experience-based medicine, but experience is important, there's no doubt. But we can say, look, evidence says this, probably she is trying to do that for you and there's nothing wrong. Okay, if you have trusted her to be with her for so many, or with him or with her for so many months, I think you should respect. That should be the colleagues' what can I say, reassuring words.
Okay, thank you.
And professionalism.
So should we use prophylactic antibiotic in a pre-labor rupture of membrane, madam?
There is no evidence, but unfortunately we do use, because like you said,
yes, ma'am,
that you felt that the infection rates were higher if we did not use, if you did not use antibiotics with induction. Similarly, we felt that with pre-labor rupture of membranes, we started using antibiotics because I felt that the rate of infection was more.
What is
institutions practice what they preach actually? Many hospital infection committees ask our opinion, like whether do the protocols, but practice after few months it will be back to again
square one.
And prophylactic antibiotic is given. I do agree with that. Yeah. That is what
Pediatric counterpart usually questions how many hours of leaking. They take their own decision about the starting antibiotic to the neonate according to the hours of leaking. They don't ask us, have you started antibiotic or not? They will take according to them. That is
as madam rightly suggested, you should have a perinatal meeting. So we should discuss with both the department and then take a decision.
They may be taking according to their guidelines. They are not taking individually.
That's what.
According to the IAP, they have recommended. According to the duration of leaking, you have to take a decision. That they may be following. It's not individual hospital policy.
We should have hospital audits and discuss it with neonatal colleagues and then come to a decision.
Okay. So what is the antibiotic preferred, madam? What is the antibiotic routinely preferred?
We usually use cephalosporins.
Cephalosporins. Sir?
Second generation cephalosporins.
We give cefotaxime or ceftriaxone.
Oral.
Okay. Srimati, madam?
Yeah, we use oral antibiotics. We use Taxim and cefotaxime. So we don't want a very broad spectrum, but at the same time, we need something which should have a fairly, sort of good effect on the microorganisms which you're planning to target. And again, I think here again, institutional protocols are important because you need to look at what your particular, hospital is growing, and based upon that, you might have to take up the antibiotics.
Thank you. So if mechanism stand Laker is seen, is it an indication for abdominal delivery?
There is an indication for induction, but not for abdominal delivery. I mean,
Induction or
some
augmentation,
argue
whatever you want to call.
in meconium stent, sometimes they say you don't even have to augment them. We can even wait because it's almost, as good as clear liquor. But we tend to be a bit worried if we see meconium. It is definitely, probably an indication for direct augmentation rather than an expectant management, but not for abdominal delivery.
Dr. Prakruti?
Yes, sir.
Yeah, in these conditions, can antenatal monitoring will help?
Yeah, we have to keep them on a continuous monitor. If they come in latent labor, inducing with oxytocin would be better choice compared to misoprostol, because to have a controlled contractions, and continuous monitoring is important because to detect any aspiration is less chance, but we have to be careful.
So after 8 hours, she went in labor. So what is the preferred method of induction of labor, or maybe augmentation of labor in this patient? Like after 8 hours, she started having slow uterine contractions, but that was not enough to go in labor. Should we, what is the preferred method of augmentation of labor or induction of labor in this case?
It depends upon the vaginal assessment. If you think she is favorable, then you might be able to just do syntocinon. So, because it said station -1, what about the cervical dilatation, effacement? It depends upon all those.
Yeah, Bishop score is around 6 only, madam. In this patient also, it was around 6.
So we can then still give misoprostol, PGE1, PGE2, all of them are fine. Only, worry is that if you're going to do mechanical dilatation, I would probably not be very comfortable with the ruptured membranes. But otherwise, prostaglandins can be safely given. Vaginal, I would again be a bit careful because it may not work properly. It can get washed out, and the amount of absorption can be very variable. So we tend to give them oral misoprostol. But again, vaginal prostaglandins can still be safely given.
Okay, sometime 4 to 6 hours, oxytocin works quite well, because plain oxytocin as well. And many people in and around our place are comfortable with oral misoprostol if the cervix is unfavorable.
Okay. So can
it depends on your preference.
Advise them ambulation in the first stage of labor because membrane is ruptured? Is a worry about cord prolapse?
If the head is engaged, then I don't think we need to be worried about cord prolapse.
Okay.
They should ambulate, in fact.
Okay. After 14 hours from the time of admission, she delivered a male baby, 3 kg, with right medial lateral episiotomy. Suppose antibiotic was started before the delivery. Should we continue after the delivery?
Again, there's not much evidence to say if she didn't have any chorioamnionitis, but we tend to give them one more dose because sometimes if they have developed intrapartum fever or tachycardia, but there's not much evidence to support that practice. But I think
no, if there is intrapartum fever, yes, yeah.
But otherwise,
there is one entity called subclinical endometritis. Sorry, Ravi. Can you please repeat the question?
Yeah, so she delivered, sir. Premature rupture of membrane was there.
Yeah.
Was given antibiotic before the delivery. Should we continue the antibiotic after the delivery?
Well, I'm not too sure about it. What we have started antibiotic for. Yeah, we should continue antibiotics. Yes.
How long we continue, sir? How many?
Might as well continue it. Yeah.
How many days you should continue after delivery?
Yeah, I would continue it for say 5 days, 5 to 7 days, I think.
Dr. Pradeep, you are telling something?
Yeah. There's something called subclinical endometritis that has been proved. It's more in the PROM that can lead to delayed involution and related complication. I think there is the science behind it. In continuing the antibiotic, the days, I think, according to which antibiotic you started. If you have started cephalosporins, commonly usually we give up to 5 days, but we will switch over to oral therapy rather than injectable. That's the practice what we do in our setup.
Okay, if there are signs of infection, it should be continued for 5 more days after the delivery.
not 5 more days. It's a total 5 days duration we continue because we keep the patient almost 2 to 3 days in the hospital, and another 2 days we will tell them to take it home actually, oral tablets. That's what we practice.
So now a case of IUGR and oligohydramnia.
Sorry, if I may interrupt.
Yes, madam.
Yeah, I have to leave by 4 o'clock if that is okay. I have got some other engagement. Sorry about that.
I think we're already
3:52.
Yeah, I see that. It's getting delayed. First case is too long actually.
No, another 2 cases very short it is. Yes, madam. I'll try to finish it as early as possible.
Yeah, you come to the management part and we'll decide. I think it's better.
Yeah. Gravida 3, para 1, living 1, A1 with 31 weeks, 5 days. She was a known of Apla's antipostulant antibody syndrome treated in the previous pregnancy. So now her scanning showed single live iterative pregnancy at 28-week gestation and AFI is 6 weeks. She is already on ecosplenide in enoxaparin from the first trimester itself. Now her weight is, baby weight is 1.3 kg. It's a lag up by 4 weeks.
Doppler.
Yeah, I'm telling you. Okay. So what is specific treatment for oligohydramnia itself?
There's no specific treatment as such.
Hydration sometimes helps. It is all empirical. You can bed rest, hydration, left lateral position, and so on. But hydration, there are studies. It does help. Taking 1 to 2 liters of oral hydration actually improves to a certain extent. But that's it.
Otherwise,
I mean, quite a few studies, I would agree with Dr. Prasanna. Quite a few studies which have shown, especially the is dehydrated or in summer, giving them oral hydration, but not for IV hydration, not those IV, drips and everything. There's only oral fluids. Apart from that, none of these antioxidants, arginins, your sildenafil, none of
or
the
amino acids and things like that.
Yeah, her Doppler findings were normal. Pelvic artery, middle cerebral artery, and uterine artery Doppler were normal. So what are the chances that fetus may be having a distress in spite of normal Doppler findings? Dr. Prakriti?
Coming to in labor, in case if there is oligohydramnias because of cord compression, even though despite the Dopplers are normal, because of cord compression, they can have CTG problems. Or if the expected fetal weight is less than 3rd centile, Dopplers being normal, then also the baby may not have reserves to take the stress of labor. So
no,
that
patient is
can
not
be
in labor. She's just antenatal. She's not in labor.
Unlikely.
With a normal
very unlikely. If the Dopplers are normal, we can, reassurance cannot be given 100%, at least for the next 1 week to probably 2 weeks. It should be okay.
And
NST.
Repeat Doppler.
Yeah, our Doppler findings and NST both are normal, but so do we anticipate a fetal distress when the patient doesn't go in labor?
No, we won't.
Any acute incident like abruption, such things we cannot. Yeah.
Why was she on enoxaparin? Was the Apla?
She was a case of Apla.
I was going to ask that question, sir, but I thought it's a labor conference. Let's stick to it. We're already running short of time. But I agree very much with Prasanna, sir. I don't think there was an indication for enoxaparin for her.
Yeah.
So what is the role of intraamniotic saline infusion in this case if they go in labor?
Being proposed for oligohydramnios or when there is thick meconium. I mean, I have used it in my postgraduate days, but after that I have not used it. Americans do propose it, but we have not used it practically, but it is supposed to be beneficial if you have variable decelerations in the setting of decreased Likert, or if you have thick meconium, then maybe you can dilute the meconium, but we have not used it very much practically. I mean, that would be
when I was a senior resident, maybe 12-15 years back in Vellore, they used to do it for meconium stained and things like that to improve visibility for scans, etc. But off late, I have not seen. Studies
No, no, it is been cleared now. There is no indication until unless to dilute the meconium to reduce the neonatal morbidity. There is no
That's
such
right.
things happening
E-
anywhere, I feel.
Yeah,
Those are
even
American
there,
support it to a certain extent, but I don't know how much practically they are using it. But if you look at the American guidelines, they do mention about it.
even there, I don't think there is much difference in the outcome, even with meconium or cord compression, etc.
So we are going to the next case because of paucity of the time. She is a case of Gravida 2, para 1, 38 week, 3 days with the previous LSCS. She came in pain abdomen since 1 day and leaking PV since 1 day. PV examination shows that Bishop score is 10. The good Bishop score is there. And she is having a adequate pelvis. So should we go for VBAC or LSCS?
So I think it depends upon what is the reason for a previous section and what kind of a cesarean section which she had, whether there's any contraindication for a VBAC. But generally, if it was a low transverse section before and for a an indication like failure to progress and it is not a recurrent indication, she would be a good candidate for vaginal delivery.
Previous indication was failure to progress of labor, madam.
Yeah,
Then
at
I would
what
definitely-
dilatation?
Maybe she has not gone in labor only.
Then it
Yeah,
is
then I don't think we should worry about it. I think she has got very good bishops. I think we should just leave her alone. We don't have to augment her. We just await events.
probably
Can we assess the integrity of the scar?
start calling it as a TOLAC. So you are psychologically or prepared. Trial of labor after.
Yeah.
The trial for the obstetrician as well.
Yeah.
Challenge. Yeah. I think all the prerequisites for safety precautions have to be met with when we are doing TOLAC. Yeah. Theater should be ready, your staff should be ready, continuous monitoring should be there, anesthetist should be available on site, and you should have senior help if there is a problem. All these have to be met.
I will ask always a patient blood group also. I will always inquire patient blood group.
Very much. Sorry. Yes. Yeah. Very much. And also you should reserve also if
Suppose the Bishop score is poor, can we go for Foley's method of induction in those patients, madam? If the Bishop score is poor.
Yeah. Yes.
And not in
I don't know
labor.
whether there's an indication for induction for her now, but if you have to induce, we can use Foley's.
Yes.
Yeah.
So can we use sonogram to identify the integrity of the scar? Will it assess the
unreliable?
It can be used. Studies have shown that it is less than 2 millimeter, which is a 10.
Yeah.
You don't do it practically.
It's very difficult to assess the scar. Okay. And also what is there just beneath that? I mean, if there is head, obviously it will be stretched. So it can look as if it is less than 2 millimeters. So integrity of the scar cannot be very reliably detected.
So what is the optimum duration of progress of labor in previous LS is same like a without scar, or it should be a little more vigilant, madam?
We have to be vigilant, definitely, but we can give it adequate time. Because she's got into paper on home, and I'm sure she's going to be progressing. I mean, we have to be vigilant though, because rupture can happen anytime, but doesn't mean that we should not give her an adequate trial.
The consent for emergency cesarean section would have been taken in the beginning. I mean, when we start that trial itself.
That's right.
Yes, sir. So can we go for epidural analgesia in case?
There should be a special consent for VBAC, actually, where all the things are explained, dehiscence, rupture, and its complications, etc., etc. I have had, personally, I have had a medical legal problem where the consent was not taken adequately. And so the court repeatedly asked, why haven't I taken a special consent if there was such a high risk to the fetus or the mother?
Okay.
Yeah.
So after 1 hour, she went in active phase of labor. So should we apply ventouse or forceps in the second stage of labor for previous LSCS?
Not routinely. Not routinely. Not routinely.
You can easily apply.
Probably the active second stage.
Yeah.
Sorry, the active second
difficult
stage.
instruments should be avoided.
Yeah.
To cut short second stage of labor.
No, not really.
cut short.
Active second stage should not be very prolonged.
Just to cut short,
Not
you are
more
telling?
than an hour.
Yeah, just to cut
Not
short.
more than an
That's
hour,
exactly.
usually.
No, we should adopt. We should not adopt such things, and I think it's not doesn't have any scientific basis.
So after 20 minutes, she delivered a female baby 2.8 kg with vacuum assisted delivery. So is routine exploration of scar recommended after the delivery?
Not routinely.
No.
Only if she is bleeding and you suspect scar dehiscence.
So if any retained placenta happens in previous lysis
We need
patients.
to be very careful. She's in this section of the retained placenta, whether there is any possibility of an adherent placenta is something which we need to be thinking in terms. Because
Yes,
of the previous section and
previous
if you're going
illness, yes.
The
that is
role
something.
of imaging as well. Only in previous maybe couple of cesareans, the role of imaging rather than intrapartum, it is antenatal rather to see PAS, placenta accreta spectrum and all that.
It's a low lying and anterior placenta if it is there.
But in the clinical experience, do you all agree that is delayed? Placental separation is delayed in the previous when you give the feedback. Do you agree or not? In the clinical experience, honestly, you all tell. Little delayed or not? The placental separation and expulsion is delayed when you, I mean, compared to the non-CS lady. Is it, I mean, practical experience I'm asking.
I haven't found that. I haven't really thought about it, but I haven't found any problems so far. I mean, I haven't had much problems. Obviously, if there have been,
I'm thinking about in future because we haven't come across, but maybe we can watch for it later
Just
because we
keep a
haven't
watch.
had.
I think from today, you just keep a watch and what's happening. When you
No, of late,
Yeah,
I
yeah,
haven't had that many
it would be
feedbacks,
interesting.
to be honest with you.
Sorry, with manual removal of placenta, please turn the palm away from the scar. That's one of the things.
Okay, ma'am. Okay, point taken. So how safe is to go for TOLAC after VBAC?
Definitely. I mean, the same precautions for a repeat TOLAC as well. But her chances of success is very high because she has had a successful VBAC already or a successful TOLAC already. But the same precautions should be carried on for every TOLAC.
This is a patient, gravida 2, living one with 38 gestation, breech presentation with adequate pelvis, but she is not in labor. Her ultrasound showed single live intrauterine pregnancy of 37 weeks, breech presentation, 2.9 kg fetal weight.
Yeah.
Should we go for ECV or elective LSCS in this case?
If there are no contraindications for ECV, yes. We should.
Okay.
If we are really talking in Labour Congress, we better.
ECV should be offered to all breech women wherever it is. At least it should be documented that you have offered her.
Yeah.
Yes, yes. What gestation do you offer, sir, usually?
36 weeks onwards. Yeah.
36 weeks onwards.
36, 37 weeks.
What percentage do you find it is ECV successful, like in your experience?
About 50 to 60% maybe, and it is less in primaries, and if I remember, 65% in multis in some studies. Yeah.
Okay.
In primaries, it is not very successful.
I feel that it is most successful in flexed breeches. Yeah.
Okay.
Not in foot sling and yeah. Extended breech also sometimes it can be quite difficult in nullips.
Any breech score is useful to go for a vaginal delivery or abdominal delivery?
This has been proposed in the past, but I think this sort of all your practical experience, because you'll be looking at a parity, you'll be looking at what kind of a breech it is, you'll be looking at the fetal weight, and that is what we are practically doing it. So we may not be using a score. I mean, there are various scores which have been proposed for various things. How practical it is very difficult. But basically, whatever is part of the score would anyway be looked at, which is the parity, the gestational age, the cervical dilatation, the weight of the baby. All of these things are factors in deciding about vaginal breech.
Actually, to tell you the truth, when I was researching for this one only, I found out that this score was quite old. it is probably in the 60s or 70s.
Yeah, yeah.
All these are pre-TBT trial era. Now I think earlier when people were actively delivering breaches, they were following it.
Yes, yes.
We've delivered
Any recent such scores are available, sir? Any recent such scores are available?
No. Now after our Dr. Virendra Kumar's talk is still fresh in our memory. So after it is like a totally different scenario now.
Yes,
so now it's about the thing practice has drastically changed when it comes for primary breach. Yeah. Yeah.
So no role of induction of labor in these patients for breach?
Again, no. It's a long time since I saw an induction of labor for breach because.
Okay. To conduct a breech delivery, what are the points should be kept in our mind? Assisted breech delivery, if we are to do.
Yeah, well, you should revise in your mind whatever you have read in the papers and hope for the best, and have a good neonatologist at hand, and have a good assistant, and explain the risks. When this usually happens when people come in advanced labor halfway through
yes,
already in second stage, and you have no other choice other than to expedite or complete the delivery. So you should never pull whatever is given in the book. Follow it to the letter and spirit, and don't pull, don't push, don't allow her to, don't no premature bearing down till she comes. The umbilicus level is delivered, no intervention. Put the cord apart, cover the baby, keep the back anterior, and the same thing, suprapubic pressure. And if you have a Piper's forceps, which I doubt in many labor rooms it is not available now. I have used it long back, but in my labor room, honestly, it is not there now. But outlet forceps, I'm not sure. I'm not too sure whether it can be used. But it is
outlet forceps will be too short.
Too short.
Okay.
Too short.
So too short. And, you have to use a long-bladed forceps. Sometimes clearance would help because not for rotation, because it doesn't have a pelvic curvature.
Yeah, correct. Sure. The first and foremost thing I told, try not to panic. Try not to panic.
Yeah.
Okay. So
one I suggest always, I always tell, you should discourage the unscientific bearing down. Especially when you are delivering a baby, you should have a lot of patience. You should allow the fetus to rotate and to deliver on its own. That's the one thing we have to keep in the mind. So you should not make them to bear down to deliver a little faster, pulling, pushing, all things to be avoided. It to be vigilance, what's happening, to intervene when it is required.
Okay. Which method is preferred for after coming in, delivery of after coming in? Which method is preferred?
If forceps is available, forceps, yes. But otherwise, normally Burns Marshall would usually will do. But if
Burns Marshall, actually there is, because of the hyperextension of the head, problem with Atlanta occipital joint subluxation, etc., subluxation, I think Maurice's Melliviate would still be the choice. Yeah. Next to forceps. I mean, forceps, sometimes it can be difficult. It depends on whether you have a good assistant to hold it up, and you have to apply it below the, go below the trunk and then just apply it onto the sides of the head. So it depends on what sort of assistance you have. As somebody said, it is important to have good assistance and also anesthetist handy, please. So, and also if the breech is taking time to climb the perineum, probably it is better she is delivered in theater. Sometimes they might just get stuck even at +2, and I don't think we should be pulling or pushing. The breech has to climb the perineum. Then only the nature is saying that yes, this baby can come through vaginally.
So can we use outlet forceps for the routine outlet forceps?
Not ideal. As I said, it can be very short.
Okay.
Yeah.
So she delivered by cesarean section. So 4 questions are rapid fire round. So is enema routinely recommended in all induction of labor?
No.
So absolutely no. So what is the role of perineal preparation before induction of labor?
No. No.
No.
Because it will increase the risk of infection.
Okay. So what is the role of fundal pressure during second stage of labor?
Not recommended.
Not recommended, but practice very often with some very, very disastrous complications.
Apparently, it can give rise to post-traumatic stress disorder in women.
No. Fundal
And
pressure.
also a lot of abdominal pain. You will start wondering what is the pain due to.
If at all you want to give fundal pressure, you choose obstetrician rather than anesthesia stuff actually. So we are better in giving fundal pressure than anesthetic, especially during cesarean or in the delivery theater. If your husband is a anesthetist or someone else, you are ready something.
Prasanna sir.
So we are always better in giving fundal pressure.
Yeah. Pregnancy following a ART. So is it like a routine case or a special precaution should be taken in those patients?
Well, I mean, it depends on the medical condition because most of the women are elderly. So some or other medical complication or diabetes or hypertension, something will be there.
Okay.
Or they have
morbidity.
ART pregnancies are known to have some pregnancy complications. So it is management depends on the underlying, whatever situation as it arises.
Okay.
Otherwise, what happens is most of them would go for elective. Left to themselves, they would prefer it. It so happens that most of the times maternal request predominates, and then we'll have to comply.
Okay.
Apart from that, no specific.
I think it is important to say that you had problems conceiving, not carrying with the pregnancy and not delivering.
Yeah, absolutely.
Yeah.
So there are many times patients will come with the time of delivery. We want delivery at this time. What do you mean by time of birth?
Nothing wrong. The technique doesn't differ. Nothing wrong. If you are possible to do it.
No, but they want the exact time of birth.
Actually, I leave it to the pediatrician. They usually announce the time.
So there is nothing like that. Okay. Sir, does sacred water, usually they'll use some sacred water, they'll bring from somewhere and they'll think that they will increase the chances of normal delivery. So what about the music therapy or aromatherapy?
The music therapy, aromatherapy is one of the recommendation. I mean, the midwives do use it very frequently, in UK, if you see. Basically, it is to calm the patient and prepare her psyche, that plays a very important role in the progress of labor, her need for pain relief. So we cannot completely discount her and say that it is not helpful, but it can help in terms of preparing the mother mentally and also for the pain relief in labor, which could have then a favorable effect on labor progress.
Music therapy may help.
The basic concept of this is the stress reduction is any stress in any type, including pain, releases lot of adrenaline in the body. Adrenaline is a sympathomimetic. It is a tocolytic. It reduces the effectiveness of contraction. That's why the good analgesia, any stress reducing exercises, anything it could be, reduces the release of adrenaline. So ultimately the tocolytic effect, what we see. So that will be reduced and hastens the delivery. That's the take home message. I think it's a
even sacred water, I think it does the same thing. You gain confidence, you relax a bit, etc.
Maybe placebo.
Yeah. And according to the Shastras, time of birth is when there is Bhumi Sparsha, that is the whole body comes out.
So when we give the pediatrician, when we give the baby to the pediatrician, that's the time, madam?
No, not Bhumi Sparsha is just coming out of the mother's body completely.
Okay, madam. Okay.
And yeah. And
So,
seen as an individual.
We have heard some traditional dye, they're pricking with the incense stick during second stage of when they try to bear down, they'll use incense sticks burning it to touch the patient. So that will increase chance of normal delivery.
I think in these times of medical legal litigation times, better to not to try this kind of things, and people get caught for smaller offenses. So, yeah.
So this
But
comes.
I don't know whether. Yeah.
One more, when we counseling the women for the delivery, and we will advise them, make them to walk. Actually, we have to take little more time. So what type of walking we have to advise them, because most of the time they go for a brisk walking. When the husband is going for a walk for the cardiac benefit, the wife will also move with the same speed. I think many women will come with the back. I think we should tell the brisk walking is not required as per to facilitate the onset of labor. I think always we should insist on them. Otherwise, usually they go for a brisk walking and coming with some problem. That's what I have seen in some of my patients.
So this completes all the questions. Thank you. Thank you for taking so many questions, which you are finding in daily practice.
Thank you.
Thank you.
Thank you. I think all.
Thank you very much.
Yeah, especially
all
madam.
the
I think
participants.
Good evening, everybody. We have now come to the end of our illuminating sessions of the e-conference on National E-Conference on Labor and Birth that was organized by the Department of Obstetrics and Gynecology, KVG Medical College and Hospital, Sulia. I am sure all of you all have enjoyed thoroughly, and we are highly thankful to all the speakers and panelists who have shared with us their vast knowledge and ideas. To begin the valedictory function, I request our chairperson, Dr. Geeta Doppa, to kindly come on the dais. Our beloved Dean, Dr. Nilambikai Natarajan, who has been the idea behind the conference and has been a great support throughout the planning process. Thank you, ma'am. I request our HOD, Dr. Geeta Doppa, to kindly hand her a token of gratitude to our Dean. I request ma'am to say a few words about the conference now.
Good evening, one and all. I appreciate and congratulate the Department of OPG, ably headed by Dr. Geeta. Actually, I just said, why not we have a conference last month? And it has taken fruit a nice way because of her and the team's dedicated, committed work. I hope you all enjoyed the exchange of knowledge these 2 days. We have an excellent speakers giving their experience. I hope all the youngsters would have shared and got anything result fruitful very much. So once again, I thank the Almighty, the founder president, our president KVC sir, and the entire department of OBG for the tireless work and all the supportive staff. Once again, I congratulate and thank everybody.
Thank you so much, ma'am. Request our organizing secretary, Dr. Borkar, to kindly give the vote of thanks.
Good evening, everybody. When the whole nation was suffering from the pandemic, I can say even the world, all the lifestyle, everything has come to a standstill. But there is always a new beginning. As we inspired by our Prime Minister, it's a new world. We have to start beginning. We have to live with Corona. At this juncture, there was a lot of things which were happening where we could not conduct or organize a conference. In such a situation, our department from OBG, from KVG Medical College, Sulia, had came an idea of National E-Conference. Now, today, we have organized it. It came to a good end, and we have done a successful event. On this occasion, it is my duty to thank everybody who has made this event successful. With the remembrance of architect of modern Sulia, late Dr. Venkatramana Gowda, who has created the educational hub in a small town of Dakshina Kannada district, Conducting a national conference was not easy due to the prevailing current pandemic, but it was made possible by our dynamic Medical Director, Dr. K. Vichidananda sir. I thank you very much. I thank all the management of this medical college who are helping us to conduct this conference. I thank Honorable Vice Chancellor of Rajiv Gandhi University, Health Science of Karnataka, Dr. S. Sachidananda sir, who had sent his best wishes for the conference and the souvenir. I thank Director of Medical Education of Karnataka, Dr. Girish, who is sending the best wishes for the conference and the souvenir. Our beloved Dean, Madam Dr. Nilambike Natarajan, who gave the idea of National E-Conference and gave her guidance throughout every step of conducting this conference, even graced us on this occasion. Even today she is with us. Thank you very much, madam. When the speakers who have made free of all their busy schedules, who are the real pillars of success of this great conference, I thank Dr. Muralidhar Pai, Dr. Srimati Raman, Dr. Jayashree Sali, Dr. Aruna Nigam, Dr. Lata Venkatraman, Dr. Sally Abraham, Dr. Parag, Dr. Srijay Nair, Dr. Sarita Agrawal, Dr. Chandrasekhar Murthy, Dr. Anisha Gala, Dr. Rekha, Dr. Purnima, and Dr. Virendra Kumar. Without you, sir, this conference would not have been a successful. I thank you once again, all the speakers who joined us in this great conference. I must mention our deep sense of aspiration of all our chairpersons for the excellent coverage, namely Dr. Prema Dikuna, Dr. Vatsala Kamath, Dr. Prasanna Shetty, Dr. Vidya, and Dr. Swati Agrawal. Thank you, all of you once again. I also thank the panelists for our interactive and informative session, Dr. Ravikant, Dr. Virendra Kumar, and Dr. Lata Venkatraman, Dr. Prasanna Shetty, Dr. Pradeep Ganiga, Dr. Naveen N.S., and Dr. Sumati Sriram. Thank you, madam. Thank you, one and all. I thank all the judges who took painful effort in judging all the papers and posters. We had overwhelming responses from all over India, and it is very difficult to judge, but still we have come to a result which will be announced shortly. The judges and for these papers and poster presentation were Dr. Nagaratna, Dr. Aparna, Dr. Mohan Bhatt, Dr. Vidyashri, Dr. Rashmi Raju, Dr. Pallavi, Dr. Viresh, Dr. Venkatesh, Dr. Ramya, Dr. Namrata, Dr. Vivek, Niharika, Dr. Geeta Dopa, Dr. Ravikant, Dr. Anil Baipaditaya, Dr. Bhavya, Dr. Veena, and Dr. Abhay Sheth. Above and beyond, let us not forget the backbone of this CME program is our beloved HOD and organized chairperson, Dr. Geeta Dopa, organizing secretaries, Dr. Ravikant, Dr. Bhavya, and our staff departments of OBG, namely Dr. Anil, Dr. Veena, who made this dream into a reality. I thank all the delegates who have registered for the conference from all over India, delegates who have presented the papers and posters. I thank all the participants who have joined from all over the India who made this conference a grand success. I thank all enthusiastic budding obstetricians and gynecologists who shared their creative ideas as e-posters and e-papers, which is a totally new concept and which will be, the new era will be generated from today or this year onwards. I extend, and it's today up to the mark, we have received 65 papers and 140 posters, a big round of applause for all of them. Today, this online era, I think without our technical support, we would not have made this occasion a successful. So I extend my very sincere and heartfelt thanks to our technical team, namely Vikram, Praveen, our staff, office staff, who have been care of audio-visual system very nicely throughout this our CME program, which could proceed without any interruption, and it was excellent coverage and without any problems. I thank Registrar Dr. Sandesh, our office superintendent, Girish, who took care of catering, and auditorium in charge, Jairam and team, Kusuma, Nayana, who helped for our making our e-souvenir, our Sridevi Digital Studio, and not to forget all the organizing committee members of Scientific Reception, Souvenir, Treasurer, Logistics, and Registration Committee for their enormous cooperation and organization of this event, even in a small span of time, and a big success. Conducting the CME would have been impossible without zealous effort of our postgraduates who devoted a lot of their time and energy for the success to this conference. I sincerely apologize if I ever missed out anybody. Kindly apologize, and I thank you whoever has been not mentioned. Thank you, one and all.
Thank you so much, Dr. Umashankar Borkar. Our scientific committee will be announcing the winners of the scientific e-paper and posters shortly, as we have just finished with the competition, and the judges will announce the winners shortly. We will now announce the winners of the free scientific e-paper and poster presentations. I request our organizing chairperson, Dr. Geeta, to kindly announce the winners.
A very good evening, one and all. So just now we finished the last session. I just received the marks from the last judge. So I was waiting to compile the result. So all the papers and posters are done. All the postgraduates and even consultants who have presented the papers, all the papers and posters were excellent. All the judges told it was very, very difficult for them to give the results. But at the end, as we announced, we are going to announce first, second, and third prize for paper and first, second, and third prize for the poster. So we have to do the formalities, but all the papers and posters were excellent. Everyone has done a very wonderful job. So I would like to announce the prizes for the paper competition. So the first prize goes to Dr. Sanjana K from KIMS Hubli. Her paper was Mifepristone, a better agent for cervical ripening and induction than dinoprostone. The second prize for paper competition goes to Dr. Pooja R from MIMS Mandya. Robson criteria for analysis of C-section in Government Tertiary Teaching Hospital, a retrospective study. The third prize is shared between two, Dr. Akshata Rao from KVG Medical College, vaginal fluid pH for detection of bacterial vaginosis, and Dr. Niaf from KVG Medical College, vaginal hysterectomy using electrosurgical bipolar vessel sealing system versus conventional clamping and suturing method, a prospective study. Now let's move to the results of the posters. The posters were also very excellent. All the judges have praised the posters. So now we'll go for the poster prizes. The first prize for poster is from Dr. Spandana N, Raja Rajeshwari Medical College, Bangalore. An interesting case of seizures in early postpartum period, falcine meningioma. The second prize for the poster competition is shared between two, Dr. Snehil Sinha from SSIMS Bhilai, Chhattisgarh, Catch Me If You Can, Ruptured Primary Ovarian Ectopic Pregnancy, a rare case report, and along with Dr. Snehil, Dr. Kiran R. Konda from Assam Medical College is getting the second prize in poster competition, Yusuf Syndrome, Wrong Way, No Way. And for the third prize is also shared between two, Dr. Tulika Das from BVMC Sangli, a rare case presentation of non-Hodgkin's lymphoma of uterus, and Dr. Shilpa Nayak of KMC Mangalore, anesthetic management of parturient with rheumatic heart disease, mitral stenosis, MR, pulmonary hypertension, and SVT for lower segment cesarean section. So congratulations, prize winners, and best wishes for your future. So we all sign off from KVG Medical College and Hospital, and thank you